Good morning, everybody. Before we begin on the next agenda item, proposed resolution and decision on so-called conference paper have been uploaded on the regional committee web portal. These were prepared by the rapporteurs. We will now move to begin our consideration of agenda item 16, specifically 16.2, WHO Work in Countries document, WPR/RC73/12. May I call on the Director of Program Management to introduce this agenda item, please.
Thank you very much, Mr. Chair. Good morning, honorable delegates. I am pleased to present document WPR/RC73/12 on the coordination of the work of the World Health Assembly, the Executive Board, and the Regional Committee for the Western Pacific, which contains 5 sections. 16.1 on the proposed technical agenda items for the 74th session of the Regional Committee in 2023. 16.2 on WHO's work in country, 16.3 on WHO reform, 16.4 on items recommended by the World Health Assembly and the Executive Board, and 16.5 on other items, mainly the International Negotiating Body, INB. Today, we will consider item 16.2 on WHO's work in country, which describes how an approach taken in this region, which we call regional grounds up, enables WHO to respond in an efficient but tailored way to the common challenges that impact multiple countries in the region. Tomorrow, we will consider item 16.5 on the INB at the fixed time of 2 p.m. The remainder of item 16 will be handled on Friday, as I mentioned on day 1. There will be separate updates and time for member states intervention on 16.1, agenda for the 74th session of the Regional Committee in 2023, and 16.3 WHO reform. The WHO reform sub-item will provide an update on workplace culture and organizational change and the prevention of sexual exploitation, abuse, and harassment. It's now my pleasure to introduce item 16.2, WHO works in country. This important item serves as a key point of accountability and offers snapshots of the work we are doing with countries and areas in the region. We always start this item with a quick trip around the region to greet our country office colleagues. What you are going to see now is a recording that we did earlier because of bandwidth issue, but our country colleagues are joining us online today. Can we get the small? Yes, thank you.
Salam sejahtera. From Samoa. Mary from US.
Thank you very much, and colleagues from country offices, it's really nice to see you all and joining online today. Before we start our journey across the region, I'd like to take us back to last year's work in country session item. Last year, we took the item together with a discussion on sustainable financing, as you would recall. And this was because the type of work WHO in the region is increasingly being asked to do is shifting towards a new type of work, guiding and supporting efforts to reform or redesign health systems for the future. Work that requires a long-term view and sustainable financing. The region faces complex challenges, such as ever-present risk of health emergencies and emergence of new health security threats, climate change and rapid urbanization, changing lifestyles that have contributed to an increase in NCD and air pollution. These are compounded by the loss of access to traditional donor resources as countries transition to middle-income country status. In addition, many priority areas, including those on our agenda this week, struggle to attract adequate sustainable financing. This brings urgency to the need to greater efficiency and effectiveness for integrating programs and services to create sustainable health systems with UHC as the foundation. We are committed to providing support to our member states to do this. We are also committed to working as efficiently and as effectively as possible while we tailor our support to each country's context. The regional frameworks we've developed since For the Future endorsement, including the one we'll present this week, are an example of this. They are based on country needs and translate global resolutions while focusing on systems development and horizontal integration. Another approach or arrangement we are leveraging for efficient and effective support to countries is what we call the regional grounds-up approach. This is the basis for Chapter 2 of the story we started last year. We'll now make 4 stops across the region to hear examples of how we have used and will continue to use the regional grounds-up to support and have impact in countries. Let's take a quick look at a short animation that describes what we mean by the regional grounds-up approach or the regional grounds-up arrangement.
The regional grounds-up arrangement or approach can be described in the following steps. First, the regional office analyses the situation across countries and identifies a common problem. It determines if a solution or good practice in one country can be applied in others, and extracts the essence of this solution to develop a skeleton framework or guidance on the issue. Second, country offices support member states to customise the framework or guidance based on their understanding of the country's health system and contexts. Third, with WHO support, member states implement the customised framework or guidance, including at local levels. Together with member states, regional and country offices monitor how implementation is working. And fourth, the regional office then consolidates and uses this feedback to learn and improve on the framework and guidance.
Thank you. We will now consider 2 examples of our work supporting member states to respond to COVID-19, which utilize the regional grounds-up approach. This will be followed by 2 examples of how this approach is now being used in other areas to accelerate the For the Future implementation. Let's make our first stop. Please bring us to Mongolia. WHO colleagues from both our country office in Mongolia and the regional office are joined by Ms. Yangjima Binderiya, Director of International Cooperation in the Ministry of Health of Mongolia, to share how our work together to develop and implement COVID-19 care pathways, reduce COVID-19 deaths at home, as well as the overcrowding in Mongolia's intensive care units. In just a moment, we will turn to Ms. Yangjima to set the scene for us. But before that, I'd like to welcome Dr. Sergei Dyorditsa back to the Western Pacific region family for this item. Morning, Sergei. I know it's very early for you, like 2 or 3 a.m. Thank you very much for joining. Sergei, until a few months ago, was WR Mongolia. He's now WR to Belarus. But very kindly, he agreed to join us remotely for this item. Thank you, Sergei. It's really great to see you on the screen and joining us today. Now, and without further ado, it's my great pleasure to invite Ms. Yangjima to take the floor. Over to you.
Okay. Thank you very much, Dr. Capuano. At the beginning of the pandemic, COVID-19 pandemic, Mongolia took prompt and stringent response measures and was seen as an early success story. However, by early June 2021, the COVID-19 hospital bed and ICU bed occupancy exceeded the total capacity in my capital city, Ulaanbaatar. This impacted both healthcare delivery for COVID-19 and other essential health services. Now let's take a quick look at what was happening and how, with the WHO support, we were actually able to respond to the situation. Can we have the video, please? Thank you.
During public health emergencies, overwhelmed health systems are an early signal that the situation is deteriorating. Despite 16 months of suppressing COVID-19 in Mongolia with only 3 deaths, the virus hit the country hard in early 2021. In the beginning, 400 beds were allocated for COVID-19 patients, but were quickly increased to more than 21,000. These hospital beds were quickly overwhelmed. By June 2021, the country's health system crossed the red line when more than 90% of ICU beds were occupied. The situation looked grim. Patients were deteriorating at home and faced a long wait list for hospital admission. By mid-June, 33 people with severe COVID-19 had died at home. Primary healthcare centers became the main source for care, treatment, and referral of severe and critical COVID-19 cases, while providing essential healthcare services. The problem could not be solved by only increasing the health workforce and the number of ICU beds.
За энэ хүн цаг үед иргэдийн амь насыг аврах чиглэлээр Дэлхийн эрүүл мэндийн байгууллагатай бид нэгт сайн хамтарч ажилласан. За гэрээр хүндэрсэн өвчтнүүдийг яаралтай эмнэлэгт хүргүүлэх, за эмнэлэг дээр одоо ирмэлэлтийг маш сайн хийх, эрчим тэмцлэгэнд оруулах хүмүүсийг аль болох одоо яаралтай хэмжээнд оруулах, цаг алдахгүй байх, эрчим тэмцлэгийг эхлүүлэх, эрчим тэмцлэгээ шаардлагагүй хүмүүсийг одоо гэрээр эмчлэх, шаардлагагүй хэвтэлтийг бууруулах нь одоо бидний гол стратеги байсан.
To make this happen, a hospital bed management team and dashboard was established to monitor the utilization of both public and private hospital beds 24/7. At the peak of the surge, the team coordinated the admission of 300 severe and critical COVID-19 patients on the waitlist in a single day.
Healthcare was delivered for the first time in intermediate care facilities. Health insurance also covered care in these facilities and home-based care for the first time.
This financial mechanism helped to reduce unnecessary hospitalizations and allow patients access to health services regardless of their treatment setting. By developing a comprehensive care pathway, Mongolia was able to swiftly treat the right patients in the right settings, saving thousands of lives.
Do you hear me? Indeed, as you've heard, by early June, COVID-19 hospital bed and intensive care unit capacity was quickly filling up. The Ministry of Health took strong leadership to address this. Together, we conducted a rapid situation analysis and found that more than 60% of hospitalized patients had mild symptoms, and the waiting time for hospitalization was between 7 to 9 days. At the time, urgent actions were needed to review and adjust the care pathway, as Mongolia shifted its approach from zero COVID to non-zero COVID. Working together with the regional office as one team, we worked quickly to develop clear guidance on care pathways, confident that our hypothesis that home-based care and clear care pathway would save lives and reduce the burden on hospitals. And I'd like to pass now to Dr. Babatunde to tell us about the situation elsewhere in the region at the time.
Thank you, Sergey. Across the region, we were seeing similar challenges. Cambodia and the Philippines were experiencing.
Your mic is on. I don't know.
Across the region, we were seeing similar challenges. Cambodia and the Philippines were experiencing equal pressure on their health systems, for example. Many countries had questions about when to admit COVID-19 patients to hospital and when and how to support home-based care amidst increasing pressure on hospitals. Our monitoring of the COVID-19 situation in countries and daily discussions with the country offices helped us to see quickly that member states were facing a common challenge, requiring a common solution tailored to each country's unique context. It was our work together as one team with country offices that enabled swift analysis and problem definition. Back to you, Sergey.
Customizing and tailoring this guidance to Mongolia's unique context saw us focus on ensuring that the right patients were in the right facilities at the right time. This meant establishing an incident management center for efficient ICU and bed management and increasing care accessibility through the appropriate healthcare pathway that included intermediate healthcare facilities, private sector, and integrated home-based care. And I'd like to invite Ms. Yanjima to tell us more about this.
Thank you, Dr. Sergey. Amid the pandemic, we were able to strengthen our capacity to manage the surges. We were able to strengthen our capacity to manage surges overwhelming health systems by closely working with the WHO. This has been a long-standing issue during annual seasonal influenza outbreaks, as well as during the 2009 H1N1 pandemic. Introducing home-based care and utilization of intermediary care facilities played an important role in optimizing the care pathway and preventing hospitals from being overwhelmed. A key lesson we identified was that by keeping hospital capacity low, we can prevent severe cases and deaths. In the period following the actions to optimize care pathway, we had positive results. Admission to hospitals was centrally managed by Incident Command Center according to disease severity. There were no more severe patients at home waiting for hospital admissions. ICU beds and hospital beds were prioritized for critical and severe patients. Deaths decreased from a peak of 104 during the week of 28th June to 41 during the week of 19th July and further decreased thereafter. Through live monitoring of bed occupancy, the COVID-19 care pathway continued to be proactively adjusted after this initial phase. Seeing this impact, this approach was having on the ground, we encouraged WHO to share our learning with the other countries in the region. Back to you. Thank you.
Indeed, Mongolia was eager to ensure the lessons they were learning were helping to save lives elsewhere in the region. These lessons reiterated the importance of treating the right patients in the right settings and at the right time, and the need for a systems approach to enable this. Regional Office facilitated a grounds-up approach, building on the lessons from Mongolia and later from other member states. In other words, a feedback loop was established to facilitate adjustments of the system and care pathway and safeguard against surges overwhelming health systems. This operational intelligence was obtained from country offices and directly from member states without country offices. And we adjusted our guidance as we received feedback from member states and saw how it was working on the ground. The regional COVID-19 incident management support team shared our analysis with our country office counterparts, preparing briefing notes and updating guidance documents. Country offices then tailored those analyses and measures to meet the needs of each country's context, with our inputs and support as needed. Lessons were also shared through a series of webinars with diverse stakeholders, including development partners, clinicians, hospitals, hospital managers, and Ministry of Health. Ministry of Health has recently published an academic paper for an even wider audience. The regional grounds-up approach and Mongolia's openness and willingness to share enabled efforts to save lives elsewhere in the region too. Thank you, Ms. Yangyama. Thank you, Sergey, and over to you, Corinne.
Thank you so much, Ms. Yangyama, Sergey, and Babatunde. This was a powerful story of how WHO's work support to develop COVID-19 care pathways helped Mongolia to save lives and protect its health systems, and how, in line with the region's culture of learning and improving, feedback and lessons from Mongolia enabled ongoing, real-time improvement to WHO guidance and support to other countries and areas in the region. Thank you again. Our next stop is Cambodia. This time we'll hear from the regional and country offices, as well as the Ministry of Health, on WHO's support to their efforts to introduce and generate uptake of COVID-19 public health and social measures. It's my pleasure to welcome His Excellency, Director General for Health of Cambodia, Dr. Hong King Cheng, Dr. Ashina Kalakdina, our Health Emergencies Team Lead from the country office in Cambodia, and Babatunde again for this mini panel session. Babatunde, the floor is yours.
Thanks, Corinne. During the early phase of the COVID-19 pandemic, pharmaceutical interventions to prevent the disease or its complications, such as vaccines and therapeutics, were still in trials and under development. And even when they became available, quantities were limited and access inequitable, meaning that vaccines and therapeutics alone were insufficient in reducing transmission and preventing deaths. In the context of great uncertainty regarding the transmission, severity, and impact of the novel pathogen, WHO has, since the start of the pandemic, recommended the implementation of non-pharmaceutical interventions, or NPIs, such as physical distancing, as a crucial means to suppress transmission, help maintain health system capacity, and protect the vulnerable. In May 2020, the regional office issued interim guidance on calibrating long-term NPIs to support member states. NPIs have now come to be known as Public Health and Social Measures, or PHSMs, and we have learned throughout the pandemic how to tailor WHO's support in designing, implementing, monitoring, and calibrating appropriate PHSMs to balance public health objectives as well as social and economic disruption and costs. I would now like to turn to my colleague Ashina, who can speak to our work in Cambodia, supporting the Ministry of Health to adapt this interim guidance to the country context to ensure effective implementation of PHSMs. Over to you, Ashina.
Thank you, Babatunde. Cambodia avoided widespread community transmission of COVID-19 in 2020, but faced a large outbreak starting in February 2021, with a continuing surge during the remainder of last year. Working together as one team with regional office colleagues, WHO Cambodia country office staff worked with the Ministry of Health and partners to adapt regional guidance to the Cambodian situation at national and provincial levels. The government recognized how critical PHSMs were to minimizing the spread of COVID-19, and WHO has been able to advise and support the government to continuously refine PHSM advice through regular monitoring of implementation on the ground. We supported the ministry to prioritize two key areas for PHSM. The first was understanding where infections were occurring to calibrate existing measures. We identified settings where infections occurred, especially high-risk settings where amplification events could occur. In Cambodia, these included entertainment venues, garment factories, and traditional markets. Correlating implemented measures with their compliance and effectiveness allowed generation of hypotheses as to where infections were likely occurring in real time. And this informed decisions on where PHSMs needed to be strengthened, maintained, or relaxed. The second area was engaging non-health sectors, because successful PHSM implementation can only be achieved through cross-sectoral collaboration. Ministry of Health, supported by WHO, advocated for PHSM with decision makers and developed sector-specific technical materials. For example, guidance and digital engagement interventions were developed for garment factories, a vital economic driver, so that they could remain open with appropriate risk mitigation measures in place. Over 90% of this workforce is comprised of young women from poorer rural provinces who have migrated because of economic necessity. Country experiences from Cambodia were regularly discussed with WHO regional and other country office colleagues, so lessons identified could be shared and adjustments implemented rapidly, not only in Cambodia, but elsewhere in the region. It is now my great pleasure to hand the floor to the Director General for Health, His Excellency, Dr. Hock Kim Cheng, to tell us more about this work on PHSM and its impact in Cambodia.
Dr. Asina, it is my pleasure to be with you today in person at the regional committee meeting. As Dr. Asina mentioned it, in 2020, under the leadership of Samdech Prime Minister, Cambodia took strong decisive action and implement population-based measures, including entry restriction and mask wearing. The successful delayed community transmission of COVID-19 in the country. In 2021, Cambodia experienced widespread community transmission. We work closely with WHO to tailor public health and social measures for Cambodia and successfully introduce three do, and 3 don't. We use community message of compassion and empathy to protect one family and community from COVID-19. We also tailor message to the younger generation of modeling behavior that are easy, fun, and doable. This message improve acceptance and practice of 3 do and 3 don't. Let's take a look, an example on how we communicate this public health and social measure. Please play our video.
តើអ្នកការពារគ្រួសារនិងមិត្តភ័ក្តិតាមរបៀបណាដែរចូលរួមធ្វើជាអ្នកការពារដោយគ្រាន់តែពាក់ម៉ាស់លាងដៃឲ្យបានស្អាតនៅផ្ទះបើមិនចាំបាច់ចេញទៅក្រៅនិងរក្សាគម្លាតពីគ្នានេះបង្ហាញថាអ្នកគោរពខ្លួនឯងនិងអ្នកដទៃរក្សាអនាម័យគាំទ្រគ្នាពីចម្ងាយរួមគ្នាការពារគ្រួសារនិងមិត្តភ័ក្តិពី COVID-19 ជំនាន់យើងគឺអញ្ចឹង
Cambodia gradually shifted greater responsibility to individual sector to ensure measures were implemented. With the support of WHO, we use multi-social listening to help adjust our message and intervention so that they continue to remain relevant. This approach of tailored measure and communication was invaluable as it has fostered trust in the government advice and sustained public health and social measure practice in the country. Importantly, it has prevented repetitive lockdown, which are disruptive, less acceptable to the society and damaging to economy. The leadership of the Ministry of Health has also been recognized by other ministries, including religion, education, tourism, which were achieved through intersectoral collaboration and strong technical support from WHO. As we move to sustain management of COVID-19 in 2022, WHO have helped us emphasize how important it is for the public assess individual risk for themselves and use their best judgment. This means, for example, the mask wearing is no longer mandatory, but still practiced as individuals assess their own risk. This approach has been more acceptable to the general public, which has enhanced compliance. Again, thank you, and back to you, Dr. Asina.
Thank you so much, Excellency DG, for sharing these reflections on the impact of our work together on the design and implementation of PHSMs in Cambodia. I would now like to hand back to Babatunde, who will talk about how feedback from Cambodia's experience helped WHO in the region to learn, improve, and refine its guidance on PHSM to better support other countries in their efforts.
Thank you, Ashina. Throughout the COVID-19 response, country offices and the regional office have developed a mechanism to monitor the situation in countries across the region. This mechanism relies on information sharing between the WHO regional office and WHO country offices, and between member states and WHO country offices. At the regional office, common challenges can be identified, analyzed, and potential solutions developed. WHO country offices can then in turn support member states to contextualize these solutions and provide guidance on implementation. The COVID-19 Incident Management Support Team at the WHO Regional Office has been key in collecting and validating information, conducting risk assessments, and sharing information with WHO headquarters, within the regional office, and with country offices. Regular meetings of the Incident Management Support Team and individual country consultations have allowed country experiences, including challenges and potential solutions, to be identified and for WHO to provide guidance and technical support to member states in their response. Lessons from Cambodia's implementing their 3 do's and 3 don'ts helped us to revise and update our interim guidance on public health and social measures to better respond to the evolving situation in the region. The interim guidance, now in its 3rd iteration, reflecting the shift from the zero risk approach, which is a strategy that aims for maximum suppression of infections, to the non-zero risk approach of sustained management of COVID-19, where individuals and business owners take more responsibility for managing risk of COVID-19 transmission. As countries continue to move towards sustained management of COVID-19, PHSMs continue to be calibrated using information from multiple sources. Staged and tailored measures at subnational and local level are being implemented with step-by-step calibration to protect health system capacity and the vulnerable, and to support economic recovery. To maintain adherence to PHSMs, strategic communication messages emphasizing shared responsibilities among individuals and setting owners to reduce risks are essential. Thanks, Corinne. Back to you.
Thank you so much, Dr. Ho Kim Cheng, Ashina, and Babatunde for sharing this story of how our support to the design and promotion of public health and social measures in Cambodia resulted in good uptake of these measures, and explaining how this lesson shaped our support to other member states on the same issue. Honorable delegates, we've heard 2 examples of how our work with countries in responding to COVID-19 showed the value of the regional grounds up. Through the stories about WHO's support on COVID-19 care pathways in Mongolia, and to frame and implement public health and social measures in Cambodia, we saw how working as one team and using our regional grounds up approach makes a real difference in countries. Committed to finding and using new, efficient, and effective ways of supporting countries, we are now starting to leverage this arrangement in other areas to further accelerate the for the future implementation. Let's travel back to Philippines. Today, we are lucky to have with us Undersecretary Kenneth Ronquillo of the Philippine Department of Health and the chairperson of the National Commission of Senior Citizens, Attorney Franklin Quejaño. They are joined by our Director of the Division of Healthy Environment and Population, Dr. Hiro Okayasu, and our acting WHO representative to the Philippines, Dr. Graham Harrison. Graham is unable to join us in person today, so he has provided a recorded message. It's my pleasure now to give the floor to Hiro to introduce this next story on aging in the Philippines. Hiro, the floor is yours.
Thank you very much, DPM. Our region is experiencing the profound and rapid population aging. Aging can pose many challenges to society and individuals. As people grow old in our region, our population experiences higher rates of non-communicable diseases and chronic conditions. Member states need to accommodate these emerging health and social needs by, for example, creating age-friendly environments and integrating medical, welfare, and other social services tailored to individuals. Many member states have, over the past few years, sought our support to prepare for an active aging society in which older people can stay healthy and continue participating in social life. As a result, the World Health Organization Regional Office developed a regional action plan on healthy aging together with the member states, experts, and partners. It serves as a skeleton plan that can guide approaches to healthy aging tailored to each country's context. The Philippines is a young country, but fast-growing and older population. So we encourage the Philippines to make early investments in healthy aging, knowing the social and economic benefits these can yield for individuals and their families, as well as society as a whole. The Philippines is making a great stride in this area, recognizing, just as the plan does, that the health and well-being of older people is significantly determined by social and physical factors that accumulate across the person's lifetime. The need for multi-sectoral approach to developing age-friendly communities that foster functional ability and value the contribution of older people in the Philippines. On this note, I'd like to invite the chair of the National Commission of Senior Citizens in the Philippines, Attorney Franklin Quejaño, to take the floor.
Thank you so much, Dr. Hiro. Indeed, based on the latest Philippine Health Insurance Corporation database, of the 110 million Filipinos, our country, the Philippines, has 10.2 million registered older persons, a figure that accounts for 9.27% of the total population. This conservative number is projected to double in 10 years. This growth in the number and proportion of senior citizens in our population will mean increase in the demand for health and social services, as well as an increase in the need for support of older persons and their caregiving families. We need to anticipate for these changes in demographics to prepare our people to continue in making extraordinary contributions as they age. We also need to prepare our country in a manner that our people can avoid unmanaged pain as well as unmet social needs, such as companionship and support. Everyone, regardless of age, should have equal opportunity to contribute to nation building. Anticipating what lies ahead, we have adopted a future-oriented way of thinking by working to promote healthy aging across the lifespan. Specifically, we have worked on creating healthier and safer environments for people of all ages and maximizing the contribution and capacities of senior citizens. The National Commission of Senior Citizens was established under the Office of the President in 2019 to ensure the full implementation of laws, policies, and government programs to protect older people's welfare. It recognizes the engagement and action to create age-friendly environments needed across sectors. We are seeking an integrative whole-of-government approach to be able to establish a reliable information system for the senior citizens of the country. The Commission, working closely with the Department of Health with the support of WHO, has developed an initial draft of the 2023 to 2028 Philippine Plan of Action for the Senior Citizens through a consultative and participatory process. It outlines key strategies and activities to promote healthy aging and identify how each government agency can contribute to its attainment. With the inspiration and support from WHO as well as DOH, we are now developing a national framework for age-friendly environments, implementing age-friendly programs in 5 local governments: Parañaque City, Borongan, Samar, Santa Catalina, Ilocos Sur, and so many others really want to participate. Importantly, this framework recognizes that the health sector has a key role to play in optimizing older persons' mental and physical health and well-being so that they can flourish in society and contribute to nation building. The National Commission of Senior Citizens advocates for laws and policies that will provide job opportunities and better retirement for older people. Along this, we take their overall health and well-being seriously. We are currently working with the Philippine Health Insurance Corporation to provide free annual medical examination for older persons. Together, let's create spaces where older persons can prosper healthily. Thank you, Dr. Hiro. Back to you.
Thank you so much, Attorney Quijano, for providing insight into the important role of National Commission of Senior Citizens and the plans of the Commission to work across sectors so that older Filipino age in good physical and mental health and can contribute to as an active member of the society. Related to that, now I'd like to turn to the officer in charge of the Department of Health, Dr. Rosario Berrijere, who's now back to the venue, to share some reflections on the department's work to support the mental and physical health of older people, and then how WHO has contributed to this. And welcome, and over to you, Dr. Berrijere.
The Philippine Department of Health, like the National Commission for Senior Citizens, government and non-government agencies, has been leveraging a whole-of-government approach in developing our action plans for healthy aging. In January of 2021, the Philippine Department of Health developed a Healthy and Productive Aging program, which focuses on promoting the health and wellness of older people and alleviating the conditions, including degenerative diseases older people are living with. This program aims to promote quality of life among older persons and contribute to nation building through the provision of equitable access to quality health care. We need to ensure that older persons are healthy for them to be able to contribute to nation building and participate in society. The WHO worked closely with the Department of Health on advancing and taking early actions on healthy aging through life course and multi-sectoral participatory approaches. The Philippine Department of Health requested WHO support to develop a framework for promoting healthy and quality life among older persons. This framework is the basis for policy advocacy plans and programs that need to be strengthened or developed
to support promotion and protection of older persons' welfare. The WHO Regional Action Plan on Healthy Aging was used as a guide to design the Healthy and Productive Aging National Action Plan and Framework for the period 2020 to 2025. To help local government units in implementing age-inclusive programs and services, including community-based preventive gerontology adapted to Filipino culture. The Philippine Department of Health developed the Manual of Procedures, Operations, and Guide. This was followed by a training to ensure our primary healthcare providers have the knowledge and skills needed for taking care of our older people. This is a priority we continue to drive forward with the support of WHO. The Philippine Department of Health also developed an omnibus health guidelines for older people with the authority of implementing rules and regulations, integrating key policy provisions that govern various health programs, focusing on integrating the various models of care. The Philippine Department of Health, together with the WHO and partners, are committed to ensuring accessible healthcare services to older persons wherever they are in our country. Thank you, Dr. Hiro, and back to you.
Dr. Berhere, thank you very much for these reflections. The Philippines was one of the first countries to take early action for the health and well-being of older people based on our regional plan and then guidance. Let's now hear from Dr. Graham Harrison, acting WHO representative to the Philippines, who will talk about how, by working as a one team, we have been able to provide tailored and customized support to the Philippines' work in this area. Please play the video recording of Dr. Graham.
Thank you, Hiro. As you have heard, both the National Commission of Senior Citizens and the Department of Health are contributing significantly to the efforts of the Philippine government to improve the lives of older people, their families, and communities. WHO has been pleased to support the considerable progress of the Commission and the Department in policy development, advocacy, and capacity building since 2019. Working together as one team with our regional office colleagues, we have supported efforts to enhance commitment to creating age-friendly environments through the first ever multi-stakeholder roundtable discussions involving government agencies and senior citizens organizations. We have supported innovative open space planning workshops to identify current and future needs of older people. And we have worked with the National Commission and the Department to support local governments to strengthen partnerships with civil society organizations, communities, and champions for cross-sectoral collaboration on creating an inclusive environment for older people through establishing age-friendly environments. We've helped to develop outreach campaigns to raise awareness among the public and other parts of government of the importance of the environmental determinants that underpin healthy or unhealthy aging. We've also organized capacity building around the design and implementation of age-friendly environments and sought to share lessons and good practices from countries like Ireland and Malaysia. Now we are starting to share the Philippines' experience with other countries in the region, and we look forward to providing ongoing support and guidance in this area. Thank you. Back to you, Hiro.
Thanks to Dr. Graham for that message. As you say, the feedback from Philippines' efforts to implement the customized plan we've worked together is starting to shape the support and advice that we at the regional office, working as one team with country offices, are giving to other countries. For example, we have adjusted our guidance to our other countries on creating age-friendly communities based on the Philippines' experience. Specifically, we are encouraging other countries to initiate, develop, and sustain a multi-sectoral approach by connecting with stakeholders and in other sectors at sub-national levels, as the Philippines has done. The Philippines' healthy aging policies emphasizing the life force approach to optimize living environments for people of all ages and recognizing that older people are also partners in healthy aging initiative are also good practice. The regional office and our country office are committed to supporting countries to prepare for population aging. We will continue to facilitate research to identify and document best practices in the field of healthy aging and promote knowledge sharing in collaboration with governments, academia, civil society, and other stakeholders. As seen in this case, the experiences of implementing WHO's guidance serves as a useful real-time feedback for our guidance as we are all addressing unprecedented challenges such as population aging. We all learn together by doing together. Thank you very much. Now over to DPM.
Thank you very much, Chairperson Kehanyo, Dr. Vahere, Hiro, and Graham. This is such an important topic. NCDs and aging, two closely connected issues, comprise one of our 4 regional thematic priorities. This story is a great example of how we are trying to leverage the regional grounds up to accelerate implementation of other for the future thematic priorities. Our 4th and final stop is Papua New Guinea. We will now hear about the work we've done together to develop a capacity building approach for the health information workforce. I'd like to invite the Honorable Minister of Health of Papua New Guinea, Dr. Tom Lino, the WHO representative to the Papua New Guinea, Dr. Sevil Usainova, and the Director of the Data Strategy and Innovation Team, Dr. Kidong Park, to tell us more about this. Sevil, you have the floor.
Thank you, Corinne. I'm thrilled to be here today with Honorable Minister Lino to share how we have been working together to tackle some of the health information challenges faced in Papua New Guinea. I would now like to invite Minister Lino to share with us about some of these challenges. Minister Lino, the floor is yours.
Nova. Despite significant progress, Papua New Guinea continues to face challenges in ensuring quality data are available and used for decision-making to protect and promote people's health. To give you a historical perspective, our National Health Information System started off in the 1980s as a paper-based system, collecting data from health facilities across the country. This involved considerable effort considering how geographically diverse the country is, with remote highlands, areas, and highlands. Health information officers were placed in provinces and in hospitals to collect the reports and enter data if computers were available. Where computers were not available, reports were sent by post to the national level for data entry and analysis. Many of these officers came from non-health and non-data backgrounds and acquired skills on the job or through vocational training. This remains the case today. I'm happy to share that our National Health Information System is now electronic, with health facilities using tablets for direct data entry. As we have moved to an electronic health information system, real-time analysis and interpretation are possible, and so our data needs and the skills required of health information officers have evolved. I'm proud of our dedicated and passionate health information workforce. However, but many staff have not received the capacity building they need to meaningfully analyze and use this data to improve health programs and services and ultimately people's health. In recognition of this, we approached WHO for advice on developing a clear pathway to build the capacity of our health information workforce to successfully implement our National Health Plan 2021 to 2030 and its Hamani strategic plan. We need a strong health information workforce, just like we need to strengthen human resources for health more broadly, which is one of my priorities as minister. Thank you, Dr. Usainova. Back to you.
Thank you, Minister Lino, for setting this scene. This is an aspect of health information system strengthening that has not previously attracted much attention, even though Papua New Guinea is not alone in facing these challenges. Other countries in the region share them too. To give us the regional perspective, I would now like to invite Dr. Kidong Park, Director of Data, Strategy and Innovation at the Regional Office, to take the floor. Kidong, please.
Thank you, Seville. Indeed, by working with you and your team, as well as other country officers, we have identified similar challenges and the potential for a common approach or solution to be used in addressing them. We therefore developed a data management competency framework to provide the tools to support integrated and sustainable capacity building for the health information workforce across different units and levels of health institutions. We would like to show you a short video that provides an overview of that framework. Please play the video.
The strategic use of data for decision-making is critical for realizing national and international health goals. Despite significant investments to improve health information systems within countries, health information workforce capacity is one area that hasn't received enough attention. Capacity building has not been well aligned with broader health system needs and priorities. Like elsewhere, this has been a challenge in Papua New Guinea. The regional office therefore designed the Data Management Competency Framework to measure gaps and guide the development of competencies along the whole data life cycle, from data generation to processing, analysis and usage. These 4 areas are further subdivided into 17 domains. They each come with a set of knowledge, skills and attitudes for different proficiency levels. The framework sets out 7 steps to customize the required skill and knowledge levels for different types of health information workers at different levels of the health system. This customizable tool aims to empower member states to drive strategic, integrated and sustainable health information workforce development according to their specific contexts, towards better data and ultimately better health outcomes.
As Minister Lino explained, the government of the Papua New Guinea has been proactively seeking ways to promote the capacity building for health information workforce across all levels of the system. The aim of this is to better measure performance of the health information workforce, whilst using data for better decision making to protect and promote good health. This is also a target of the MNE strategy plan for the National Health Plan 2021 to 2030 of Papua New Guinea. We developed this framework to respond to needs of and the request from the National Department of Health of Papua New Guinea. But the framework itself focuses on the essence or key element of the data competency development, which we hope will be used for other countries in the region, whilst similar changes. This is because it can be tailored to their own need and context. As you saw in the video, there is a series of the steps that enables the framework to be tailored to countries' different contexts. I will now hand back to Seville to share some reflections of how we worked with the Papua New Guinea Department of Health colleagues to tailor or customize the framework to the country's needs and context.
Thank you. Thank you, Kidong. When the Department of Health sought our support to develop a capacity building approach, we agreed at the outset that it would need to be designed to address the real needs on the ground. The data strategy innovation team in the regional office had the expertise that we needed for this, and we had knowledge of the situation on the ground. Working closely together, we began to design the data management competency framework, including concrete steps and actions needed to tailor the framework to Papua New Guinea's context for effective implementation. This is a long-term work for the future of PNG. We wanted an approach that would address immediate needs while contributing to building and sustaining capacities over the long term. In our work with the National Department of Health, we have therefore focused on data competency issues within the broader context of health system integration, avoiding ad hoc trainings that are largely driven by short-term or programmatic specific needs. We have tried to do things differently. We have used backcasting to help us ensure this work is developing the competencies needed by health information officers in the future, not just today. And we have involved, using a participatory approach, the full range of stakeholders working in PNG. This includes the health information staff who have been working in their roles for so long, provincial health authorities, in addition to National Department of Health, and development partners. This has enabled us to understand how the data demands and skills needed have evolved and identify lessons so we can build on strengths while addressing urgent current and future gaps. To hear more on how we are implementing this tailored approach to developing competencies in this area, let us hear from Ms. Manat Dindi, the Manager of the Performance Monitoring and Research Branch at the National Department of Health of Papua New Guinea. Please play the video.
Greetings to ministers and senior representatives from the member states of the Western Pacific region, senior management of WHO, colleagues and friends. I'm happy to share the journey taken so far in 2022 to develop capacity building pathway for our health information workforce with the support of WHO. We have followed a 5-step process involving mapping of the information roles, analysis of job descriptions, interview with the staff themselves, and consultation with relevant stakeholders to define competency for 3 different health information roles at the national, provincial, and the hospital, using the tailored data management competency framework. I remember the first time my team shared the initial findings, I was excited to see competency types and levels in the 3 role types. This is something we never had before, and it felt groundbreaking. Our findings were subsequently discussed in a 2-day consultation workshop in August, involving colleagues from the National Department of Health, including the HR colleagues, as well as senior management from selected provincial health authorities, health information staff, and the development partners. Together, we reviewed the competency required in the roles, and then we discussed the changes needed to ensure staff were equipped with appropriate skills and knowledge to meet the future national and provincial needs, guided by the vision and objectives of the M&E strategic plan from the national plan. I was assured by the strong engagement and enthusiasm of all participants. We were thanked for leading the discussions, which were essential but had never held before. Involvement of provincial level senior management representative during the consultation was critical to understand how this work is connected to broader organizational objectives, as well as for securing their commitment. At the end of the consultation, we came up with competency profiles for each of the 3 role types. These profiles will be presented for a final agreement in a workshop in October with the involvement of the health information officers from all provinces and the senior management from the provincial health authorities and the National Department of Health. After this, we will move forward to develop the capacity building plans based on the competency gaps. We want all our stakeholders working in health information to implement capacity building activities in line with our plan. An unexpected outcome from this work was the broader critical conversation on the human resource issues that surfaced from the data. For example, we found variation in the positioning of health information roles in the provincial health authority structures and the grade levels, as well as job descriptions that were non-standardized and some were over 10 years old. And these factors impact on staff motivation and performance, as well as how data is governed, coordinated, and used. We heard resoundingly that provincial health authorities wanted guidance on these matters, and we plan to take forward this discussion with our HR colleagues. Lastly, we plan to define competency profiles for our staff with data-related responsibilities at the district and health facilities in the coming months. To conclude, as you can see, there is a lot of work for my team, but I am also excited and to have embarked on a journey which will help to strengthen the health information workforce as we implement the new administrative plan. Thank you.
Thank you, Ms. Mana. I hope that gave you a bit more of an insight into the work we are doing and the impact we hope it will have, including through the restructuring of health information roles. I would now like to hand back to Kidong for some final remarks.
Thank you. We are glad that our data management competence framework is having a systematic impact on the ground. Your experience is also helping us in our efforts to support other countries in this area. First, it has helped us to identify and confirm the need for a detailed expression of the knowledge and skills requirements at the different proficiency levels across the framework. Second, it has helped us clarify how the essence of the framework can be customized for different country contexts, and then some key element of the success, like the importance of a commitment from the health ministers, and then positioning of this work within a broader and a longer term plan for strategic health information workforce development. Finally, in line with our culture of the learning and improving, as we continue supporting Papua New Guinea and start scaling up our support to other member states facing similar challenges, we will build on what has worked well and address aspects that have worked less well towards our goal of the effective and efficient support to countries. Thank you so much. Back to you, Corinne.
Thank you very much, Honorable Minister Lino, Seville, Kidong, and sincere thanks to all our panelists this morning. Before we conclude this session, I wanted to highlight a few of the elements of our culture in the region that underpin or form the foundation for the success of the regional grounds up, a culture that has been nurtured and strengthened in the past few years. First is our culture of putting and keeping countries at the center, and the health of their people, of course, at the center of our work. Examples of how we do this are wide-ranging, but include careful consideration of the political, economic, social, and cultural factors at play in communities, in addition to understanding national, political, cultural, and socio-economic and social dynamics. Another example of this is bringing country and sub-regional priorities like rheumatic heart disease and safe and affordable surgery to the global level. Second is our culture of working as one team, as you have heard, not the regional office simply responding to country office requests for support, but country office and regional office teams really working together for planning and implementation to refining our guidance and support based on lessons from the ground. And third is our commitment to learning from the work of our member states, from our efforts to support member states, and from the work of our partners, and to improving. This relies on strong networks and information sharing between WHO offices, member states, and partners to build on successes, adjusting and improving in real time. These elements of our culture are critical to our ability to really understand needs on the grounds and identify lessons or experience from one country that can be useful to other countries and areas in the region. The starting point for the COVID-19 example is years of preparation guided by APSED and experience and understanding of other viral illnesses. But the elements I've just described means that we were able to quickly adjust our guidance and support based on experience, lessons identified, and the evidence evolving associated with the virus in real time. Working as one team with country offices means the regional office could identify and analyze common challenges experienced by countries and areas and develop effective approaches and mechanisms that could be tailored by country offices to the specific national and subnational contexts. Our efforts supporting member states to respond to COVID-19 by using this regional grounds-up arrangement and the impact we saw this work having on the ground showed us its value. We saw the potential to use this approach in other areas of our work for impact on the ground. So the example of our work supporting healthy aging in the Philippines and health information workforce competency development in Papua New Guinea aren't finished examples of the regional grounds up, but rather examples of how we are starting to leverage this arrangement as we continue to implement for the future thematic priorities and operational shifts. We are doing this in other areas too, like safe and affordable surgery, which is a priority for many Pacific Island countries. We hope this session was useful in showing how the regional grounds enabled by our one team approach is helping us to provide effective and efficient support to countries towards our shared goal of being the healthiest and safest region. Sincere thanks again to each of our panelists who've joined us online from different parts of the world and in person here today. Thank you very much, Mr. Chair. I give you the floor back. Thank you.
Thank you, Dr. Capuano. Because we are running behind schedule, we open for only a couple questions or interventions from representatives who wish to speak on this item. Please indicate your wish to speak by clicking the button on your microphone if you are in the plenary, or by using the raise hands function on Zoom. I call on the representative of Australia. The floor is yours.
Thank you, Chair. Australia thanks all WHO staff for their continued dedication and resilience across the past few challenging years. WHO staff are the key to its ability to deliver its mandate. We acknowledge the critical role of WHO's country officers have played in our region during the pandemic, deploying COVID-19 vaccines and treatments, combating vaccine hesitancy, and sustaining basic health services. We particularly appreciate the work of the WHO Division of Pacific Technical Support in SUVA in convening partners through the Joint Incident Management Team on COVID-19 response coordination. Strong and responsive WHO country officers that are well staffed with adequate resources are critical to achieving sustainable health outcomes and delivering impact at the country level. We acknowledge WHO's efforts to use a ground-up approach to enable the regional and country officers to work together as one team to deliver tailored support to address health issues in the region. We remain concerned by the ongoing challenge of mobilising and attracting high-quality staff to country offices in our region, particularly in the Pacific. We note that there have been long absences in WHO representatives in some country offices in our region. Support from the sub-regional or regional officers, although welcome, is not a substitute for strong and stable leadership at the country level, which is crucial for building trust and credibility in country. We welcome further information on how WHO is working to attract and retain quality ongoing staff in country offices, streamline recruitment processes to reduce staffing gaps, and increase mobility across the levels of the organisation to support regional and country level impact. We're keen to work with the region to help develop a pipeline of qualified staff to fill key positions at the country level. Thank you.
Thank you, Australia. Are there any more interventions? If not, then we can conclude this item before we have a coffee break. Okay. The Secretary, would you like to have some response?
Thank you very much, Mr. Chair, and thank you, Australia, for your work on the ground, on the regional grounds-up approach, and for your concern on the mobilizing resources, HR resources for country offices, in particular in the Pacific. As mentioned by the DDG earlier this week, there has been a number of things both at global level and also regional level. So at global level, as mentioned, we have the mobility program, but also the 3-level HR planning. We have a number of activities also to attract talents from underrepresented and unrepresented countries to WHO, the program that we call the Go WHO. We have been really sending and trying to attract many people. We are also streamlining our processes, accelerating as much as we can the recruitment process from even 90 to 60 days. It's still challenging, but we know that we can do it in some areas. And we are working really towards accelerating the recruitment process in a number of country offices. It has been challenging indeed, and we have been really working towards accelerating the recruitment process. It's not ideal yet, but we are fully aware of this issue, and we have been working really hard to get as many recruitment as possible. So yeah, thank you very much for your concern. We will continue to work towards filling up the gaps in the position, including working with the global level and the initiatives that have been mentioned earlier, including the 3-level workforce planning. Thank you.
Thank you very much. We have come to the end of item 16.2. Before we have a coffee break, we had some announcement. It has been my honor to serve as your chairperson during this 73rd session of the Regional Committee. Unfortunately, I need to return to my country to attend to urgent matters. While Chairperson Honorable Sir Pukala, Minister of Health of Tonga, has kindly agreed to preside over the remainder of this session. So I would like to sincerely thank Minister Pukala for taking on this role in my absence. So I wish you all very fruitful deliberations over the coming 3 days. I thank you very much for your cooperation. So before we break for coffee, Before we break for coffee, I would like to invite the Director of the Administration and Finance to make a short announcement. And please be back for the next items in 20 minutes. We will resume at 10:45.
Thank you very much, Mr. Chair. Just some reminders today. Immediately after the plenary in the afternoon, the informal consultation with member states, the caucus, we call it, will be held in this hall. As you know, this caucus is attended by chief representatives and up to one of the alternatives of member states with seats of government in the region, and addresses issues such as office bearers for the World Health Assembly and nomination of executive board members. We would ask that all others vacate the hall immediately following adjournment this afternoon. And for those joining online, a separate link has been shared for you. Sorry. Also, at the same time, Rapid Tours meeting will be held at the Amethyst Room on the second floor. That's the same room that's been used for that meeting. Thirdly, since it's already Wednesday, we need to remind on flight departures. So for those of you who had not yet received your airport transfer flyers, please visit the desk in front of the plenary room so we can coordinate your transport to the airport. And finally, just a big thanks to all of us, to everyone for continuing to adhere to the safe practices against COVID while we're here at the regional committee meeting. So, however, if you're experiencing cold or flu-like symptoms, please isolate in your rooms, make use of the rapid antigen tests that have been provided, and inform the Secretariat so we can support you. Thank you very much, Chair.
Thank you and welcome back. Hope you had a nice coffee break. Even though we are meeting in a hybrid setup, it not be WIPRO meeting not to have a mobility break. So we will have a Pacific mobility break. May I ask everyone, please stand up, turn on your camera and join in to the Pacific mobility break. Thank you. That it's quite a big shake. And that's the Pacific mobility. You shake the calories from that coffee break. Now we'll start this session and reminders, please be mindful of time 3 minutes for your intervention. And please speak slowly and directly into the microphone. It is very important that we understand your intervention. And please, I feel sorry for our translators at the back. Allow them to translate your intervention appropriately. We now move to agenda item 12, non-communicable disease prevention and control. Document WBR/RC73/8. And may I invite Dr. Jacob, DDG, and Wipro OIC to introduce this item. Thank you.
Sorry, Mr. Chairperson, distinguished representatives. I am very pleased to present for your consideration the document WPR/RC73/8 on non-communicable disease prevention and control. The Western Pacific region is undergoing profound and rapid changes. New demographics and shifting lifestyles, coupled with evolving perspectives on disease and technological innovations, have powerful consequences on the epidemiology and approaches to non-communicable diseases, or NCDs. Despite some reductions in premature NCD mortality between 2000 and 2010, progress has slowed and in some areas been reversed. NCDs are the largest disease threat to our region, accounting for 87% of all deaths in the Western Pacific in 2019. These diseases, primarily the cardiovascular and chronic respiratory diseases, cancers, and diabetes, are largely preventable. The prevention and control of NCDs is a cornerstone of the effort to make the Western Pacific region the world's healthiest and safest region. With that in mind, I would like to emphasize the following 5 key points. First, NCDs are largely preventable and can be controlled with a range of evidence-based interventions. But investment in NCD prevention and control must be increased now to make a difference for the future. Second, it is important to communicate powerful arguments to other sectors that NCDs are strongly linked to sustainable development. For example, WHO has determined that a $1 investment in key NCD Best Buy interventions and policies has a $7 return in health and economic benefits. Third, NCDs result over time from a combination of genetic, psychological, environmental, and behavioral factors. Therefore, actions and coordination among various sectors beyond health are critical to creating health-promoting environments. Education, environment, and food sectors play a key role along with government taxes that make unhealthy choices less affordable. Member states are encouraged to establish a coordination mechanism across all sectors for NCDs. Fourth, it is critical to integrate NCD prevention and control into the primary healthcare system, including patient screening and disease management. It is important to set specific targets and monitor them. Lastly, the life course approach should be used as the basis of targeted interventions, supporting individuals from womb to tomb especially at the community level. This is particularly important as health inequity and risk factors can carry through from one generation to the next. This draft regional action framework proposes an integrated and lifelong approach to transform 6 systems in which unhealthy environments create NCD cases, and the health sector primarily focuses on treating diseases, into health systems with environments that enable an individual's health and wellness, as well as socioeconomic development. The regional committee is invited to consider for endorsement the draft regional action plan framework for non-communicable disease prevention and control in the Western Pacific. The Secretariat would like to show a short video on this agenda item. Thank you, Mr. Chairperson.
Non-communicable diseases, or NCDs, are the leading cause of death in the Western Pacific, causing an estimated 12 million deaths in 2019. Due to rapid urbanization, aging, and changing lifestyles, more people are living with diabetes, cancer, cardiovascular diseases, and chronic respiratory diseases. Healthcare costs from NCDs will further overwhelm household budgets and contribute to poverty if left unaddressed. Cross-sectoral partnerships are necessary to address these challenges and create health-promoting environments which support healthy diets and lifestyle choices. The Regional Action Framework for Non-Communicable Disease Prevention and Control in the Western Pacific aims to transform a sick system into a health system, where countries invest healthy environments, behavioral change, and prevention and early detection in addition to treatment. By adopting a whole society approach, strengthening primary health care and empowering patients to make decisions about their health, we can stop the NCD epidemic, enabling more people to live long, healthy, and productive lives.
Thank you. We will now hear from representatives who wish to speak on this item. Please indicate your wish to speak by clicking the big button on your microphone if you are in the plenary, or by using the raise hand function on Zoom. Now I call upon Marshall Island, followed by Tonga. Thank you.
Thank you. Your Excellency, Honorable Chair, distinguished delegates, ladies and gentlemen, friends and colleagues here. Chair, on behalf of the Marshall Islands, I wish to congratulate you on your election as chair. In the same vein, I wish to convey our gratitude through you to the people and government of the Philippines for the warm hospitality given to our delegation since our arrival in Manila. We also recognize the efforts of Western Pacific states in working diligently to end the critical phase of the COVID-19 pandemic. Chair, with about 41 million deaths each year globally, NCD remains the largest source of preventable death and disability for my country and our region, far exceeding the death toll of COVID-19 pandemic. The successful creation of the Pacific Monitoring Alliance for NCD Action, or MANA, has helped provide a clear idea of where we are insofar as the status of NCDs is concerned and what needs to be done to bring about effective responses. Sadly, the dashboard results from the surveillance of the MANA clearly indicates that things are getting worse and the overall death rates are increasing due to increase in youth tobacco use in the last 10 years, 4% increase in adult overweight and obesity, 5% increase in prevalence of diabetes, and 8% increase in the overall NCD death rate. The MANA tracking shows a large backlog of unfinished business in terms of adopting laws and policies. showing that we've fallen behind in adoption of effective laws and policies. As well, recent community-based surveys tell us that 2 out of 3 of our people who have diabetes or hypertension do not receive health care and are vulnerable to illness and death. To address this, there is a new administration in place determined to turn this around through the completion of fiscal year 2023 to 2030 strategic plan. This new strategic plan aims to vastly ramp up outreach, decentralization, integration of services, form partnerships, upgrade our data systems, and most importantly, a more active and effective legislature approach. Chair, it is in this legislative approach that the RMI seeks your assistance, especially in the development of specific laws and policies. Clearly, deployment of the public health law specialists to our Pacific region or made available through our CLO offices to provide direct support to our health agencies to assist with drafting legislation and coaching on effective negotiation strategies to enact, finance, and enforce our various NCD prevention and control policy priorities. Lala, and thank you very much.
Thank you, Marshal Island. Can you please turn your name, country name tag toward the Secretariat so we can get all your names down? So, Tonga, the floor is yours, followed by Lao PDR.
Oh, yeah. Thank you, Honorable Chairman, Your Excellencies, ladies and gentlemen. Non-communicable diseases, the world's and the Pacific's biggest cause of death, is a major threat to health and economic development. Despite many NCDs being highly preventable, over 80% of deaths due to NCD most deaths are premature. This has resulted in significant loss of productivity in our region. In Tonga, like other countries, NCDs are the top killer and the leading cause of disability. Everyone in Tonga is affected, whether directly or indirectly, by NCDs. In addition, climate change, natural disasters, and COVID-19 pandemic have continued to challenge the existing burden of NCDs through the disruption of essential healthcare services and delaying the implementation of NCD policies, legislation, and programs. Tonga ensures that NCD prevention and control is the top priority in our National Sustainable Development Agenda. We are implementing the National Multi-Sector NCD Strategy developed through multi-sector consultation with technical inputs from SPC and WHO. It focuses on trying to address social, cultural, behavioral, and environmental factors influencing NCDs. Our NCD strategy is in line with global and regional NCD best buys, the Pacific NCD roadmap recommendations, and the Pacific Ending Childhood Obesity Priorities, which were endorsed by our Pacific leaders. The Tonga NCD strategy focuses on 5 areas, which are effective governance, leadership, multi-sector stakeholder engagement and partnership, health promotion and disease prevention, health system strengthening and monitoring and evaluation. Tonga has been monitoring the progress of our NCD action using the Pacific Monitoring Alliance, or MANA, which is a mutual accountability mechanism used across the Pacific. To date, Tonga has progressed in many ways, except in terms of policies and legislation. Tonga will continue to address these policies and legislation gaps using the Pacific NCD legislative framework, recently endorsed by the Pacific Health Ministers meeting, through scaling up of actions on multi-sector NCD strategy. Addressing NCD requires efforts beyond the health sector for a holistic approach. Honorable Health Ministers, heads of delegates, ladies and gentlemen, you have the power to bring in stakeholders from all relevant sectors to encourage them to scale up the NCD investment of additional resources in order to, one, to scale up NCD actions to prevent NCDs, two, to safeguard the people with NCDs, and finally, to promote well-being of our Western Pacific region. Thank you, Honorable Chairman.
Thank you, Tonga. That was 2 minutes and 59 seconds. Thank you. We have Lao PDL, you have the floor, followed by China. Thank you.
Doesn't work. Distinguished chairs, honorary ministers, and delegates. As in other countries, Lao PDI is undergoing demographic and ecological transition and change in our lifestyles. Sadly, we now face an increasing burden of non-communicable disease, contributing to an estimate of 60% of deaths in 2016. During the COVID-19 outbreak, many COVID-19 deaths may be linked to NCDs. To address this growing threat to human health, we have prioritized the prevention and control of NCDs in the 9th Health Sector Development Plan 2021 to 25, outlining key steps to save lives. Taking the major LCD risk of tobacco, our tobacco control law have been recently updated in line with the WHO Framework Conventions on Tobacco Controls to include plain packaging, a key step in reducing tobacco-related deaths. More broadly, we believe health promotion to reduce LCD risk factors at the community level are the most effective ways to protect health. Health literacies and promotion activities are part of works by village health volunteers who are exploring how village health community can play a key role in improving health and well-being. But none of these actions will work without a whole of society approach. Beating LCDs is a team's, community, and national effort. To support multi-sectoral collaborations, our government developed the national policy on multi-sectoral action plan for the prevention and control of NCDs from 2014 onwards. Furthermore, we have developed the Lao package of essential non-communicable disease interventions for primary health care. This is currently being updated to strengthen capacity for health promotions, early detection, timely referral, and care for NCD at primary health care levels, and we are working on a plan to deploy it nationwide in the coming years. However, due to the competing priority like mother and child health, communicable disease, outbreaks, and disasters, our investment to strengthen the health system to address LCDs is still limited. With challenge exacerbated during COVID-19, we seek WHO continued support as well as others donors to help beat LCDs in Lao People Democratic Republics and support the endorsements of that draft regional action framework. I do thank you.
Thank you, Lao PDL. China, the floor is yours, followed by Vanuatu.
Okay. Mr. Chair, ladies and gentlemen, distinguished representatives, the Chinese delegation in principle agrees with the draft action framework. The Chinese government has always attached a great importance to NCD prevention and control. We have used the hypertension, diabetes, and cancer as the breakthroughs and emphasized the early screening and detection. And also, we promoted the transition from disease treatment to health management. We have made the following efforts. First, we have constantly improved the NCD prevention and control. We come up with the national program of action for Healthy China 2030, and we have developed an NCD prevention and control policy system with the focus on cancer prevention treatment and stroke prevention treatment, emphasizing the integrated approach for prevention of diseases and targeted control of the specific diseases. Second, we have taken shape the comprehensive paradigm for NCD prevention and control. Thirdly, we have promoted the treatment and prevention of the major NCDs for specific diseases like cancer, CVDs, chronic respiratory diseases, diabetes, obesity, and oral diseases. They have been identified as key NCDs for control. And also we have improved the service and technological application for NCD screening and prevention. The unmatured deaths of NCD have been dropped by 17.3% from 2015 to 2021. And in the future, China will strengthen its collaboration with WHO, and we will continue to promote NCD prevention control, strengthen our exchange with the relevant countries, and promote the NCD prevention control to a new level. Thank you.
Thank you, China. Vanuatu, the floor is yours, followed by the Philippines.
Thank you, Chair. His Excellencies, Vice Chair, distinguished fellow delegates. Chairman, let me start by conferring with the comprehensive regional framework for non-communicable disease prevention and control for the Western Pacific region. Chair, in recent years, we have come to realize that despite our efforts to hold the healthy and advancement of NCDs, its prevalence and incidence continue to increase, and the management of both secondary complications, such as kidney failure, stroke, below-knee amputations, are putting pressure on our health system. But we believe this framework will provide the basis of guidance and support the ongoing efforts of the Vanuatu government to address NCD in a more systematically way, with the support from our stakeholders and partners. Our last NCD step survey indicates that 90% of our adult population have at least one risk factor of NCD, and this is alarming. Therefore, as any other small island state, we kept NCD at the top of our agenda and have elevated it to the highest possible level. I'm happy to say that the NCD is now among the priority list of the National Security Committee, a committee that sits within the Prime Minister's office. We have shifted our focus from the notion of absence of disease focus to a holistic approach of health and well-being, as enshrined in the Healthy Island setting, to bring together our non-health sectors into the field to be part of the team player. We are currently reviewing our NCD task force, which was established in 2019 and consisting of members from various government ministries. As we come to realize that NCD is more than a Ministry of Health matter, but we need a more collective effort and decision from all government agencies and other sectors. As of January 2022, Vanuatu has increased the excise taxes for tobacco products by 30%. We have increased the prices of selected unhealthy food and sugary sweetened beverages, and we have totally banned all forms of electronic nicotine and non-nicotine delivery systems in the country. We are currently reviewing a Tobacco Act, our Alcohol Act, Food Act, and other policies to ensure that we achieve our society goal number 3, which is to reduce the incidence of communicable disease and promote healthy lifestyle choices and health-seeking behaviors. Vanuatu is committed to participate in the participated process leading to the 4th high-level meeting of the UNGA 2025 and will continue to work to achieve the SDG 3.4 and 3.8 goals. We will continue to implement the NCD multiple sectoral policy and action plan and our mental health policy. Finally, Chair, we wish to propose the idea of sharing our success stories to continue among member states so we can learn from each other on how we can succeed with the plans to address the risk factors of NCD throughout the different communication channels.
With this, I want to thank Australia for sharing their success story yesterday, and we look forward for more. As we reaffirmed our support the regional framework, and we thank WHO for its technical assistance through the office in Vanuatu. Faftaine, thank you, Chair.
Thank you, Vanuatu. Philippines, you have the floor, followed by Mongolia.
Mr. Chair, I am Dr. Maria Rosario Vergere, the current OIC or Officer in Charge of the Philippine Department of Health. The Philippines fully supports the draft regional framework for non-communicable diseases, prevention and control in the Western Pacific. We concur with the strategies and recommended actions indicated in this document. To ensure responsiveness, relevance, and integration of programs and services, the Philippines, guided by the Universal Health Care Law, promotes intensified interventions at the primary care level to promote health, prevent and reduce the emergence of risk factors, and ensure equitable, comprehensive, affordable, and quality treatment across the continuum of care for all life stages with linkages to the higher levels of care. At present, the country is scaling up health promotion strategies to ensure that environments are health supportive and that Filipinos are health literate in an array of areas including diet and physical activity, tobacco, and alcohol use. Our health promotion framework strategy is also aligned with the Regional Action Framework in its recommendation to develop healthy public policies across known risk factors of non-communicable diseases and the social determinants of health, and implement strategies that will enable health-promoting environments, including through known risk factors of NCDs, and to implement strategies through regulatory and legislative routes. For this, the Philippines is adopting the settings-based approach to promote healthy schools, healthy workplaces, and healthy communities, and is implementing aggressive and innovative social and behavioral change interventions to increase literacy and build capacity at the individual level. This is complemented by the strengthened primary care strategy in the prevention and control of NCDs operationalized through the following: enhancement of existing national policy and management system to strengthen NCD prevention and control service delivery towards universal health care, development of our omnibus health guidelines per life stage, including primary health care package of services parallel to the provisions of universal health care, development of implementation tools based on the aforementioned omnibus guidelines, and integrated course on primary care per life stages for our primary care workers. The Philippines reaffirms its support to the regional framework for NCD prevention and control in making the Western Pacific region the world's healthiest and safest region and winning the battle against non-communicable diseases. Thank you, Mr. Chair.
Thank you, Philippines. Mongolia, you have the floor, followed by Republic of Korea.
Thank you, Mr. Chair. Non-communicable disease are the leading cause of death in Mongolia, with 58.5% of all deaths due to cardiovascular disease and cancer. The prevalence of common risk factors among the people aged 15 to 69 years remains higher. According to the WHO's NCD Progress Monitor 2022, it is estimated that NCDs are accountable for 83% of total death in Mongolia, and the probability of premature mortality due to NCDs is 35%. Nonetheless, my government is committed to address NCDs and adopted several national policies that includes targets that are aligned with the WHO NCD Global Monitoring Framework and of that SDGs. Currently, we are in the process of amending our tobacco control law to strengthen the legal environment for tobacco control by imposing regulations for new and novel tobacco products, including electronic nicotine delivery systems and heated tobacco products, fully imposing 100% indoor smoke-free environment, increasing excise taxes on tobacco products, and increasing the size of pictorial and verbal health warnings on packages of tobacco products. Distinguished delegates, Under the initiative and leadership of the President of Mongolia, His Excellency Mr. Ognagin Horesokh, the government of Mongolia has taken major policy measures for alcohol control. In April 2020, the President issued a decree giving directions to the government to take measures to reduce the adverse impacts on health, social security, and economic condition of the population caused by harmful use of alcohol. As part of the implementation of the decree, the Parliament endorsed a revised law on controlling the circulation of alcoholic beverages and combating alcoholism, and amended the law on excise tax. The latter imposes the increased excise tax on alcoholic beverages based on its alcoholic concentrate every 2 years until the year of 2029. Both the revised and amended laws will come into force from the 1st of January 2023. In addition, in May 2020, the government launched a nationwide health screening program, which covers all population for early detection and screening of common non-communicable disease, including mental, neurological, and substance use disorders. The health screening program is fully funded by the health insurance. Mr. Chair, Mongolia is fully committed to further accelerate our efforts to addressing NCDs, and we welcome the endorsement of the current draft regional action framework for non-communicable disease prevention and control in the Western Pacific 2023-2030. At the same time, taking this opportunity, Mongolia would like to request the WHO technical support in adapting and implementing the regional action framework, in addition to technical and funding support for scaling up the Mongolian Mongpan initiative to improve NCD and CVD management at primary healthcare settings in my country. I thank you for your attention.
Thank you, Mongolia. Republic of Korea, you have the floor, followed by Tuvalu.
Thank you, Chair. The Republic of Korea is pleased to have this opportunity to discuss NCD prevention and control. Also, Korea endorsed the regional action framework for NCD prevention and control in the Western Pacific. Mr. Chair, the Republic of Korea expressed concern that the rate of regional progress in NCD prevention and management in the Western Pacific region is not fast enough. In addition, the prolonged COVID-19 is exacerbating the already cumbersome NCD burden in the region and causing substantial change in public health. Thus, now is the opportune time for member states to transform a disease treatment center's sick system into a health system. For this, the Republic of Korea acknowledged that establishing an early detection system through screening, including health checkup, strengthening the role of primary health care, and empowering patients for self-management are crucial. In addition, member states would be considered building and using data for surveillance and analysis of NCD to implement evidence-based policies. As a part of the Korea's effort to prevent against NCD, we integrated policies for the management of risk group into the comprehensive cardiovascular disease management plan. Moreover, Korea has stably operated not only the NCD examination system, but also primary healthcare system that supports health checkups, early diagnosis, and treatment. Even during the COVID-19 pandemic, Korea has continually endeavored to prevent and control NCDs building upon Korea's stable healthcare system with innovative strategies. Moreover, Korea is conducting Korean National Health and Nutrition Examination Survey every year to monitor trends in health risk factor and prevalence of major NCD. Ms. Chair, still in a Western Pacific region remain insufficient in terms of examination system, early detection and treatment of NCD. Thus, capacity building for countries in the region to help build stable primary health care service is a must. Republic of Korea will define an NCD prevention and management model based on its experience and exemplary cases, and explore how we can more actively contribute to the implementation of NCD prevention and control. Thank you, Chair.
Thank you, Korea. Tuvalu, you have the floor, followed by New Zealand. Thank you.
Thank you, Chair. Non-communicable diseases account for around 75% of all deaths in the Pacific. Most are premature. NCD increases healthcare costs, low workforce, and reduced productivity, and poses a major threat to health and development, particularly small island state development. Tuvalu has been fighting against this NCD crisis and consequences of climate change. Our report are saying that NCD mostly represents 78% of all deaths in Tuvalu. Cardiovascular disease account 44%, diabetics 25%, cancer 11%, and CRD 4.9%. In our response to escalating NCD issues in the country, our efforts have been focused around some of the renowned risk factors that are commonly exist and contributed to countering of NCDs. We implement WHO best by interventions and make some progress. We would like to further implement best of the best by interventions in Tuvalu. Those are harmful use of alcohol through increased excise tax on alcoholic beverage together with alcohol advertising restrictions. Physical inactivities, increase in physical activities level among general populations, educate and implement community-wide public education and awareness campaign for physical activities, which includes media campaign. Reform food to reduce salt intake and set target level for salt in foods and meals, and ban imported of unhealthy foods. Increase excise tax and price of tobacco products are eliminates exposed to second-hand tobacco, smoke in all indoor workplace, public place, and public transport, enforcement of existing tobacco law. Over the years, the key issues and challenges that MO8 is currently facing are easily noted. This is a huge need to strengthen our policies and legislations to address counter NCDs in the country. The need for engagement of non-health sectors and civil society is also a challenge at the moment. All in Tuvalu strongly support proposed idea of the regional action framework for NCD prevention and control in the Western Pacific. More importantly, not only what to do, but also how to do based on the country counter needs in Tuvalu. Tuvalu will revitalize pushing NCD agenda in the country and beyond. Malo Pito.
Thank you. Thank you, Tuvalu. New Zealand, you have the floor, followed by Micronesia.
Thank you, Chair. Tēnā koutou katoa. Aotearoa New Zealand thanks the Western Pacific Regional Office for its development of this framework. The framework presents a clear vision to support us in our mission to counter and reverse the growing burden of NCDs in our region, and we are already implementing it into our domestic work program and policies. The COVID-19 pandemic's impact on NCD prevention and management remains of serious concern. It is vitally important that we continue to accelerate action in the Western Pacific, including as we consider the significant and ongoing health risks NCDs pose as comorbidities to COVID-19. Aotearoa New Zealand is adopting a more holistic approach to NCD prevention and management, which recognises the burden of comorbidities, including mental health, intergenerational impacts, and common risk and protective factors. Our recent health and disability system reforms will be instrumental in making this shift. For example, we are implementing a locality approach to allow us to prioritize investment in high-quality, long-term, wraparound support that is whānau-centered, community-led, and culturally appropriate. A vital lesson learned from COVID-19, and one that is reflected in the draft framework, has been that if we can achieve better health outcomes for underserved populations when local communities are in the driver's seats. Empowering these groups to co-design health-enabling environments and appropriate pathways towards early identification and intervention of NCDs is critical if we are to achieve high order, healthy futures for all. Chair, innovation is crucial as we emerge from the pandemic. We would like to share one example of innovation in action, Aotearoa New Zealand's Kaya Whina workforce. Previously referred to as our unregulated or non-regulated community health workforce, Kaya Whina are community members without clinical or public health training who are being empowered to navigate across to ao Māori, the Māori world, and to ao Tauiwi, the non-Māori world, to understand the health of people and communities. This bicultural ethos acknowledges a person's individual sense of belonging, identity, and connection to Wairua, the spiritual realm, Hinengaro, psychological, Tinana, physical, and whānau, social connections, as interwoven elements to encompass collective and relational health and well-being. By supporting holistic well-being, Kaya Whina will continue to play a critical role in achieving improved outcomes for all New Zealanders, including those managing NCDs. Chair, Aotearoa New Zealand will continue to support positive momentum in NCD prevention and control, and we look forward to listening and learning from fellow member states on how we might counter the regional NCD burden together. As we would say in New Zealand, ma whero, ma pango, ka oti ai te mahi. Through cooperation and combined effort, our work will be completed. Ngā mihi nui, thank you.
Thank you, New Zealand. Micronesia, you have the floor, followed by Brunei. Thank you.
Thank you, Chair. My party would like to contribute the following interventions. The FSM recognized that a significant and preventable cause of death and disability in the Pacific is violence and injury caused by gender-based violence. It is therefore recommended that NCD interventions incorporate and support ending violence against women and girls prevention and response. The FSM agreed that it is important for member states to engage community leaders and workers to reach vulnerable populations with NCD prevention and control services. When developing controls and services, it is recommended that a consideration is given to working with existing cultural strengths as well as intersections between disability, gender, climate change, and disaster. I thank you, Chair.
Thank you. Thank you, Micronesia. Brunei, you have the floor, followed by Australia.
Thank you, Chair. Brunei Darussalam would like to note and commend WHO for the preparation of the comprehensive report, as well as for WHO's continuous commitment and extensive work at many different levels on the prevention and control of NCDs. NCDs remain the major cause of mortality in Brunei Darussalam, estimated to account for about 85% of all adult deaths. Our NCD surveillance over the years showed some plateauing in obesity rate and decrease in physical inactivity. However, these are early days yet. Unhealthy diets remain a challenge, and impact of care debt on NCDs management in the current pandemic era remains to be evaluated. I am pleased to inform that we have recently launched our second Brunei Darussalam multi-sectoral action plan for the prevention and control of NCDs 2021 to 2025, which includes stronger governance mechanism and clear monitoring and evaluation framework. The establishment of a national multi-sectoral task force for health has created closer collaboration amongst various stakeholders in the promotion of tobacco control, physical activity, and healthy food environments. The COVID-19 pandemic has provided us an opportunity to leverage on the use of digital technology, our Brew Health application, which was initially used for COVID-19 purposes and now extended to health education and promotion, and NCD health management, including monitoring several key NCDs and risk factors, as well as facilitate in NCD-related research. A diabetes health management platform is currently in the trial phase to empower adults with type 2 diabetes with knowledge to modify diet and lifestyle via the application. In promoting physical activity in the country, BN on the Move, a promotional health plan via the Brew Health application was launched recently with 1 billion Steps Together campaign, an initiative to promote healthy lifestyle by encouraging the public to collectively increase their physical activity. The challenge was completed in 8 days with 43,000 participations. As shared previously, we are now in the midst of the 20 billion step challenge. To further strengthen physical activity promotion and reduce physical inactivity, as well as sedentary behavior, the second National Physical Activity Guidelines for Brunei Darussalam was recently launched, which is more comprehensive and covers all age from early age to older adults, and taking into consideration subpopulations, including pregnant and postpartum women, and those with chronic conditions and disability. These guidelines, which are aligned and based on the WHO guidelines on physical activity and sedentary behavior in 2020, serves as a guidance document to further increase physical activity in the country. Additionally, we are reviewing relevant legislations to support all the above-mentioned strategies. Finally, Brunei Darussalam would like to reiterate our gratitude to WHO for the continuous support extended to us, and we remain fully committed to working together towards achieving the NCD voluntary global targets. Brunei Darussalam therefore fully supports the Regional Action Framework for NCD prevention and control in the Western Pacific. Thank you, Mr. Chair.
Thank you, Pranay. Australia, you have the floor, followed by Kwan. Thank you.
Thank you, Chair. We endorse the Regional Action Framework for NCD prevention, control in the Western Pacific. Addressing NCDs is essential in moving towards universal health coverage and achieving the SDGs, including ensuring healthy lives and promoting well-being for all. We underscore the importance of strengthening primary healthcare as the core component of delivering people-centered NCD management and health services. The Australian Government's National Strategic Framework for Chronic Conditions recognises the importance of placing people at the centre of their own healthcare, empowering them to make informed decisions about matters such as treatment, palliative and end-of-life care, and plan appropriately for their future. Australia recognises NCDs are the major cause of death and chronic illness in our region, and there is an urgent need to accelerate action. More meaningful engagement with a broader range of civil society representatives is critical to address the social determinants of health and enable health-promoting environments. We also encourage greater collaboration with other relevant areas, such as the WHO's Framework Convention on Tobacco Control Secretariat and the Tobacco-Free Initiative. Australia recognises the framework's attention to gender and equity and encourages further strengthening the focus on disability access to health systems and healthcare decision-making and effects in countries and populations. We are pleased to see the framework's focus on data, evidence, and surveillance of risk factors, disease prevalence, health inequalities, and priority population groups to drive evidence-based policy and investment, which is consistent with Australia's approach to monitoring of chronic conditions, associated risk factors, and burden of disease. Domestically, the Health Outcomes Modelling and Evaluations Project develops a robust evidence base to inform advice on interventions to support better outcomes later in life, including delaying or diverting entry into the aged care system. Australia welcomes the framework's attention to ensuring inclusive and equitable collection of appropriate information amongst marginalised groups and would encourage the Secretariat to undertake analysis of collected data outlined in the framework to ensure insights for priority cohorts such as Indigenous people with disability or Indigenous women and girls can be obtained. Future work should also consider aligning the principles of Indigenous data sovereignty. Thank you.
Thank you, Australia. Guam, you have the floor, followed by Samoa. Thank you.
Thank you, Chair. Honorable Chair, distinguished ministers, delegates, and guests. Similar to the Western Pacific region, and as already shared in some of the member state interventions, the U.S. Pacific territories equally face a crisis of NCDs. This crisis is not new. In 2010, the 6 U.S. affiliated Pacific Island countries and territories, their health leaders came together to declare a sub-regional state of NCD emergency, calling for immediate and urgent action to address NCDs across the lifespan, across sectors, and through empowered local leadership and communities. It was a landmark decision that triggered a framework of action to focus on developing and implementing evidence-based NCD health policies improving local and sub-regional NCD surveillance systems and capacities, strengthening and expanding NCD program delivery and quality improvement efforts, and supporting the continuous engagement of local and sub-regional executive, legislative, judicial, community, traditional, and private sector leadership. 12 years on, though we have made significant and critical strides to address NCDs within our communities, recently analyzed data trends collected since 2010 to date show little improvement within our sub-region across a core set of critical NCD risk factors, morbidity, and mortality indicators. It was a wake-up call. We have done so much, and we are extremely proud of our accomplishments in addressing NCDs. Yet, it is clear we have so much more to do. Our shared challenge today is to critically reassess not just what more can be done, it calls for how we move forward to be effective in our interventions to result in improved health outcomes. What lessons can we learn from the 10+ years of targeted NCD response that worked, not worked, could have worked if technically supported more appropriately, among others, to listen to the concerns of the target population we work to affect, and using evidence-based approaches, highlighting best practice to nudge our Pacific communities to access services, maximize resource mobilization, and impact evaluation, striving towards a well community. The United States territories support the Regional Action Framework for Non-Communicable Disease Prevention and Control in the Western Pacific, and kindly request WHO and regional partner support to assist our sub-region to critically rethink our NCD response efforts, particularly supporting us in identifying appropriate technical and financial resources that can strengthen and upscale our local efforts and interventions. Thank you, Mr. Chair.
Thank you, Kwam. And before I give the floor to Samoa, just a simple reminder, please speak slowly and directly into the microphone. Our interpreters is finding difficult when you speak very fast. Be mindful, there is no race for a prize here. What is important that after the intervention, we all understand and the Secretariat understand your intervention, as well as the interpreters to interpret and translate your intervention. Thank you. Samoa, you have the floor, followed by Cook Islands. Thank you.
Thank you, Chairman. Samoa wishes to thank the Western Pacific Region, Regional Office for its work in this vital area of health. The impact of non-communicable diseases in this region, and particularly in the Pacific Islands, has become burdensome on our health system. Diabetes, cardiovascular disease, cancer, and chronic respiratory disease have burdened our health system and accounts for the majority of deaths and takes a large proportion of our health budget. NCD in Samoa actively implements strategies in health and wellness programs, taking a structured preventative approach in addressing the NCD burden. In the last few years, the health system has focused on the curative arm of health. There is the need to go back to the grassroots at a community level to address NCD prevention and control. Samoa continues to focus on the risk factors, namely tobacco use, the harmful use of alcohol, unhealthy diets, and physical inactivity through policy and legal intervention to assist with the changing and the mindsets of the general public in making informed and the right choices. There has been a sustainability of health promotion activities in our country through the involvement of the community to take ownership of their health at a village setting. Samoa continues to implement the Penfa Samoa program, which has been contextualized to the Samoan setting using cultural approaches. Mr. Chairman, we need to promote and advocate the wellness model versus the sick model to make it routine to look after ourselves through healthy choices and regular medical screening and not waiting until we feel symptoms of illness. NCD has to take a multi-sectorial approach to involve all actors at all levels of society. It is everyone's responsibility. We believe that there are policy interventions that assist through adopting evidence-based initiatives, such as the WHO Framework Convention on Tobacco Control and the Best Buys Initiative. For Samoa, NCD prevention and control is crucial, as it has caused many premature deaths for our country. We continue to strengthen health systems at a community level to help curb the burden of NCDs. Policy and legal interventions are also mechanisms to assist with addressing the social determinants of health and the challenges of NCD. Samoa therefore acknowledges and endorses the Regional Action Framework for Non-Communicable Disease Prevention and Control in the Western Pacific region. Partai, and thank you.
Thank you, Samoa. Cook Island, you have the floor, followed by Japan. Thank you.
Thank you, Chair. Kia orana, and a warm Pacific greetings again to each and every one of us. The Cook Islands commends the Regional Committee and supports the request to endorse the Regional Action Plan Framework for Non-Communicable Disease Prevention and Control in the Western Pacific. Like other countries, NCD is and continues to be the silent killer to our people and costing our government significantly every year, both through our social welfare support and the long-term medical care and management of our patients. The Cook Islands have recently completed its STEPS survey with the support of the Samoa Sub-Regional Office, Dr. Kim Dixon and her team. The analysis of that survey is scheduled to take place next month, which will inform the review and strengthening our current NCD strategy going forward. However, I do agree that we need to accelerate the implementation of evidence-based and cost-effective policy interventions adapted to country-specific requirements. The Cook Islands in late 2021 and early 2022, with the support of SPC, undertook a men's health screening program on the main island of Rarotonga and on my home island of Attu. The results and findings was really concerning. This regional action plan framework is timely, so that innovative methods and strategies to reducing NCD burden to our society, to our Ministry of Health and our government can be accelerated for adoption. The Cook Islands would like to acknowledge the great work of the people, of those who were involved in the development of this regional action plan framework. Metaki Ranunui, and I thank you, Chair.
Thank you, Cook Island. Japan, you have the floor, followed by Malaysia.
Thank you, Mr. Chair. We appreciate the Secretariat's report and support the draft regional action framework for non-communicable disease prevention and control in the Western Pacific. First, we strongly agree that a cross-sectoral coordination mechanism should support actions. Taking this approach, Japan is creating cities where people can naturally keep physical activity and people can enjoy sports regardless of age, gender, or disability. We also started an award program for health management and health promotion in various organizations, cooperating with the Ministry of Economy, Trade, and Industry. The number of companies engaging in health management has been steadily increasing. Second, we strongly agree that early detection and intervention are cost-effective. This perspective also emphasizes the importance of mutual linkage between screening and primary health care. Third, Japan has approved the insurance coverage of the smartphone application for nicotine addiction and hypertension. Such tools could be useful in other member state settings. Finally, we expect the WHO's strong leadership in supporting member states to assess their situation and development and implement cost-effective NCD action plans, utilizing existing programs and infrastructure aligning with their specific circumstances. I thank you.
Thank you, Japan. Malaysia, you have the floor.
Thank you, Honorable Chair. As we have heard today, NCDs are increasing in all member states and account for 71% of all global deaths each year. And only 14 countries are on track towards achieving SDG 3.4, a sobering reminder of all of the immense challenge we face moving forward. NCD steals the life and livelihoods of our people, often in their most productive years. Given that NCDs are largely preventable, addressing it warrants the highest political and social commitment, and Malaysia is fully committed towards heeding the call by the WHO to strengthen its efforts in addressing NCDs to turn the tide against the epidemic. Malaysia recognizes the need for urgent action and that the health sector cannot stand alone in the battle against NCD. In line with the implementation roadmap of 2023 and 2030 for the Global Action Plan for the Prevention and Control of NCDs 2013 and 2030 by WHO, and Malaysia's National Strategic Plan for NCDs 2020 and 2025, we had launched the National Healthy Malaysian Agenda Initiative, or Agenda Nasional Malaysia Sihat in 2021. Understanding the importance of early detection of NCDs to prevent complications and premature death, Malaysia has launched the National Health Screening Initiative under ANMS, a collaborative effort among various ministries, private sectors, and non-governmental organizations to encourage and provide opportunities for the people to undergo health screening as a first step of knowing and take charge of their own health. Malaysia recognizes the need for health reform to be future-proof, transcending change in the political landscape. As such, we are currently in the process of putting forward a white paper on health towards national health system reform of service delivery, financing, governance, as well as organization for the next 15 years. We recognize the chronic underinvestment towards addressing NCDs, and this will be addressed within this white paper to ensure a sustainable health system that meets all public healthcare needs. As part of the implementation strategy, we will tabling this white paper in Parliament to garner bipartisan support and establishing a health reform commission that shall be accountable to Parliament. All too often, we focus mainly on treating and ensuring that chronically sick people become healthy again. This should not be the case. The health system should concentrate on keeping people healthy to begin with. It is increasingly recognized that to improve and maintain the health and the well-being of the people, we need to go beyond healthcare. Studies have demonstrated that medical care only contributes 20% of the health outcomes of the people. The largest share is contributed by social determinants such as education, housing, transportation, agriculture, and the environment. These affect how people experience the world and the choices they make. When any of these conditions pose a challenge to people, they become risk factors that will impact health and well-being. We are pleased to see that the draft regional action framework for NCD prevention and control in the Western Pacific has a strong focus on addressing the various determinants of health, turning the sick care to healthcare. This is very much aligned to our proposed health white paper and our national strategic plan for NCDs. As such, Malaysia strongly supports and endorses the regional action framework for NCDs prevention and control in the Western Pacific region. I thank you, Chair.
Thank you, Malaysia. Ministers, Excellencies, ladies and gentlemen. You have done very well in this agenda item. Only the WIPRO member states knows how to read the time, and you have done very well. We will now break for lunch, and we will continue with this agenda item after lunch. There will be a side event on a crisis on our doorstep. Act now on antimicrobial resistance to save lives at 12:45. So be back here at 12:45 for this side event. The same Zoom connection link as the session will still be used. Thank you and enjoy your lunch.
Thank you, Chair.
here to talk about my daily action since I started to take commitment with this campaign to fight against antibiotic resistance. So the first priorities of mine is I always seek for advice from a qualified health professional before using antibiotics, and I always follow their advices on how to take them, where to take them, and when to take them. And also, I started to wash my hands regularly, especially before I taking meals. And I started to educate my family and friends about these issues as well. And I promise to keep doing these actions for the rest of my life. And I hope you join the campaign too. Thank you.
Make the pledge to fight antimicrobial resistance by preventing infections and stopping the misuse and abuse of antibiotics. As an ordinary citizen and a future healthcare professional, I always try to prevent the emergence and spread of antimicrobial resistance. The best way is to keep personal hygiene, so I always try to keep my work by carrying a small hand sanitizer with me in my backpack, as well as making frequent use of another one in my home. I will also ask my doctor for professional medical advice before the use of any antimicrobials. I am a steward for the future.
In Singapore, in year 3 of our curriculum, we'll be learning about the Antimicrobial Stewardship Program. So ASP, which stands for ASP, Antimicrobial Stewardship Program. So it coordinated interventions designed to improve and measure the appropriate use of antibiotic agents by promoting the selection of the optimal antibiotic drug regimen, including the dosing, duration of therapy, and the route of administration. So this allows us to know that in the future when we enter the workforce, before prescribing any antibiotic regimens, we have to ensure that the dosing, duration, and the route of therapy is appropriate before prescribing it to the patients. Also, we have to make sure that we do not overuse these antibiotics in case so as to minimize toxicity and adverse effects, as well as to prevent antimicrobial resistance. Thank you.
Now, here are some simple examples of what I've done in my daily life. I help stopping the overuse and misuse of antibiotics. When I'm unsure if I should use antibiotics, I would normally seek advice from a qualified healthcare professionals. So if they do deem that I should stop taking the antibiotics course, then I will follow the instructions given and take the medications accordingly. Let's say if I've been told to finish the antibiotic course, then I'll follow the instructions given and finish all the antibiotics given. Subsequently, I can also help to prevent the spread of infections. Some simple activities that can be done include simply by washing my hands more regularly, or encourage the others to wash their hands regularly as well, preparing food hygienically, and partake cooked food instead of raw food. I can also keep my own vaccination profile and also my family members' vaccination profile up to date. So all of this may seem to be very simple and insignificant, but you'll be surprised to find out how these simple actions and activities can help contributing to the movement or fight against the antimicrobial or antibiotic resistance.
I am Melissa D. Barcelona, a Pediatric Critical Care Fellow. Being a pediatric intensivist, I care for the sickest children in the hospital, and most of the time I have to deal with the worst infections, both community and hospital acquired. Therefore, timely and aggressive antibiotic control is imperative in my day-to-day practice. In the PQ, the first challenge is choosing the most appropriate antibiotic without going overboard. The second challenge is deciding when to de-escalate antibiotics once the cultures are in. That is, when to shift from an initial broad-spectrum antibiotic to a more targeted and narrower spectrum antibiotic. This is especially tricky for us, especially when we seek significant clinical improvement in our patients with the initial broad-spectrum antibiotics. However, in the PQ, we are also most familiar with dealing with multi-drug resistant infections and the grave difficulty that come with it. And this has become, unfortunately, more common in the recent years. I, therefore, strive to be steadfast in practicing rational antibiotic use in and out of the PQ at all times, because I am a steward for the future.
I'm a doctor major in infectious disease, and I'm also a mother of a teenager girl. About 14 years ago, my daughter got a serious illness. It is the first time I met drug-resistant bacteria. At that time, she received high-dose adrenal cortex hormone treatment. Doctors worried that high-dose hormone treatment would lead to immunosuppression and may increase the possibility of hospital-acquired infection. So they treated her with antibiotics at the same time. 2 weeks later, she developed severe diarrhea and was finally diagnosed with enteritis and suspected of Clostridium difficile infection. So she was given more broad-spectrum antibiotics. However, the symptoms of diarrhea did not improve. Finally, the doctors decided to stop all of these antibiotics and asked other breastfeeding mothers to donate colostrum to my daughter. Finally, about 32 days after stopping using all of these antibiotics, the frequency of her diarrhea decreased from more than 30 times a day to 6 times a day. And my occupation career has shifted from then on to infectious disease. A very important part of my daily work is to provide anti-infection consultation for doctors of different clinic departments, especially hospital-acquired infections. In recent years, hospital-acquired drug-resistant bacterial infection has become more and more common, and I have become more cautious to give anti-infection suggestions. I will provide empirical anti-infection suggestions according to the common isolation bacteria and their drug resistance. At the same time, samples are obtained through various puncture or drainage or even endoscopy. Then the pathogen will be identified by a variety of microbial testing methods so as to achieve the accurate anti-infection treatment. Doctors can also obtain experiences in the proper use of antibiotics through discussions with us. We also work together with surgeons, physicians, microbiologists, and pharmacists, engaging in multidisciplinary discussions. In the face of super drug-resistant bacterial infection, we also try to achieve more effective antibiotic concentrations at different infection sites according to the principles of PK and PD. These daily works are very interesting. Different patients, different infection sites, different pathogens, and different drug resistance are full of challenges. If we don't take action today, there will be no medicine available tomorrow. So I am a steward for the future.
Hello, my name is Umi and I come from Malaysia. I am currently 23 years old and I care for my elderly parents at home. Like any other countries in the world, Malaysia was also affected by COVID-19 and I got so worried about my parents. Despite restricted access to the hospital, I arranged for my parents to obtain their routine vaccines this year, such as their annual flu shot. Vaccination is important, and along the process, I learned that it also helps to prevent some bacterial infection for which treatments with antibiotics are needed. I am sharing this message because I want to encourage everyone to continue to be vaccinated so that the unnecessary use of antibiotics can be prevented. I am a steward for the future, and if we all can keep ourselves, family, friends, parents, and children safe, we can keep the world safe from COVID-19 and other threats such as the superbugs.
working mother from Hanoi, Vietnam. I'm a steward for the future of antimicrobial resistance. To protect my son and myself, we keep my son make sure that he's vaccinated and only take antibiotics as prescribed by the doctor.
talk about my daily action since I started to take commitment with this campaign to fight against antibiotic resistance. So the first priorities of mine is I always seek for advice from a qualified health professional before using antibiotics, and I always follow their advices on how to take them, where to take them, and when to take them. And also I started to wash my hands regularly, especially before I taking meals, and I started to educate my family and friends about these issues as well, and I promise to keep doing these actions for the rest of my life, and I hope you join the campaign too. Thank you.
Made the pledge to fight antimicrobial resistance by preventing infections and stopping the misuse and abuse of antibiotics. As an ordinary citizen and a future healthcare professional, I always try to prevent the emergence and spread of antimicrobial resistance. The best way is to keep personal hygiene, so I always try to keep my work by carrying a small hand sanitizer with me in my backpack, as well as making frequent use of another one in my home. I will also ask my doctor for professional medical advice before the use of any antimicrobials. I am a steward for the future.
In Singapore, in year 3 of our curriculum, we'll be learning about the Antimicrobial Stewardship Program. So ASP, which stands for ASP, Antimicrobial Stewardship Program. So it coordinated interventions designed to improve and measure the appropriate use of antibiotic agents by promoting the selection of the optimal antibiotic drug regimen, including the dosing, duration of therapy, and the route of administration. So this allows us to know that in the future when we enter the workforce, before prescribing any antibiotic regimens, we have to ensure that the dosing, duration, and the route of therapy is appropriate before prescribing it to the patients. Also, we have to make sure that we do not overuse these antibiotics in case so as to minimize toxicity and adverse effects, as well as to prevent antimicrobial resistance. Thank you.
Now, here are some simple examples of what I've done in my daily life. I help stopping the overuse and misuse of antibiotics. When I'm unsure if I should use antibiotics, I would normally seek advice from a qualified healthcare professionals. So if they do deem that I should stop taking the antibiotics course, then I'll follow the instructions given and take the medications accordingly. Let's say if I've been told to finish the antibiotic course, then I'll follow the instructions given and finish all the antibiotics given. Subsequently, I can also help to prevent the spread of infections. Some simple activities that can be done include simply by washing my hands more regularly or encourage the others to wash their hands regularly as well, preparing food hygienically, and partake cooked food instead of raw food. I can also keep my own vaccination profile and also my family members' vaccination profile up to date. So all of this may seem to be very simple and insignificant, but you'll be surprised to find out how these simple actions and activities can help contributing to the movement or fight against the antimicrobial or antibiotic resistance.
I am Melissa D. Barcelona, a Pediatric Critical Care Fellow. Being a pediatric intensivist, I care for the sickest children in the hospital, and most of the time I have to deal with the worst infections, both community and hospital acquired. Therefore, timely and aggressive antibiotic control is imperative in my day-to-day practice. In the PQ, the first challenge is choosing the most appropriate antibiotic without going overboard. The second challenge is deciding when to de-escalate antibiotics once the cultures are in. That is, when to shift from an initial broad-spectrum antibiotic to a more targeted and narrower spectrum antibiotic. This is especially tricky for us, especially when we seek significant clinical improvement in our patients with the initial broad-spectrum antibiotics. However, in the PQ, we are also most familiar with dealing with multi-drug resistant infections and the grave difficulty that come with it. And this has become, unfortunately, more common in the recent years. I, therefore, strive to be steadfast in practicing rational antibiotic use in and out of the PQ at all times, because I am a steward for the future.
I'm a doctor major in infectious disease, and I'm also a mother of a teenager girl. About 14 years ago, my daughter got a serious illness. It is the first time I met drug-resistant bacteria. At that time, she received high-dose adrenal cortex hormone treatment. Doctors worried that high-dose hormone treatment would lead to immunosuppression and may increase the possibility of hospital-acquired infection. So they treated her with antibiotics at the same time. 2 weeks later, she developed severe diarrhea and was finally diagnosed with enteritis and suspected of Clostridium difficile infection. So she was given more broad-spectrum antibiotics. However, the symptoms of diarrhea did not improve. Finally, the doctors decided to stop all of these antibiotics and asked other breastfeeding mothers to donate colostrum to my daughter. Finally, about 32 days after stopping using all of these antibiotics, the frequency of
Good afternoon, and maybe to some of you joining virtually online, good evening. I'd like to start with a really warm welcome to this side event on an extremely important challenge for our Western Pacific region, that of antimicrobial resistance. My name is Martin Taylor. I'm the Director of the Division of Health Systems and Services, and I've got the honor to be the moderator of this wonderful panel of experts and esteemed speakers today. The opening videos that we've been watching remind us about the threat that antimicrobial resistance poses to our health, to our lives, and to our economies. It is one of the 4 priorities for the future vision for the region. It's of such high-level importance that the UN General Assembly will be holding a second high-level meeting on this subject in 2024. That shows us the scale of the importance. Across our region, we've seen some strong political commitment, with most member states now having national action plans in place to tackle antimicrobial resistance. The question in front of us, though, is what more needs to be done to stimulate or accelerate the implementation of these action plans and the actions that can slow the spread of antimicrobial resistance. So in today's side event, we've got a group of global and regional leaders to help us explore 3 key questions. How can we address the bottlenecks that exist to making progress? What can we learn from the recent pandemic in terms of how we can tackle antimicrobial resistance, and what actions should we be urgently prioritizing. To help us start with today's side event, I'd like to invite Dr. Corinne Capuano, the Director of the Division of Program Management, to share some opening remarks. Dr. Capuano, the floor is yours.
Thank you very much, Martin. Honorable Dr. Vahere, Dr. Fiale, Mr. Joe Tseyong, distinguished country representative, partners, ladies and gentlemen. Good afternoon, and thank you for joining us for this side event on AMR during your busy schedule at the session of the Regional Committee. The theme of this side event is a crisis at our doorstep, act now on antimicrobial resistance to save lives. As Martin mentioned, health security and AMR is one of the thematic priorities for WHO's work with member states and partners in the Western Pacific region. There are three basic reasons why. First, antimicrobial resistance is threatening our health and our lives. It can affect anyone of any age in any country. It is conceivable that in 20 years, it could make common diseases such as pneumonia, urinary tract infections, and infections in newborns untreatable. This would turn many of today's endgame plans into endless battles against infectious diseases such as malaria and tuberculosis. The impact of AMR is already real. Recent data show that it contributes to nearly 5 million deaths a year worldwide and disproportionately affects low and middle-income countries. Second, AMR makes infection more costly to treat. It affects the productivity of patients and their caretaker through prolonged hospital stays and results in more expensive and intensive care. Professor Colling will update us shortly on the health and economic impact of AMR in the region. Third, AMR is not a one country or one area issue. Resistant pathogens spread across borders from person to person or between people and animals and from the environment. AMR severely affects human, animals, and environmental health, undermining the sustainability of food and agriculture production systems across the region. The 1.9 billion people of the Western Pacific who live in countries and areas with various levels of economic growth cannot afford to pay this price. We have made progress in these past few years. We have the framework for accelerating action to fight antimicrobial resistance in the Western Pacific, which was endorsed by the Regional Committee in 2019 to fight AMR. As of today, 21 countries in the region have endorsed national action plans. But we still have a lot of work to do. Pathogens change every day. We are losing lives by not acting quickly enough. We must work together and redouble efforts to accelerate actions against AMR to prevent this crisis at our doorstep. This side event gives us an important opportunity to look at the latest situation, including challenges and opportunities in the region, and hear from countries on their experiences and ideas and actions going forward. We look forward to the exchange of information and insights from all of you so we can speed up progress and shape a future with a sustainable system through which AMR can be effectively contained. Thank you again, and back to you, Martin.
Thank you very much, Dr. Capuano, and your opening remarks highlight a couple of points to us. The potentially terrible situation of easily treatable diseases becoming untreatable. And secondly, the statistic that you provided about almost 5 million deaths per year. That equates to one person every 6 seconds. If we just think about how many people that would mean during the course of this side event. To help us understand the potential of impact of this all, both in terms of health, but in terms of economics, I'd like to invite Professor Benjamin Cowlin next. Professor Cowlin is the co-director of the WHO Collaborating Center for Infectious Disease Epidemiology and Control at the School of Public Health of the University of Hong Kong. Professor Cowlin has been estimating the health and economic impact of antimicrobial resistance in the Western Pacific region. He joins us now virtually. Professor Cowlin, thank you very much for joining us. The floor is yours.
Oh, thank you very much. It's my pleasure to be with you today. I'm sorry I couldn't be there in person. Do you have my slides to share on the screen? Thank you. So let's go for the next slide immediately. I just start by way of background by reviewing where antimicrobial resistance comes from. This study was published in The Lancet in 2016, and I could actually speak for a long time just about this figure, about the different potential drivers of resistance. The one thing that I would add beyond this figure is that I think antimicrobial use, let alone misuse or overuse, antimicrobial use, of course, contributes to resistance, but it's the misuse or overuse of antibiotics that we are particularly concerned about. Next slide, please. The project that my colleagues and I at the University of Hong Kong have been doing in collaboration with WIPRO is to understand the potential disease burden now and into the next 10 or 11 years for situational awareness, so that we can think about what's the impact of potential interventions, and so that we can communicate the risk to you and to the public as well, and so that we can talk about resource allocation. Next slide, please. We looked in our study at the potential disease burden in terms of mortality and also in economic cost in the region. We looked at data that were available in the literature for the last 10 years, and then we tried to project ahead for 10 years. And we focus on a subset of pathogens listed on the slide here, and that's related to the GLASS program that has a specific focus on the top priority pathogens. And our geographical scope was all countries and areas in the Western Pacific region. Next slide, please. Our analytic framework was to collect the data on infections and resistance on the left-hand side here, and also mortality, and then to put that into a model that I don't have time today to describe in detail, but a model of the underlying processes resulting in mortality, also resulting in economic cost. At the bottom of this slide, we would like to include data on consumption of antibiotics over time to have some kind of forecast of how AMR might trend in the future. Unfortunately, though, there is not a lot of available data on antimicrobial use. There was relatively more data on antimicrobial resistance. So we ended up having to make some assumptions for that part. Next slide, please. In terms of the available data on resistance, there were hundreds of studies that we included. The largest number were from China, some studies from other parts of the world, but there was a lot of heterogeneity. And I think there's a long way to go to have more stable and consistent data from being reported across the region. And GLASS is going a long way to standardizing the collection of antimicrobial resistance data, but I think we have a way to go. So this just illustrates on this slide some of the data that we included. There's a lot more in the full report. Next slide, please. In terms of the impact at the top of this slide, we have the potential mortality over the next 11 years. So 2.2 million MRSA deaths would be 200,000 a year, because that's for 11 years. And in terms of the GDP loss, the big ones as well are E. coli and MRSA, with substantial potential impact. So this is a major concern for us, of course. Next slide, please. In terms of the context with the other major causes of death that we're aware of, AMR is in the mix. You can see in the middle our estimate, 23.5 deaths per 100,000. So it's not the biggest, but it's certainly not at all a small number. And that's going to be an important estimate to share with the countries and with the public as well. Thank you. Next slide. So this is my last slide. The summary is the first bullet point. We project a substantial impact from AMR on mortality and economic cost in the region over the next decade. And then the subsequent 4 bullet points on this slide are the policy implications. Firstly, we think there's a need for significant attention comparable to many of our other priority diseases in the region. The next point, although GLASS has improved surveillance in the region, we do think there's a way to go in terms of the quality of surveillance data, the stability of surveillance data, the approaches that we use, and there's a lot of room for improvement and development. And secondly, for antimicrobial usage, I mentioned earlier, there's a lack of data on antimicrobial usage, and I think that's really an urgent priority to have that data. What amount of antimicrobials of different types are being used in different parts of the region. The penultimate point, we know that investment in laboratory infrastructure is critical, but not only the laboratory infrastructure, but the data collection. And I would add that includes the epidemiological data that goes with the laboratory data. Often AMR surveillance is an activity focused in laboratories. And my view is that the epidemiological data on patients and their conditions is also a vital part of AMR surveillance. It's not just a laboratory activity. And then the final point, I hope that this side event and the council in general will continue to advocate for the need to raise awareness of AMR and the potential impact that it's having in our region. So I will end there. Thank you very much for your attention.
Thank you very much, Professor Cowlin, for joining us today and for sharing those recommendations at the end. You highlighted to us in particular the potentially vast impact of antimicrobial resistance over the next 10 years in our region, potentially 5 million excess deaths and potential cost to the region of 150 billion. To put that in context, that equates to the combined national gross domestic product in 2021 of Cambodia, Laos PDR, Mongolia, and Papua New Guinea. That's not insignificant. Sometimes numbers like that can be very large and scary. So also maybe to go back to your opening point, we can take this back to the basics. Antimicrobial resistance is a natural process. It would happen anyway, but by addressing the misuse and overuse, we can significantly delay that process, save those lives, and reduce that economic impact. To help us consider what we need to do and to prioritize, next we're going to invite Professor Dame Sally Davis, the United Kingdom Special Envoy on Antimicrobial Resistance. Dame Sally is a world-renowned advocate. She has spoken on antimicrobial resistance to the World Health Assembly, to the G7 group of nations, and to the United Nations General Assembly. She's also a member of the World Health Organization's Global Leaders Group on Antimicrobial Resistance. Because of the time difference, Dame Sally, of course, can't be with us live today, but she pre-recorded a video. We're going to play some parts of that video now, and the full version will be available on the WHO website for you to view later. So could we please play Dame Sally's video?
It is a great honour to address the 73rd session of the WHO Regional Committee meeting for the Western Pacific. I'm delighted to be here, inspired by your leadership on AMR and you convening together for today's side event, where the last 2 years have painfully demonstrated to the world what the impacts of an initially untreatable infection can be. The next 2 are going to be vital to leverage the lessons we have learned and build towards the 2024 high-level meeting on AMR. The sad truth is that AMR was increasing and not matched by political action even before the COVID-19 pandemic demonstrated what is at stake. In 2019, the Interagency Coordination Group on AMR warned that there was no time to wait to act on AMR, demanding unprecedented action from governments, researchers, civil society, and the private sector. Again, in 2020, the World Health Organization listed AMR as one of its top 10 threats facing humanity. And now, just this year, the WHO have issued a stark warning that the world is failing when it comes to access, innovation, and stewardship of antibiotics. The report by IHME earlier this year showed that there were 254,000 deaths in Oceania directly attributable to AMR, and over 1 million deaths where a death was associated with AMR. Globally, we haven't yet turned our policy and political commitments into action. I am impressed that 18 countries and territories in the Western Pacific region have developed multi-stakeholder national action plans on AMR. However, across the world, only 20% of countries are implementing and monitoring their plans, without which our global health security and the sustainability of our health systems remains at stake. As it stands, we do not know what the next pandemic will look like. It could be bacterial, drug-resistant, or as flu, dependent on antimicrobials to mitigate. At the same time, many of the interventions needed to prepare for, prevent and respond to future pandemics are similar to those needed to address AMR. We have an opportunity to now maximise the interventions and the investments that countries are making to address current, increasing and future pandemics together. Indeed, AMR is a pandemic that's happening now. 1.3 million people died directly as a result of AMR in 2019. With this new data up our sleeves, we have a more comprehensive picture of the terrifying reality of AMR. But it is up to all of us to use these numbers to galvanise local, national and global action across health ministries and far beyond. With the regional breakdowns of mortality figures, we can show the need for regions and multilateral groupings to work together. For example, the Western Pacific region of WHO, right through to G7, G20 and G77. We need both collective ownership and action. As a matter of urgency, we need to integrate AMR into the global agenda for pandemic preparedness and prevention to ensure that our mutual priority, protecting more people with efficient resource allocation, is achieved. As we work together, therefore, we need to commit to real, measured action and resources for global health. And that includes for WASH, for equitable access to medical products and timely, accurate surveillance and alerting. We then need to commit to sustaining that investment so we don't end up 20 years from now in the situation we've faced since 2020. These are all necessary regardless of the source of the outbreak. I am pleased that the WHO Western Pacific region is addressing health security and AMR as one of its 4 priorities for the period 2020 to 2025. And in doing so, that you recognise AMR is a matter of security. Antibiotics are essential infrastructure for resilient and sustainable health systems, for UHC. So we need to safeguard, steward, and also innovate for new antibiotics to meet unmet clinical needs of today and tomorrow. As we look ahead to that high-level meeting on AMR in 2024, we've all got to play our parts in building security and sustainability for human health and food and water systems. And there are 4 ways which I look to you in the WHO Western Pacific region to support this through. First, we must ensure that all global governance mechanisms recommended by the IACG are up and running as soon as possible. The momentum built by the Intergovernmental Panel on Climate has leveraged action through COP26 and the upcoming COP27. We need the establishment of the recommended independent panel on evidence for action against AMR to collate evidence for policymakers to act on. If we establish this before 2024, it'll enable us to use its findings to inform the outcomes of the meeting. Secondly, WHO regional members and organisations will have an important collaborative role to play with other UN organisations. I welcome the formal integration of UNEP into the quadripartite and encourage strengthened collaboration across the organisations with international financial institutions so your technical expertise can be more than the sum of your parts. This will help us ensure the high-level meeting reflects the stakes we all have in AMR. Next, as we look forward to the next 2 years, we need to build on upcoming events in 2023 so we advance multiple agendas and ensure AMR benefits from existing work. An example is the upcoming high-level meeting on UHC, the ones on pandemic preparedness, prevention and response, or TB and WASH, where AMR should clearly be integrated. I look forward to working with countries from across Western Pacific region to make the most of these opportunities. Finally, the WHO Western Pacific region's 5-year strategic plan commits to harnessing the power of communication to deliver better health. As part of this, I encourage you to bring in young people to become champions for action against AMR. Not that long ago, I had the privilege of meeting Eric Venant, the founder of Rollback Antimicrobial Resistance Initiative. Eric's a young pharmacist, putting his expertise to practice, raising awareness of AMR across communities and schools in Tanzania. He runs craft workshops in schools and has even put posters on tuk-tuks and educated drivers to pass on messages about AMR to their passengers. There's an opportunity to think creatively on tailored, modern messaging for the population of your region. Globally, we have a short window in which to build forward from COVID-19 with resilience, equity and security at the heart of our pandemic preparedness. AMR is an international, intergenerational, insidious pandemic, which we need to tackle at the same time. On behalf of the UK and the Global Leaders Group, I stand ready to work with you to contain and control AMR. Thank you.
We thank Dame Sally for her video recording, and I encourage participants here to take some time to view the full video. It's packed with lots of ideas and potential actions. She highlighted in particular the need to integrate our work on antimicrobial resistance into our work on pandemic preparedness, and in particular as well, the importance of strengthening partnerships and interagency, multi-sectoral working mechanisms. Now let's bring the discussion to this region and our panel here in the room. We have 3 fantastic speakers from member states who have joined us to share their leadership and experience. So if I can introduce them to you now, we have to my left over here, Dr. Maria Rosario S. Vergere, the officer in charge of the Department of Health from the Philippines. To my right, we have Dr. Siale Akaula, Chief Executive Officer from the Ministry of Health in Tonga. And on my far left, Mr. Zhou Jiong, Deputy Chief of Mission of the Embassy of the People's Republic of China in the Philippines. Thank you all for joining today's side events. I'd like, if I may, to start with Dr. Vergere. The Philippines established its Interagency Committee on Antimicrobial Resistance in 2014. Could you enlighten us on how this Interagency Committee has been working, how it works to ensure effective implementation of the National Action Plan? Have there been any challenges, and how have you been addressing them?
Thank you, Martin, and good afternoon to all of you. In 2014, the President of the Philippines passed a policy which ordered the creation of the Interagency Committee on Antimicrobial Resistance, or the ICMR. This is a multi-sectoral body consisting of government agencies representing the human health, animal health, agriculture, trade, science and technology, and the local government sectors. The ICMR facilitated the development of the Philippine National Action Plan to combat AMR 2015 to 2017. This was launched in May of 2015, which aims to provide a country roadmap towards containing, controlling, and preventing AMR in our country. It also facilitated the implementation review of the first action plan and oversaw the development of its second medium-term action plan spanning the period of 2019 to 2023. This was launched in 2018. The Department of Health of the Philippines served as a secretariat to the ICMR, specifically our pharmaceutical division. There are designated AMR coordinators in our regional offices to ensure cascading of programs and activities up to the regional and the local levels. Through the ICMR, the Philippines has engaged the increased participation of the environment and the education sectors and initiated the amendment of the policy to include these said sectors as official members of this interagency committee. The presence of these policies signed by the President served as our key driver to ensure that resource requirements shall be provided by the ICAMR member agencies to support the effective implementation of the Philippine AMR Action Plan. The country has an antimicrobial resistance surveillance program under our Research Institute for Tropical Medicine, which monitors the resistance rates of organisms in human health. The animal health sector also has ongoing efforts to strengthen their surveillance capacity in animals. The Ministry of Health also developed training modules on antimicrobial stewardship to optimize the use and the prescription of antimicrobials in our healthcare facilities. The COVID-19 pandemic catalyzed the implementation of programs to take advantage of various platforms in the digital age. Recognizing the interplay between COVID-19 and AMR, we have doubled our efforts to promote and cascade antimicrobial stewardship training through the development of online courses for our hospitals and primary care facilities with the support, of course, by WHO. To date, the Philippines has already trained 100% of all of our Level 3 hospitals, 92% of our Level 2 hospitals, and 52% of our Level 1 hospitals on antimicrobial stewardship. Overall, 67% of our licensed hospitals nationwide were already trained on AMS. Highlighting primary care at the forefront also, we have started with our primary care facilities, and to date, we have already trained 1% of our primary care facilities, and we aim to increase this number as we continue to cascade the AMR training for hospitals and primary care. The Philippines has also been actively participating in the global celebration of the World Antimicrobial Awareness Week since 2015. And during this pandemic, we took advantage of the social media platforms to expand the reach of our advocacy, and the country is currently preparing our activities for this week-long exercise this coming November. Thank you, Martin.
Thank you very much, Dr. Vehre. And I note a number of really interesting points for our discussion. First of all, you highlighted the top level from the President's leadership on this. The second, the work with regional offices to make sure that you had coordinators working on antimicrobial resistance throughout the country. And then third, taking advantage of some of the digital platforms that were developed under COVID-19 to train staff in hospitals and primary healthcare centers, real action on the ground that can make a difference. So thank you very much for sharing that. Continuing on the theme of what opportunities COVID may have brought about and how we can capitalize on them for our work on antimicrobial resistance, I'd like to turn next to Dr. Siale Akola from Tonga. Many countries are strengthening their health emergency preparedness. Can you share, Dr. Siale, how Tonga has used the process of strengthening health emergency preparedness as an opportunity to take actions to address antimicrobial resistance and your future plans in this regard, and in particular in terms of preparedness, but also health systems transformation? Dr. Siale, the floor is yours.
Thank you, moderator, Martin Taylor, and thank you for the opportunity to include Tonga in this important discussion. The COVID-19 pandemic has highlighted existing inequities and unmasked the fragility of health systems in Tonga. Therefore, leveraging lessons identified during the pandemic is needed to attain an integrated, resilient health system. For example, in addition, with other partners using One Health approach, the Ministry of Health was able to, one, to improve the laboratory infrastructure to facilitate the introduction of molecular testing and container laboratories for COVID-19 and other public health diseases surveillance. In addition, improving the laboratory capacity will contribute to the overall strengthening of the detection, reporting, and analysis of AMR as part of the pandemic preparedness and response in Tonga. Two, to coordinate training for most healthcare workers on infection prevention and control, rational use of medicines, including antimicrobials, and management of adverse events critical to both COVID-19 response and AMR interventions. 3, organize the review of the medicine regulation to ensure the safety and quality of medicines and vaccines, including antimicrobials. Lastly, the Ministry of Health, Tonga, will work with other partners to review progress of the Tonga National Multisectoral Plan on AMR, monitor and evaluate the implementation of priority AMR activities in line with current epidemiology and context. Furthermore, continue the effort made during the pandemic to ensure system strengthening across all sectors, including protecting the vulnerable population in Tonga. Thank you.
Thank you very much for that, Dr. Siale, and I can see some common themes emerging already. The second of the points that you highlighted, as with a speaker from the Philippines, was training of healthcare workers for the importance of antimicrobial resistance, but linking that with other areas of work, infection prevention control, rational use of medicines and antibiotics. You also noted the importance of laboratory strengthening the infrastructure and how the investments made in the COVID-19 response can be of benefit in the longer term for antimicrobial resistance surveillance. And I think that takes us back also to one of Professor Cowlin's points in his slides, one of his recommendations around strengthening surveillance so we know more about what is going on and we know therefore how to target our actions. Let's turn next to our third speaker from the region, Mr. Joe Juyong. Very delighted to have you with us today. As we know, China plays a vital role in the fight against antimicrobial resistance. China was the second largest consumer of antibiotics in 2010 around the world. And in the past few years, China has increased its actions to contain the use of antimicrobial resistance, both in the human and animal sectors. Mr. Zhang, could you elaborate what actions China has been taken to decrease antimicrobial resistance and what your plans are to sustain the effort and accelerate progress?
Thank you. Thank you, Mr. Taylor, for the question. Good afternoon, colleagues. It's a great pleasure to join the AMR site event today on behalf of China. Antimicrobial resistance is a common public health problem worldwide. China has a large population in a vast territory with a diverse natural environment and many types of climates. The disease spectrum, the consumption of antimicrobials, and the antimicrobial resistance patterns vary greatly from one place to another. This is further complicated by the disparities in economic and healthcare development among different areas, making it more difficult to contain antimicrobial resistance in China. The Chinese government has always attached great importance to the containment of antimicrobial resistance by putting in place a multi-sectoral collaborative mechanism involving human health, animal health, ecology and environment, science and technology at the national level. China was one of the first countries in the world to issue and implement a national action plan to curb antimicrobial resistance. China has been constantly exploring the ways to promote the rational use of antimicrobials and curb antimicrobial resistance. Over the years, China has improved laws and regulations on healthcare, drug management, biosafety, and environmental protection, established long-term systems for antimicrobial management, implemented a series of standards and norms, improved the system for testing antimicrobial use and resistance, and carried out international exchanges and cooperations. Through the joint efforts of the government, industry, and the public, China has made significant achievements in containing antimicrobial resistance with improvement in the rational use of antimicrobials. In general, the containment of antimicrobial resistance is good, and the research and development of new antimicrobials has also achieved possible positive results. As to the next steps, with the accelerated globalization, global warming, and changes in human behavior, as well as the occurrence of emergent infectious diseases such as COVID-19, it is of increasing urgency for antimicrobial resistance containment to strengthen international cooperation and exchange, strongly implement the One Health approach, form synergy, and jointly promote development. As a major consumer of antimicrobials, China will release and implement the next National Action Plan of fighting against antimicrobial resistance, make prevention of infectious disease and rational use of antimicrobials a priority task, define the different responsibilities of governments, industries, institutions, and individuals, and further improve the effectiveness of antimicrobial resistance containment work. Thank you.
Thank you very much, Mr. Joel, for those highlights from China's recent work and future plans. And I think there's a couple of points to pick up on. One, you mentioned the importance of the national action plans, multi-sectoral cooperation, and we look forward to the new national action plan that you have alerted us to. I think it's also particularly important to highlight as well, as you have just done, the importance of science and technology, the development of new antimicrobials. And we really look forward to China's really important global role in this regard and your leadership. We know that that can be extremely important as we prepare for the future. Now, let's take I think we've got time for another round of questions with our speakers to build on what we've heard, but now begin to think a little bit more precisely to the future. We've heard many different actions and suggestions for what member states, healthcare facilities, health workers, and individuals can and should be doing in their role to tackle antimicrobial resistance. Those are all important, but if we were to put the speakers on the spot and ask you what you think the top priority action would be, I think it would be interesting for us to hear from your experience where we should be focusing our efforts. So Dr. Verhey, if you don't mind, if I can turn to you first on this one, from your perspective, what do you think is the top priority action that we should be doing together right now to make some progress in terms of reducing antimicrobial resistance in our region?
Thank you, Martin. Primarily, for the Philippines, we think that strengthening and building capacity of every member state on surveillance on antimicrobial resistance for timely detection of emergence of resistant pathogens and for generation of evidence on the local burden that will drive urgent and concerted actions at the country level should be prioritized. The lack of country-specific data on the burden of drug-resistant infections possibly influences and delays the implementation of AMR policies and priority activities due to the lack of understanding and grasp of the gravity of the problem. Thus, strengthening the surveillance, infrastructure, and public health systems should be one of the top priorities of the Western Pacific Regional Office, with recognition as well that accomplishing this priority action requires the commitment and the support of top leaders to ensure allocation of sufficient human health, information, and of course, monetary resources. Simultaneously, building capacity of member states to monitor antimicrobial consumption at the national level should also be prioritized to determine critical information on prescribing or usage patterns, which would allow benchmarking and enable evaluation of the impact of antimicrobial stewardship interventions. In the long term, correlating the resistance and antimicrobial consumption patterns shall provide significant information on association between resistance rates and prescribing practices and can guide the formulation of strategies and directions to pursue in controlling the prevalence of certain resistant pathogens. In the Philippines, these are also top priorities as we plan efforts to pilot case-based surveillance of AMR while continuing to strengthen the laboratory-based surveillance to better monitor our targets of reducing the prevalence of resistance rates of certain pathogens, such as reducing by 10% multi-drug resistant Pseudomonas species infections acquired during hospitalization and obtaining a 10% reduction in the use of antibiotics in humans and animals. Establishing a national antimicrobial consumption surveillance is also in the pipeline, and we are starting by incorporating this in the antimicrobial stewardship training. Public-private collaboration and global governance in research and development, similar to what happened in COVID-19, should be another focus to ensure timely development of new antimicrobials and tools for fast detection to contain resistant pathogens and at source and to prevent further transmission. Thank you, Martin.
Thank you very much. I think that was extremely rich and insightful. And the last point that you made there picked up, of course, on what we had just heard from our representative from the People's Republic of China. But I think also it's really important to dwell for a second on the key parts of what you shared, Dr. Verhey, around essentially the strategic intelligence and knowledge, the strengthening of surveillance to better and more quickly and timely detect resistant pathogens, to be able to link that with antimicrobial prescribing practices and give us that information, that practical information, which can dictate policy and actions in member states, and need therefore to also have the antimicrobial consumption monitoring and surveillance increased and improved. And I think they're all extremely important areas, and areas actually incidentally that from our office we're very happy to work with member states on, as we can take that forward across the region. Next, if I may, Dr. Siale, the same question from your perspective. What are the top priority actions that we should all be doing and be doing right now to make a change on antimicrobial resistance in our region?
Thank you. I have a simple answer here. It's really to maintain all sectors' commitment and strengthen political will to fight AMR, to sustain funding and resources for AMR, and of course, systematically monitor and evaluate progress of each national action plan to probably implement and revise as needed for all countries and areas. That's all.
Thank you. Short, sweet, succinct, to the point. Maintain the political will, ensure that we still have sustainable funding, and then all the systematic actions that need to be taken forward. Very, very clear. Mr. Joe, may I turn to you on this question? From your perspective, what would be the top priority actions that we should all be doing together right now to change the course of antimicrobial resistance in our region?
Yes, thank you. We suggest that global collaboration be enhanced by making full use of the existing global and regional cooperative mechanisms, improving the cooperative mechanisms among human health, animal health, and environmental protection, strengthening leadership and coordination at the international level, and promoting exchanges and cooperation in all areas of antimicrobial resistance work. Thank you.
Thank you very much for that. And I think on those last couple of points that you shared, the strengthening of leadership is a critical one. I know that Dame Sally and a number of our speakers spoke about that and the importance of that in the international context, both in terms of what we do within our region, for which reason we're holding this side event, but also as our region thinks about how we contribute to and engage in that high-level event at the United Nations next year. Can I turn quickly on to our virtual participant today? Professor Cowlin, I'm not sure if you're still there at the moment. I can't see on the screen. Can our IT help us to understand if Professor Cowlin is here with us still? And would like to share a couple of reflections? Okay, I understand. I think he may have gone. In which case, let's move on. I'd like to, in drawing this to a close, thank our speakers today. Your insights from the member states and the diverse set of member states that are represented here have been fantastic. I'd like to thank Professor Cowlin and Dame Sally for their comments. From this discussion, what I'm concluding is that there is still a high level of will and concern to tackle antimicrobial resistance across our region, that we're seeing that urgency, and we're seeing a wide range of extremely important and focused actions to tackle antimicrobial resistance, from the surveillance, from the knowledge, from the will, from the systems, from the financing, down to the practical actions that are so needed to make a difference in healthcare facilities and with health workers across the region. So I think today has given me encouragement that we are on the right path. We all know we have more to do, but we are on the right path and we have a lot of the right actions already in motion. Our task is to continue to take those forwards. To close out today's session, I'd like to come back to where we started and hand the microphone back to Dr. Corinne Capuano to close the meeting and give us your reflections from this discussion. Dr. Capuano.
Thank you very much, Martin, for your competent and efficient facilitation of this side event on such an important topic. I would like to add my voice and thank all the speakers in this side event for sharing your insightful ideas, experiences, and action going forward. It is very encouraging to see efforts in countries which resulted in a decrease in usage of antimicrobials or policy and behavior change. We need to collect all these very valuable experiences and information from the countries, and we need to share them so that other countries can really benefit from this experience and don't have to start from scratch. It is also great to hear many innovative ideas from speakers about seeking sustainable financing and resources to support AMR activities. Equally important were your perspectives on using new technologies in health and agriculture sectors and cultivating champions among the younger generations to pass on modern messaging about AMR to the broader population. Many of these ideas may help address challenges and bottlenecks so we can see things moving much quicker in the right direction. As Dame Sally said, we have a short window in which to build forward from COVID-19 with resilience, equity, and security. We need to grasp this short window to ensure that AMR is incorporated into the system transformation to better prepare for future pandemics. As WHO, we are committed to continue working with you, our member states, with quadripartite partners, financial sectors, experts and champions around the world and the region, using the One Health approach to continue transforming and shaping a sustainable system to contain AMR in the region. We all have a role to play. Let's win this fight together. With this, I want to thank you all again for joining this side event, and all participants, all speakers. Thank you very much for sharing your insights, and thank you again, Martin, for facilitating this side event. Thank you very much.
Thank you and welcome back. I hope you have enjoyed the lunch break. And we will continue with item 12 on non-communicable diseases. We'll give the floor to Kiribati, followed by Singapore. Thank you.
Honorable Chair, Honorable Ministers, ladies and gentlemen, Kiribati continues to face challenges in addressing health issues related to NCDs. Comparing progress as seen through data published in the 2015 to 2016 STEPS survey with the 2004 to 2006 survey, there were no significant improvements. Kiribati is among the top 10 in the region with high smoking rates, low fruits and vegetable consumption, high physical inactivity, and overweight and obesity. Child obesity is an emerging NCD complication, and we are just embarking on a school-based survey to look at this and other issues among our young population. In relation to this, complications of NCDs are taking up the bulk of our overseas referrals at more than 70% of cases since 2016. NCD prioritized interventions in Kiribati include multi-sectoral approach for holistic planning and implementation of early preventative measures to address the main risk factors: smoking, nutrition, alcohol, and physical activity. It also includes the implementation of the PEN package for early diagnosis, treatment, and management of cases. The ongoing priorities also include healthy settings approaches, such as smoke-free public places, schools and workplaces, healthy island and village approaches, engagement with the community to lead healthy lifestyles, and enforcing NCD-related regulations to support a healthy, enabling environment for all. On behalf of the Kiribati government, I would like to acknowledge the government of New Zealand, our major donor funder, for the implementation of the NCD strategic plan in Kiribati, WHO and SPC for their technical support, and not forgetting UNICEF, DFAT, and other development partners for their continuous support. With these few highlights of our ongoing work to combat NCDs, I would like to confirm the support of the Kiribati government to the Regional Action Framework for NCD Prevention and Control in the Western Pacific. Korapa, and thank you.
Thank you, Kiribati. Singapore, you have the floor, followed by Palau.
Thank you, Dr. Chairperson. Singapore supports the Regional Action Framework for Non-Communicable Disease Prevention and Control in the Western Pacific. In particular, we wish to contribute 3 examples where Singapore's NCD strategy reflects the principles of the framework. First, NCD prevention and control is imperative for sustainable development and requires greater investment. Singapore has recently rolled out a preventive care strategy called Healthier SG. To get this off the ground and running, the Singapore government is committed to spend more than 1 billion Singapore dollars over the next few years. This is a worthwhile investment as we foresee that Singapore's total healthcare spending could rise by 3-fold in another 10 years to about $60 billion a year. Second, the shift in focus from absence of sickness to health and well-being. Healthier SG is a fundamental reorientation and reform where we pair residents with family doctors and tap on their long-lasting relationships to encourage regular health screening and good lifestyle habits, creating and sustaining health-enabling environments that will promote healthy behaviors and improve early prevention, detection, and treatment of non-communicable diseases. Third, strengthened efforts are required at community and individual levels. At the population level, our health promotion agency has partnered manufacturers to reformulate sugar-sweetened beverages and introduced mandatory nutrition labels called NutriGrade to empower citizens to make informed dietary decisions. This is strengthened by our individual level efforts to nudge citizens to form healthy behaviors through gamification, such as engaging in daily tasks of hitting at least 10,000 daily steps in order to exchange for healthy lifestyle rewards. This is done via Healthy 365, a mobile application which seamlessly pairs with fitness tracking devices to log individual daily step count and time spent on exercises. We look forward to learning from the experiences of other member states. Thank you.
Thank you, Singapore. Palau, you have the floor, followed by Vietnam.
Good afternoon, Honorable Chair. Thank you for the opportunity. Palau certainly echoes all that has been highlighted by distinguished colleagues thus far with regards to the issues we continue to face in addressing NCDs in our respective jurisdictions, as well as in the wider Pacific region. We, like many of our neighboring island states, have had to redirect much of our limited resources, personnel, and national focus over the past 2.5 years towards the COVID-19 pandemic, which has exacerbated existing challenges and issues we have in dealing with the NCD crisis. However, as we learn to live with COVID-19 and move on with it, we continue to seek all opportunities to enhance our plans, strategies, and interventions to minimize the burden and onset of NCDs in Palau. With the generous assistance and support of our partners, including WHO, the US CDC, Japan, Australia, New Zealand, the Republic of China, Taiwan, among others, we are looking to strengthen our efforts to address NCDs, including scaling up our clinical capabilities and capacity by procuring our first ever MRI system this year. We hope to also improve our telehealth capacity, as well as explore the feasibility of establishing an oncology unit in our only hospital in Palau. These projects will not only reduce the cost of us sending patients abroad for medical referral, but more importantly, it will allow us to provide immediate, affordable, and effective care for our NCD patients. Similarly, we also believe that while we continue to enhance diagnostics and clinical management of NCDs in Palau, we are also looking to strengthen our work in primary care, health promotion and protection, and disease prevention. In the coming months, we plan to establish a national health improvement framework initiative that would include the redesigning and redeployment of a more robust and holistic approach to the prevention of NCD morbidity and mortality. As the NCD component of this initiative will be guided by and aligns with the draft Regional Action Framework for NCD Prevention and Control in the Western Pacific region, Palau therefore fully supports and endorses the proposed framework, which we believe will assist all of us in sustaining and further enhancing our efforts against NCDs in the region. Thank you, Honorable Chair.
Thank you, Palau. Vietnam, you have the floor, followed by France. Thank you.
Thank you, Chair. Vietnam highly appreciates the efforts of WHO Regional Office for developing the Regional Action Framework for NCD in the Western Pacific. It will place an important guidance for member states to develop and implement the action plan on NCD prevention and control at country level. Vietnam endorses and recommends the endorsement of the Regional Action Framework in the Western Pacific. To implement the NCD national strategy, the Prime Minister of Vietnam has signed the decision to approve the National Action Plan for Prevention and Control of NCD and Mental Disorder for the period 2022-2025. On risk factors control, in 2022, the Prime Minister of Vietnam has approved the National Strategy on Nutrition, identifying the important measures to manage and reduce the consumption of salt, as well as control overweight and obesity among the population. Vietnam is also in the process of developing national plan on prevention and control of alcohol and national strategy on prevention and control of tobacco to 2030. To strengthen NCD screening and management, the NCD services at primary healthcare have been expanding nationwide in the objective to get 95% of commune health stations providing services for prevention and management of key NCDs by the end of 2025. And for NCD surveillance, Vietnam has completed the second round STEP surveys in 2021 to provide data for monitoring and evaluation of the national NCD targets and indicators. Thank you, Chair.
Thank you, Vietnam. France, you have the floor, followed by Hong Kong, China. Thank you.
Merci, Monsieur le Président.
Thank you, Chair. I would like to give everybody a minute to put on your headsets and receivers. So France wishes to thank the regional office for the work done in preparing this action framework. France recognizes that strategies for the prevention and control of non-communicable diseases are based on a vision of health driven by data and its processing, artificial intelligence, the prospects of genomics-based personalized medicine, and the implementation of standardized preventive strategies. However, the reference to health promotion could be strengthened, especially on the notion of health decision-making. France recognizes equally that reference is made to drug strategies for the validated treatments of risk factors, but believes that these should be complemented by behavioral component. In addition, we sometimes note confusion between advice and management of behavioral factors for lifestyle modification and lifestyle changes, and that obscures the importance of ad hoc resources within the health system. Thank you very much for your attention.
Thank you, France. Hong Kong, China, followed by the Solomon Islands.
Thank you, Chairman. Hong Kong, China commenced the effort of the regional office for the Western Pacific, taking a leadership role in the fight against NCD. And we'll be pleased to join other member states to endorse the regional action framework for NCD. As one of the most rapid aging society in the world, Hong Kong, China anticipate that the burden imposed to NCD will likely be pleasant. In 2018, we launched an action plan to prevention and control NCD in Hong Kong, which defines local targets adopted from global targets advocated by WHO with a view to reducing the NCD burden in Hong Kong by 2025. The targets include reduction of premature death as a result of NCD, reduction of bothersome risk factors, and strengthening of the healthcare system to enhance management of NCD. We adopt a setting-based approach in organizing various health promotion events to promote healthy eating and physical activities, such as campaign targeting schools to provide healthy lunch and snacks for students, campaigns that enlisting support of restaurants to provide healthy dishes, and organized walking challenge to promote exercise targeting adults in workplace. We are aware of the emergence of alternative smoking products, such as e-cigarettes and heated tobacco products, has posed new health risks and challenges. In response, we have the Smoking Public Health Amendment Ordinance 2021, which has been implemented since April this year to prohibit totally the importation, promotion, manufacture, sale, and possession for commercial purpose of alternative smoking products. Moving forward, we will embark on initiatives towards tobacco endgame. While considering the pressing need to strengthen our healthcare system in view of the aging population, Hong Kong, China has conducted a comprehensive review on the planning of primary healthcare services and governance framework to formulate a blueprint of primary healthcare development. Under the blueprint, the district health centers acting like a hub are providing district-based multidisciplinary service to people at all ages with different health needs, from health promotion, risk factor modification, to prevention by screening and clinical management of chronic illness with integrated care team. To conclude, Hong Kong, China will continue to put our priority in NCD prevention and control. We look forward to work closely with the regional office in sharing experience with other countries and areas on NCD prevention and control. Thank you.
Thank you, Hong Kong, China, Solomon Islands, the floor is yours, followed by Papua New Guinea. Thank you.
Good afternoon, Chair, and thank you for the opportunity. Solomon Islands, like other Pacific Island countries, is undergoing the epidemiological transition with the double burden of both non-communicable and communicable diseases. Non-communicable disease is increasing at an alarming rate. About 75% of the populations are dying of NCDs based on data from the demographic survey of 2015. Based on our clinical data, NCD accounts for 84% of admissions at the National Referral Hospital and leading cause of death of our citizens, at least 6 deaths per day, as compared to 1 death each due to heart attack, stroke, type 2 diabetes, and cancer. Unhealthy lifestyles such as tobacco use, unhealthy diet, physical activity, and harmful use of alcohol and bitter chewing are some of the high-risk factors and causes of NCDs-related conditions in the country. The Solomon Islands, through the Ministry of Health and Medical Services and other government ministries, are implementing the multi-sectoral National NCD Strategic Plan 2019-2023. Addressing NCD is a top priority of the new National Health Strategy 2022-2031, and hence the NCD Strategic Plan 2019-2023 will be reviewed and updated to align to the new National Health Strategy Plan 2022-2031 and the role delineation policy, increasing focus of the monitoring evaluation on frontline health worker practices. In addition to these priority areas, the country also recognized the value of using churches and community as key NCD partners with MOUs established with the major churches and faith-based organizations in the country. We also recognize NCD screening and NCD referral at community level, linking with our Solomon Island package of essential non-communicable disease program package that is being rolled out in all our health facilities. NCD poses a major challenge to the country, and as noted in the Pacific Health Ministers meeting 10 years ago in Honiara, health ministers in the region declare NCD at a crisis point. We must strengthen and re-strategize our efforts, giving the same level of commitment, response mechanisms, and resources as we have shown during the COVID-19 pandemic to tackle NCD. We therefore welcome and endorse the Regional Action Framework for Non-Communicable Disease Prevention and Control in the Western Pacific as a guide to member states where non-communicable diseases remain a threat to the respective countries. Thank you, Chair.
Thank you, Solomon Island. Papua New Guinea, the floor is yours. Thank you.
Thank you, Chair. Honorable Ministers, ladies and gentlemen, Plenary acknowledges the presentation from the WHO Regional Office on the Regional Framework on NCD. Further acknowledge comments from those that have commented before me on what they are doing in their countries. Papua New Guinea recognizes the importance of the experiences and innovations shared by colleagues from different member states in this meeting. NCD is a growing concern in PNG. Lifestyle-associated diseases are increasing, and we are keen to ensure our people take care of their own health. PNG has revised and updated its tobacco control legislation and commenced its implementation. One of our key interventions is to collect fees and certain percentage of taxes to fund health promotion program. We are in discussions within government to ensure the taxes are collected. We are optimistic in that we have prioritized NCD in the National Health Plan 2021 to 2030 that cuts across all key result areas, but it's prioritized under KRA 1 and KRA 4 of our new health plan. This includes spend extra efforts on raising more health promotion and awareness to increase community knowledge on NCD prevention in the population. We value the experiences shared by the member states, including the continued support from WHO Regional Office in advancing NCD prevention and control, and endorse the NCD framework. Thank you, Chair.
Thank you, Papua New Guinea. Are there any more representatives who wish to speak on this topic? If not, I understand that the following non-state actors have submitted a video statement to the committee on this agenda item.
I'm Linian Wong, member of the IPA Strategic Advisory Group on Excellent Health, to deliver the message on urgent actions needed for the alarming rise of child obesity during the COVID pandemic. Child obesity is a major health concern globally, with 158 million children aged 5 to 19 years living with obesity in 2019. Child obesity has been exacerbated exponentially during the COVID-19 pandemic, mainly related to the lockdowns, school closures, home confinement, and social restrictions, which has disrupted the daily routines of children and changed their eating behaviors, physical activity, sleep habit, and screen time. The COVID-19 pandemic had changed drastically in the food environment and also increased the level of food insecurity. Such challenges are greater among disadvantaged families and those in low to medium income countries. The negative impact of child obesity on physical, mental, self-esteem, and social well-being has jeopardizing the health of children. It will also lead to chronic illnesses in adulthood, such as hypertension, type 2 diabetes, cardiovascular diseases, and other non-communicable diseases. All these will increase the medical and social burdens of the community. So it is now the time for global communities to have urgent and decisive actions, including effective interventions, preventive strategies, and long-term policy to fight against child obesity. IPA will work closely with WHO and other stakeholders to support pediatricians, healthcare professionals, and parents to reduce child obesity, with the mission of serving every child, every age, and everywhere.
The next two videos will be from McCabe Center for Law and Cancer and Healthy Philippines Alliance. Thank you.
Hi, I'm Hayley Jones, Director of the McCabe Centre for Law and Cancer in Australia, and I'm excited to join you today for this important discussion on non-communicable disease prevention and control. Last month, the McCabe Centre was honoured to be redesignated as a WHO Collaborating Centre on Law and Non-Communicable Disease, and we are excited to continue working with WHO colleagues and member states across the region. And there is much for us to do. We are alarmed that only 3 countries in the region are on track to reduce premature mortality from NCDs by 1/3 by 2030. So we welcome the Regional Action Framework for Non-Communicable Disease Prevention and Control in the Western Pacific to counter and reverse the growing burden of NCDs. We note the framework's focus on health equity and Objective 2, which calls for policies that go beyond the health sector to enable health-promoting environments to address the social determinants of health. We note also the 2050 strategy for the Blue Pacific continent endorsed by Pacific leaders at the Forum meeting in July and its commitment to secure the well-being of Pacific people through people-centred development. We firmly believe that law and regulation are crucial to addressing the NCD epidemic. Laws are an enabler for commitments in the UN Sustainable Development Goals, the WHO Framework Convention on Tobacco Control, the WHO Global Action Plan on NCDs, including the Best Buys. Laws can reduce the chance of people getting sick, protect patient rights, and help ensure that health systems work for people living with NCDs. We encourage member states to operationalise the Regional Action Framework, including by using law to prevent NCDs and assist those affected, and we are here to support you to do so. We recently delivered our 3rd online course on using law for NCD prevention and control. We welcomed 81 motivated delegates, noting large groups from Fiji and the Philippines, as well as from Brunei, Vanuatu, and Papua New Guinea. We encourage all member states to invest in NCD prevention and control and leave no one behind.
I am Ralph Emerson de Golacion of the Healthy Philippines Alliance, and I am speaking on behalf of the NCD Alliance in the Western Pacific region. I will be providing our statement under agenda item number 12 on NCD disease prevention and control. The Healthy Philippine Alliance applauds the draft action framework's alignment with the 2030 Agenda for Sustainable Development. However, the progress seems bleak in the region as only 3 countries are likely to meet the SDG target number 3.4. To accelerate the progress of achieving NCD-related global targets, the HPA urges the member states to officially endorse the draft regional action framework on NCDs and highlight the importance of the following items. On guiding principles. First, consistent with the principle of no one left behind, we urge that statements related to the most marginalized sectors such as indigenous peoples, internally displaced peoples, persons with disabilities, and those with diverse gender identities be included in this section. Second, on the empowerment of individuals. It must be emphasized to include patients, their families, and communities, and policies and programs need to be responsive to their issues and concerns. Third, the level of engagement or participation with communities, patients, and families, and marginalized must be meaningful and go beyond tokenism. Fourth, the promotion of good governance through transparency and accountability mechanisms should also be evident. On future trends, aging, NCDs affect everyone. Therefore, adult-centric intervention should expand to include the entire life course, especially the adolescents and older persons. On innovation, in using technology, it is best to ensure its accessibility through infrastructure setup, proper guidelines for use, and appropriate training and complementation of healthcare workers. Certain services are best done by actual healthcare workers than artificial intelligence as patient coaches. The HPA also supports the need to develop the electronic health and medical record systems and scaling up of telehealth platforms. On objectives, concentrate implementing policies to enable a health-promoting environment. Concentrate on effectively addressing the social and commercial determinants of health. The actions identified under this objective will require political leadership from the highest level to ensure coordination across government ministries and policy coherence. The prioritization of policies must be based on population's needs, and focus must be on promoting healthy environments and on behavior change interventions. On integrating NCD prevention and control in primary healthcare, the HPA recommends the Health in All policies be integrated in policies and programs which may potentially aggravate the problem and burden of NCDs within the health system. This include policies or programs on climate change, extractive industries, conflicts, and emergencies. Thank you.
Thank you very much. All written and video statements from non-state actors and observers on this agenda item will be uploaded to the RCM webpage, as statements reflect solely the views of the NCOs concerned. It follows that statements do not necessarily reflect the views of WHOs, including its member states and secretariat. May I now call on Dr. Jacob and Dr. Hiro to respond to the points that have been made. Thank you.
Thank you very much, Chair, for giving us the floor. I will start with some high-level comments, and then Dr. Hiro Gayasu will continue. So first of all, let me thank you for this very rich discussion and sharing your national experience. It is obvious that a lot is on their way, and this work now has to be accelerated to improve health outcomes and also to move from a disease-centric to a health-centric approach. And this regional framework will definitely help, and we would like to thank you for your support. What I would like to point out is that I'm extremely encouraged by this discussion today, particularly by your political commitment for NCD prevention and control, and also for your commitment to strengthen the governance mechanism in your countries, and also your commitment towards a paradigm shift for prevention and health promotion and other essential public health functions throughout the life course. Thank you. Which clearly has to cover also, and we have to cover also the whole spectrum of NCD prevention and control, from prevention and health promotion through detection, treatment, monitoring, and follow-up. And therefore, the integration with the health systems and particularly integration at the level of primary health care and community-based care is absolutely vital. And it is so encouraging to hear from you that you will and you are already embarking on intersectoral whole of government, whole of society approaches. You are implementing many of the best buys which are ready for implementation. You are also very keen to address the broader determinants of health, including both the social, the environmental, but also the commercial determinants. And then the use of the new innovative and digital solutions will be key. And of course, this is a huge agenda which definitely needs your political leadership and commitment. And therefore, we keep it on the agenda of the regional committees and also globally in the Executive Board and World Health Assembly. And then, as you may recall, in 2025, we have to report back also to the UN General Assembly, particularly on the implementation on the voluntary target on NCDs. And what I would like to point out as my last point is that what Vanuatu has raised to share the success stories and the positive examples is a very good way forward, and particularly on innovations and actions. And New Zealand highlighted that we have to move towards a holistic view of well-being. I think if we can bring these two things together to share experiences in this regard, and then bring in innovations and move towards a holistic view of well-being, that will definitely help us to cover the NCD agenda and to make progress in the years to come. So with this, through you, Chair, we are ready to hand it over to the colleague, Dr. Hiro Ogayasu.
Thank you very much, Mr. Chair, and thank you very much, DDG. And from the Secretariat, on behalf of two divisions of healthy populations and then Division of Health Disease Control, I sincerely thank all member states for your excellent comments and then support of the regional framework on NCD prevention and control in the Western Pacific. As DDG has indicated, it is really encouraging to hear that all member states acknowledge that NCDs are an urgent issue threatening sustainable development, especially in the context of disruption of NCD work during the COVID-19. It is also encouraging to learn that member states also made significant actions and progress to combat NCDs, including the development of a multi-sectoral national NCD plans in Brunei, China, Kiribati, Laos PDR, Marshall Islands, Malaysia, Palau, Philippines, Solomon Islands, Tonga, and Vietnam, and the implementation of evidence-based policies such as Best Buy mentioned by Mongolia, Samoa, Tuvalu, and then PEN mentioned by Kiribati, Laos, Samoa, and Solomon Islands. And Australia, Cook Islands, New Zealand, Republic Korea, and United States of America emphasize the importance of policy development based on scientific evidence and surveillance, including vulnerable populations. Establishment of Pacific Monitoring Alliance for NCD Action, MANA, is another great example of improving monitoring across countries. With this background, I'd like to point out the following key themes in member states' intervention. First of all, as pointed out by the DG in his opening remarks in the beginning of this conference, we need to address the root causes of NCD to stop the surge. Many member states gave excellent examples of addressing these root causes, including the availability of fresh food in Kiribati, 1 Billion Steps campaign in Brunei, regulating unhealthy food in Papua New Guinea and then Tuvalu, and addressing injuries and violence in FSM, and then 100% indoor smoke-free environment in Mongolia, law to prohibit alternative smoking products in Hong Kong, China, and gender-based violence in, I mentioned this. And then federal states of Micronesia and PNG. And then Philippines introduced a comprehensive health promotion framework strategy to improve health literacy and behavioral changes. Second, countries should engage sectors beyond health As the minister in Malaysia indicated in C4H session, and then DGG mentioned in opening statement, NCD risk is primarily driven by the factors outside the health sector. Kiribati, Solomon Islands, Tonga, and Tuvalu highlighted the need to enhance partnership across the society. And President's initiative on alcohol control Mongolia and multi-sectoral NCD task force in Vanuatu and Tonga are good examples. Since the NCD risk profile varies significantly by the individual and community, effective community engagement are very important. Examples include collaboration with faith-based organizations for NCD in Solomon Islands, the holistic approach advocated by New Zealand, setting-based health promotion, including schools and workplace in Japan, FSM, Hong Kong, China, Kiribati, and Philippines, and healthy villages mentioned by Samoa, and then community-based NCD screening in Japan, Laos, Malaysia, Mongolia. And New Zealand also engaged the community volunteer to co-create the NCD strategy. Some members mentioned the use of technological and social innovations to address NCD challenges. In previous session, we have reviewed the innovative approaches for behavioral changes in Australia, China, Fiji, and Malaysia. And France also mentioned today the health promotion for behavioral change is very important. On technological innovation, Japan supports the mobile phone-based smoke cessation program. Singapore mentioned the use of fitness devices, and Brunei mentioned screening and monitoring of risk factors with the Blue Health application. As a last point, I'd like to point out the importance of a systems approach in addition to addressing individual risk factors and diseases. Many member states, including Hong Kong, China, Malaysia, Samoa, Singapore, Republic of Korea, and Vanuatu, pointed out that we need to transform six systems in which unhealthy environment create NCD cases, and then health sector primarily focusing on treating diseases, into health systems with health enabling environments that enables, an individual health and wellness, and health systems supporting people's health throughout their lives. Finally, we acknowledge that several member states have asked WHO for continued support. WHO Secretariat will continue to work with other UN agencies and partners to support member states to realize this framework. As member states, including New Zealand, Tonga, USA, and Vanuatu mentioned, we should work together to identify and share lessons so that we can more effectively address this common problem together. Again, thank you very much for all your intervention and endorsement of the framework. Now I'd like to invite Dr. Naoko Yamamoto, the Assistant Director General of UHC Healthier Populations, WHO headquarters, to provide additional perspective. Over to you, Dr. Yamamoto.
Thank you, Hiro, and thank you, DDG, and Mr. Chairperson, and distinguished representatives. I echo DDG's or Director Hiro to thank Member States for their comments and guidance regarding the draft Regional Action Framework for NCDs, Prevention and Control in the Western Pacific. Member States state that NCD is one of the biggest public health and development challenges in their countries and in this region. This is true in all regions. This action framework will be fundamental to improve current situation and achieve voluntary global targets and SDGs. We appreciate Member States for their strong support to the action framework, which is a testimony of their prioritization to NCDs. Indeed, to raise the priority of the prevention and control of NCD is number one objectives of the WHO Global Action Plan on NCD. Member States emphasize the importance of the health promotion and prevention. As Hiro said, that health promotion and to address root causes of ill health is the DG Tedros, the first priority of the next 5 years. Prevention contributes to health and well-being of people, achieve UHC, and create more sustainable and fairer society. Member States also underlines the importance of screening, early detection, and treatment of NCD. We experience the disruption health services because of COVID-19 crisis. Solid, supportive NCD treatment based on strong universal primary health care. It's so important for people living with NCD and all. In the intervention, Member States and partners pointed out key elements to implement this action framework. I don't necessarily to repeat all. So Member State intervention help to crystallize WHO programs and concretize our next steps. WHO will accelerate our efforts at the country, regional, and global levels to ensure that UPRO action framework and global action plan achieve the objectives. And these will be reflected to the preparation toward the fourth high-level meeting on the prevention and control of NCDs in 2025. So thank you again for your guidance and support. And let me say that I also enjoy the Pacific mobility or exercising in this early in the morning in Geneva. But thank you very much to give us opportunity. My headquarter colleagues also join this session. Thank you very much. Back to Chairperson.
Thank you, Secretariat. And definitely we will have the Pacific mobility after tea break. If there are no further comments, may I request the rapporteurs to draft an appropriate resolution. That concludes our consideration of this agenda item. Thank you very much. We now move to agenda item 13, primary healthcare, document WPR RC73/9. May I invite Dr. Jacob, TDG and WIPRO OIC to introduce this item. Thank you.
Chairperson, distinguished representatives, I'm very pleased to present to you for your consideration the document WPR/RC73/9 on primary health care. Primary health care is an essential foundation for building resilient health systems and making progress towards universal health coverage. Member states in the region have made good progress in improving health outcomes for maternal and child health, as well as for many infectious diseases. But many challenges persist. The burden of non-communicable diseases, which we just discussed, will continue to rise as many countries face rapidly aging populations. There are still population groups that cannot get appropriate health services due to cost or location. Others are pushed into financial hardship because of health expenses, including the cost of medicines. These challenges, combined with continued fiscal pressure on economies and the rising cost of care, threaten to make health systems financially unsustainable within the next decade. Over the past 2 years, the COVID-19 pandemic has re-emphasized the importance of empowering communities to participate effectively in health decisions and as part of caregiving. All these factors point to the need for a fresh approach to primary health care that promotes the greatest level of health and well-being throughout the life course. This approach integrates all health programs into primary health care and uses innovation to drive improvements in access and quality. It is much broader than simply focusing on curing diseases. It can respond to changing population health needs and make healthcare more equitable. The draft regional framework draws from and builds on the reflections of member states at the panel discussion on primary health care at the previous session of the regional committee. It outlines what is needed for primary healthcare systems in the future, as well as the key areas of action for member states to consider in planning primary healthcare reforms. The draft regional framework also provides a platform to deliver more effectively on the other frameworks being presented to the regional committee this week, in particular the frameworks on NCDs, reaching the unreached, and mental health. The regional committee is invited to consider the endorsement of the draft regional framework on the future of primary health care in the Western Pacific. The Secretariat would like to show a short video on this agenda item. Thank you.
A rapidly aging population and increases in non-communicable diseases are challenging health systems in the Western Pacific region. Distance, cost, availability, and concern about quality are keeping people from accessing primary health care. A new approach to primary health care is needed, including a shift from disease-based to patient-centered primary health care, where people play an active role in managing their health. The regional framework on the future of primary health care in the Western Pacific outlines actions countries can take to help people maintain well-being and achieve the highest possible quality of life for the longest time possible. These include investing in stronger primary healthcare services which provide affordable, high-quality care close to where people live, strengthening the primary healthcare workforce, and the use of digital technologies to bring care closer to communities. Primary healthcare of the future ensures that all people should get quality primary healthcare services when they need them right in their community.
Thank you, Dr. Jacob. We will now hear from representatives who wish to speak on this item. Please press the button on your microphone, even if your flag is raised. You need to press the button in order to be included in the automatically generated list. Otherwise, we need to keep two lists, and it is difficult to know the order hands were raised. If you are in the plenary or by using the raise hand function on Zoom. Thank you. So Tonga, you have the floor, followed by China. Thank you.
Thank you. The Honorable Chairman, Your Excellencies, ladies and gentlemen, Tonga would like to endorse the regional framework for future of primary health care in the Western Pacific. As a small island developing state, Tonga is number 3 in the list of the most vulnerable country in the world to natural disasters. It is expected to be exacerbated by climate change. Our geographical isolation has added another dimension that will challenge any government in Tonga. In spite of these challenges, we try to deliver effective primary health care using a people-centered approach based on a plan developed through multi-sector consultation. A health plan that will deliver high-quality, integrated healthcare, innovative, and most importantly to us, that is resilient to be able to absorb the shocks that will come our way in future. Just to share a few initiatives that Tonga has developed to guide our actions. We have a package of essential healthcare services plan, which serves as our roadmap to achieving universal health coverage for all, with everyone achieving improvements in health at no financial burden. This package covers the continuum of care expected to be delivered to everyone, including at remote areas, ranging from health promotion, health prevention, curative rehabilitation, and palliative care. They will be delivered at both hospitals, community health centers, and at the maternal child health clinics settings. In addition, we are also in final stages of approving our safe and affordable surgery, obstetrics, and anesthesia care action plan to guide our actions to ensure everyone in the country has easy access to safe and affordable surgery. Our package, of course, include strong upstream health promotion actions to focus on health determinants of health at the non-health sectors. Lastly, I just wish to confirm an innovation approach that we are working with government to develop a WASH project proposal for the outer islands. Short-term impact, of course, will be on environmental health. However, we are also aware that this can have economic benefit in future if these communities can achieve some kind of accreditation status to be recognized as homestays for visitors, giving some economic sustainability to these rural areas. I'm sure, ladies and gentlemen, a lot of you haven't spent your weekend on a tiny island that you can walk around in less than 1 hour. It is a lovely experience indeed. Thank you, Honorable Chair.
Thank you, Tonga. China, you have the floor, followed by Mongolia.
Thank you, Mr. Chair. China supports the draft regional framework on the future of primary healthcare in the Western Pacific, which has highlighted the basic principles in the Declaration of Alma-Ata and Declaration of Astana and put forward the vision of the region. We have 3 points to make. First, we need to improve the workforce development of the general practitioners, providing services to the elderly, pregnant women, those suffering NCDs, and people with disabilities. They should be our focus to improve the accessibility and affordability of primary healthcare. Besides, we need to improve the grassroots level health governance capacity building so that the grassroots health institutions can play a bigger role in providing primary healthcare in organization, coordination, and mobilization, so that the efficiency and effectiveness of primary healthcare can be improved. Second, we must ensure the sustainability of the health system, clarify the roles played by the government in primary healthcare, in particular in the funding raising, so as to improve the financial investment in the poverty-stricken areas and the vulnerable population. Third, we should improve the infrastructure development of primary healthcare health providers and standardize their facilities and services so that their service capacity can be further advanced. In particular, we need to gradually shift to health-centered approach and reorient towards the people-centered primary healthcare. Children, the elderly, pregnant women, and people suffering from NCDs should be the priority of our intervention, for whom we should provide health education, healthy lifestyle intervention, and health services provision so that the health literacy of these people can be further stepped up. Thank you, Mr. Chair.
Thank you, China. Mongolia, you have the floor, followed by Micronesia.
Thank you, Mr. Chairperson. The government of Mongolia continues to be committed to strengthening primary health care to address the growing double burden of communicable and non-communicable disease. This includes the implementation of prevention, early detection, diagnosis, and management, and continuum of care from primary health care to referral care level to combat the rising burden of NCDs and CDs to meet the needs of the population, especially of the most vulnerable populations, including low-income and unregistered people, as well as herders residing in hard-to-reach remote areas. While responding to the pandemic, my government has taken major health reforms and initiatives in the healthcare sector, including decentralization of healthcare services, prioritization of preventive health examination, the use of innovative technologies, strengthening e-health system, introduction of strategic purchasing and performance-based financing to further increase access and improve the quality of healthcare. These reforms are in line with Mongolia's long-term development agenda, Vision 2050. As part of the reform, in August 2020, the Parliament amended several legislations, including the Law on Health, Law on State Budget, and the Law on Health Insurance. The aim of this reform is to strengthen and enhance the purchasing power of the pool to purchase services more strategically towards improving efficiency and equity. Furthermore, the national and local governments have recognized the importance and cost effectiveness of reaching out to remote and disadvantaged populations to provide people-centered integrated PHC services using mobile technologies, along with the use of essential medical equipment and rapid tests. Good partnerships and strong multi-sectoral relationships with various stakeholders have also contributed to the delivery of more people-centered integrated primary healthcare services. For instance, since 2016, mHealth initiative at the primary health care level has been significantly expanded to 70% of the total 536 PHC facilities in my country. To further support its commitment to PHC and the overall healthcare sector reform, the government announced an annual national screening program on the prevention, early detection, tests, diagnosis, and common communicable and non-communicable disease. Mr. Chair, guided by the for the future vision of the Western Pacific region and the WHO operational framework for primary healthcare, Mongolia is confident that the current draft regional framework on the future of primary healthcare in the Western Pacific will complement these reform measures and will bring significant progress in the health sector and beyond, and will advance our progress towards achieving universal health coverage. I thank you for your attention.
Thank you, Mongolia. Micronesia, you have the floor, followed by Australia.
Thank you, Mr. Chair. Again, FSM supports and endorses the draft regional framework on the future of primary healthcare in the Western Pacific. FSM also recognizes that access to essential health services remains highly inequitable within and across countries. But we should not give up, and WHO should continue to provide technical assistance in translating evidence and science of primary healthcare for country implementation. The COVID-19 pandemic brought out the weakness and strength of our entire health systems, demonstrating that it really takes the whole of society to be successful in our public health endeavors. As a region, we have made some gains in ensuring essential services are extended and sustained in the hard to reach and rural communities. Sustaining these gains are important, and the WHO and donor partners can play important role. Finally, health equity and equality remain important considerations in every step of the way of primary healthcare development, particularly with respect to the health needs of vulnerable groups such as girls, persons with disability, and aged persons. Thank you, Mr. Chair.
Thank you, Micronesia. Australia, you have the floor, followed by Singapore. Thank you.
Thank you, Chair. Firstly, let me thank the Secretariat for its work on the regional framework and your kind accommodation of comments from Australia provided recently, which focus on the importance of sexual and reproductive health services as part of primary health care. COVID-19 highlighted the importance of building and maintaining robust, resilient, and sustainable health systems centred on primary health care. These systems should be designed to adapt and effectively respond in times of increased demand and evolving population needs, while also maintaining core functions and service delivery. We all must invest more and better on primary health care to avoid backsliding on pre-COVID-19 health gains. Accelerating efforts to realign primary healthcare financing is critical. In Australia, a $2.9 billion package will drive an innovative revamp of our primary healthcare system, Australia's health system is founded on the principles of universal health coverage through the provision of universal access to quality services supported by Medicare, the Pharmaceutical Benefits Scheme and the aged care system. We are supportive of the framework and recognise primary health care as the cornerstone of a sustainable health system for universal health coverage. This includes access to essential services such as promotive, preventative, curative, rehabilitative services and palliative care. This also includes sexual and reproductive health services. The framework should directly reference the breadth of services and care provided under primary health care, as reflected in the recent Astana Declaration. Australia welcomes the set of strategic actions in the framework and its people and community-centred approach. We emphasise the importance of efforts being adapted to country context, as well as aligning and integrating these efforts with existing country-led efforts to strengthen primary health care and achieve universal health coverage. We note the distinct needs of small island developing states, especially those with sparsely located populations, can experience high transaction costs, diminished access to accessible, equitable and affordable health services. We encourage WHO to ensure provision of appropriate in-country support to these member states to implement the framework. We look forward to continuing this important work with the region, as well as working across region to ensure high-level meetings on universal health coverage in 2023 strengthens political commitment to primary health care. Thank you.
Thank you, Australia. Singapore, you have the floor, followed by Republic of Korea. Thank you.
Thank you, Mr. Chairperson. Singapore supports the draft regional framework on the future of primary health care in the Western Pacific to build strong and resilient health systems in the region. Aging populations and rising incidences of non-communicable diseases are among the pressing public health challenges that our Western Pacific region face. Now, to respond to evolving population health needs better, we need to move away from a disease-based health system to achieve quality health outcomes while balancing financial sustainability and resource optimization. To achieve this, Singapore has recently published a white paper on our new population health strategy, which we call Healthier SG, SG for Singapore. And a key part of Healthier SG involves a major mobilization and transformation of our primary healthcare system. Now, allow me to contribute 3 points from the white paper. First, we acknowledge that primary care is the first line of care in the community. It is also a key part of our push to achieve universal health coverage. Primary care providers must be involved and engaged in any meaningful impact on health outcomes. Now, 80% of Singapore's primary care providers consist of private providers across our island, all of whom will be incentivized to work with the government on Healthier SG through the enrollment of patients and to take care of their enrolled patients through the life course. Second, the provision of holistic, preventive, and personalized care for patients is non-negotiable. And as part of Healthier SG enrollment, family doctors are required to develop customized health plans for their patients. These include lifestyle adjustments and regular checkups. Enrolled patients, in turn, will get free annual checkups and nationally recommended vaccinations. Third, partnerships are key to delivering integrated and patient-centered care. Our healthcare clusters will partner with private primary care providers within their geographical region to enhance care delivery through better coordination and strengthen clinical capabilities of GPs across the sector. Primary care practitioners will also need to be aware of community assets and work with community partners to help them take care of their patients' non-medical needs better. Now, as Singapore embarks on our Healthier SG journey, we had taken reference from the experiences of other WIPRO member states, and we look forward to the continued sharing of experiences and learning from fellow member states as we shape a healthier Western Pacific region together. Thank you, Mr. Chair.
Thank you, Singapore. Republic of Korea, you have the floor, followed by New Zealand.
Thank you, Chair. For the last 2 decades, the Western Pacific region has made considerable progress, such as increased life expectancy and decreased infant mortality rate. However, we are concerned that over the same period, burden of chronic disease and health disparities have been exacerbated within and across countries. As regional framework suggests, we expect that equitable primary healthcare services play a critical role in preventing NCDs and reducing health disparities. In this regard, Korea would like to express our support for the regional framework. 5 strategic actions outlined in the regional framework is essential to achieving high quality and effective primary health care. And building on this, we have to make enormous efforts toward achieving UHC while improving access to preventive health care for NCDs and strengthening financial support. Korea has so far implemented diverse pilot programs aiming to strengthen people-centered PHC at community level. Among them is the NCD management program, which offers integrated care from local clinics for people with NCDs such as hypertension and diabetes. With a team-based approach, we developed a team composed of a doctor and care coordinator and established individual treatment plans. And we also provided regular check on conditions such as blood pressure, blood sugar level, and lifestyle improvement. Additionally, we intended to create a comprehensive NCD management system via session and counseling tailored to each patient's needs. With the goal of achieving UHC, Korea has developed strategies to support and utilize limited healthcare resources efficiently. It covers reshaping incentive systems to promote essential health services, including severe emergency care, fostering, securing, and supporting essential healthcare workforces, as well as building partnership and collaboration systems. Korea also implemented the integrated community care program, which provides integrated services of housing, healthcare, long-term care, and community care for older adults and people with disabilities to continue to live in their own community. Especially home healthcare and health management services are available for people struggling to visit healthcare facilities in person. Finally, sharing and developing success stories of among member states will help establish successful PHC architecture in response to NCD burden and aging population. We look forward to sharing and discussing experiences continuously. Thank you.
Thank you, Korea. New Zealand, please speak slowly for interpreter. You have the floor, followed by Japan. Thank you.
Malo, Mr. Chair. Tēnā koutou katoa. Aotearoa New Zealand welcomes and endorses the draft regional framework on primary healthcare in the Western Pacific, which is well aligned with the rationale behind recent domestic reform to our health and disability system and our goal of achieving pai ora, healthy futures for all. Comprehensive primary healthcare is an important vehicle to reduce the burden of disease through better prevention and a stronger focus on population health. Every year, our primary care sector fields over 20 million consults or other encounters, each session an opportunity to identify health conditions and initiate interventions. In the past, our health and disability system was fragmented. This led to inconsistency of care and practice, as well as a postcode lottery, which meant that where you lived affected the care you could access. Our new system has been designed to enable a whole-of-country view to planning and delivering healthcare services. A healthcare system that is nationally planned, regionally delivered, and locally tailored will address things such as burgeoning surgical waiting lists. Most importantly, it means that when it comes to health services, where a person lives matters less than what they need. As noted previously, under this new model, primary healthcare will be delivered via localities, which are mechanisms for organising health and social services to meet the needs identified by whānau, communities, and mana whenua, local tribes. As outlined in the framework, our new approach to primary healthcare must respond to the changing health needs of populations and increase their participation in their own health. Each locality across Aotearoa New Zealand will have integrated primary healthcare services who partner with community provider networks to ensure a strong, no wrong door approach. This will create opportunities for early detection and response to health issues, as well as increased wraparound support to combat broader social, cultural, financial, and environmental determinants of health. Chair, we wholeheartedly support the framework's emphasis on stronger community engagement, particularly Indigenous populations and other underserved groups in society. We support their involvement in planning, developing, and delivering policies and services. Our reformed health system strengthens the role of Indigenous Māori in all aspects of health and health services, strengthening local primary and community care services that are culturally safe and accessible for Māori communities will ultimately improve poor health outcomes for Māori, as well as being better for everyone. We know that a health system that does better for Māori does better for us all. Aotearoa New Zealand looks forward to learning how our fellow member states are implementing this framework to ensure our region can deliver optimal health outcomes for everyone. Ngā mihi nui. Thank you.
Thank you, New Zealand. Japan, you have the floor, followed by Philippines. Thank you.
Thank you, Mr. Chair. The changing environment, including aging, urbanization, and climate change, makes it more difficult to achieve the provision of people-centered prevention and treatment envisaged by PHC. The draft strategic framework has a renewed focus to tackle these challenges, and for that reason, Japan supports the draft framework. Although primary health care covers a wide range of areas, it is necessary for member states to go beyond the conceptual discussions and to present concrete action plans, including the efficient use of limited resources. We would also like to emphasize the importance of incorporating multi-sectoral data into the monitoring and evaluation system. We are mindful that the community level is at the heart of the best and wide-ranging functions required by this framework. However, it has very limited resources and is often in a weak position in policy making. WHO and the member states should ensure that policy directions do not seek to place additional burdens on the community level alone, but achieve the appropriate country-wide health system strengthening and increase investment in health. To increase the budget for primary health care, we needed to demonstrate cost effectiveness. We would like WHO to set clear PHC indicators and evaluate guidelines. We would also like to see WHO to promote initiatives that enable diagnosis, treatment, and care to be completed within the community through the use of innovative ICT and transport systems. I thank you, Mr. Chair.
Thank you, Japan. Philippines, the floor is yours. Thank you.
Thank you, Mr. Chair. The Philippines fully supports the draft regional framework on the future of primary health care in the Western Pacific and concurs with the strategies and recommended actions laid out to achieve comprehensive, continuous, and high-quality primary health care. The development of this framework is a particularly opportune time for the country as it reaffirms the direction set forth in our Universal Health Care Act, passed in 2019 and currently being operationalized. While the prevailing health crisis brought about by the COVID-19 pandemic had stalled the country's efforts, the Philippines sought to capitalize on the investments during the pandemic towards fostering a health-literate populace, health-promoting communities, school and workplaces, and high-quality and effective primary care system. To enable this, the country has prioritized development of guidelines and tools to enable frontline healthcare providers to provide evidence-based, cost-effective interventions. Our 2040 Health Facility Development Plan seeks to close the gap in primary care facilities. Appropriately, all of these are undertaken alongside the strengthening of institutions and human resources
for health through capacitation, scholarships, and curriculum changes. The Philippine Health Insurance Corporation has updated and will continue to enhance its primary care package to quickly expand access, but also to shift supply-side investments by local governments and the private sector from hospitals to primary care facilities. In refocusing towards primary health care, a shift in the mindset from a program-based to a people-centered system-strengthening approach is critical to shape policy and operations, including how development partner assistance is provided. Thus, it is critical for WHO to help lead the way in this transition, a step we deem critical in mainstreaming primary health care. Much remains to be done in order to achieve people-centered, comprehensive, continuous, and high-quality primary health care. The Philippines is one with the vision of the WHO and its member states and partners to make the Western Pacific the world's healthiest and safest region. Thank you, Chair.
Thank you, Philippines. Ministers, Excellencies, let's take a 30 minutes coffee break. We'll continue after the coffee break, and we'll start exactly at 3:45. Thank you. Thank you and welcome back. We'll continue with item 13, primary health care. And we will continue with the intervention. Cambodia, you have the floor, followed by Vietnam. Thank you.
Thank you, Honorable Chair, Honorable Ministers, distinguished delegates, ladies and gentlemen. Cambodia highly appreciates the WHO Western Pacific regions for the development of the regional framework on primary health care, which provides the potential planning tool of transforming health system to promote better health and wellness throughout the life course. Cambodia shares many of health burden and risks as highlighted in the draft regional frameworks. Those include burden of disease, notably NCD, and remaining unfinished agenda that must be addressed, such as tuberculosis and hepatitis, as well as child stunting and wasting. PHC has been called to Cambodian health system for decades. We released all the PHC policy and PHC guidelines to support the policy implementation back in year 2000. Cambodia is now further re-emphasizing the focus on the PHCs as the foundation for UHC. Our next health strategic plan placed PHC as one of the 5 key strategic shifts. In the coming months, in collaboration with the WHO and the other partners, the Ministry of Health will finalize the framework to boost PHC, while the larger health system projects, namely health equity and quality improvement project, co-financed by the government and the World Bank with a grant from the government of Australia, Federal Republic of Germany, Republic of Korea, and the Global Financing Facility. The project come to the second phase and emphasis on the PHC to address NCD and increase financial risk protection. Across this initiative, our intervention focus mainly on strengthening engagement between the PHC facility and community, including through health center management committee and within health support group. Second, restructuring our primary health care level minimum package of activity to promote integrated care over the life course. Third, financing that incentivize appropriate use of the PHC and referral, continuous quality improvement, and early detection of primary and priority NCD. Finally, using of the innovation, including digital technology, such as electronic medical record, to promote continuous integrated care. Cambodia look forward to further information and knowledge sharing, as well as good practices on the PHC across the region. And we fully support the draft of the Western Pacific region PHC framework. I thank the Chair.
Thank you, Cambodia. Vietnam, you have the floor, followed by Vanuatu.
Mr. Chair, we agree with the report that success in highlighting public health challenges, the requirement for shifting primary health care from disease-based continuous interaction with individuals throughout the life course. We needed a new model for primary health care. Vietnam's support for the draft regional framework on the future of primary health care in the Western Pacific. Having a strong and resilient health system oriented toward primary health care is an important policy objective in the national health policy strategy and plans of Vietnam. Vietnam aims to revitalize the grassroots health system with the district health system, including commune level, to become the strong foundation for primary health care. More specifically, this entails strengthening the organization and management of the district health system, changing the service delivery model with emphasis on disease prevention and health promotion beyond the curative care. reforming the provider payment system to support quality primary healthcare services, and developing a competent health workforce to meet the changing healthcare needs. Incorporating current private primary care providers into grassroots district health services delivery network is also needed. The Ministry of Health also accelerate the introduction of new approach by applying the digital technology in health service delivery, called telehealth program, to provide technical support for primary care health facilities. Implementing primary health care is not only responsibility of the health sector. It requires the engagement of all related stakeholders and multi-sectorial actions. Therefore, Vietnam kindly requests WHO to continue supporting member states technically and financially to implement the framework. Thank you very much.
Thank you, Vietnam. Vanuatu, you have the floor, followed by United States of America. Thank you.
Thank you. Thank you, Chair, and good afternoon. Vanuatu appreciates the work done by the WHO Secretariat in developing the regional framework on the future of primary healthcare in the Western Pacific region. The background information for this framework is a guiding tool to revisit how government National Sustainable Development Plan, including the health sector strategy, with a key focus to strengthen primary health care to attaining universal health coverage. Chair, the COVID-19 pandemic has stressed the need for a strong primary health care system with coordination that goes beyond the health sector in Vanuatu. A special attention on how this could be better reflected into our existing plans. Therefore, Vanuatu calls for technical and financial assistance for betterment, alignment of the framework with the existing government policies from our partners. We believe very much on access to essential health services close to where people live and work as our country of 83 islands. And the challenge we face is the cost of communication and transportation to reach the unreached population. Therefore, the need to identify approaches to design better strategies to provide the essential health services is most welcomed. Chair, in the same context, we wish to inform you of our new approach. The Ministry of Health, partnering with the Ministry of Internal Affairs and the Department of Local Authority, which governs provincial governments of the country, with objectives to strengthen primary healthcare program and assist on health planning. The approach is likely to replicate to all provinces in the country. And for this, Vanuatu will put forward as the most likely relevant approach in welcoming the strategy framework on the future of primary healthcare in our country. Chair, with a new regional framework of the future of primary healthcare in the Western Pacific, Vanuatu is seeking WHO's technical assistance for the following priorities. One is to strengthen the capacity for the provincial health authorities in the management and supervisory roles for the primary care facilities. Secondly is to improve access to quality essential health services for remote and unreached populations by implementing integrated outreach services at the provincial level. Thirdly, implement the strengthening of primary health care program in the province from 2022 to 2023 as a pilot and aiming to scale up nationwide. And lastly is to develop the Vanuatu Primary Healthcare Strategy Action Plan for 2023 to 2030 as a high-level national framework. Chair, in concluding our intervention, we confirm our endorsement for the regional strategic framework on the future of primary healthcare in the Western Pacific region. Faftai, and thank you.
Thank you, Vanuatu. United States of America, you have the floor, followed by Brunei. Thank you.
Thank you, Mr. Chair, distinguished delegates.
the United States thanks the Secretariat for the regional framework on the future of primary health care in Western Pacific. We appreciate the consultative process to develop the framework. This pandemic has made it clear to all of us the core need for strong and resilient health systems, why universal health coverage is an essential element of preparedness and response to pandemics, and why primary health care is the foundation for success. PHC is critical to building and sustaining community trust in public health and in healthcare to meet the daily needs of everyone in our communities. This must include specific health needs for women, children, and adolescents, including but not limited to services for sexual and reproductive health and immunizations. It must also include healthcare and services for LGBTQI+ persons as well, and health systems that respects them and their health needs free of stigma and discrimination. And we know that health systems anchored by a strong health workforce contribute to improvements in life expectancy and increase countries' capacity to respond to outbreaks and health emergencies. The health workforce is key to advancing delivery of primary health care, and that is well coordinated and integrated. We welcome this regional framework and look forward to working together on revitalization efforts to optimize and further integrate primary care services to meet the health needs of each person at every stage of life while strengthening countries' health systems and workforces.
Thank you, United States of America. Brunei, you have the floor, followed by Malaysia. Thank you.
Thank you, Honorable Chair. Brunei Darussalam commend WHO for the commitments and preparations of the regional framework on the future of primary care in the Western Pacific region. Brunei Darussalam reaffirms our commitment to strengthen our primary healthcare system in achieving universal health coverage as reflected in the Ministry of Health strategic plan goal of excellence in healthcare service by assuring the provision of universal health coverage, ensuring accessible and equitable healthcare to all, as well as strengthening primary care in the country. The COVID-19 pandemic has demonstrated that a strong and flexible primary healthcare system is an essential component of a nation's pandemic preparedness and response, especially at the height of the pandemic outbreak and now in the prolonged post-pandemic period. Prioritization of all health services, conversion of health centers into dedicated flu clinics, swab centers, and vaccination centers were some of the actions taken, while at the same time ensuring the continuity of care of patients, especially those who are frail with multiple chronic non-communicable diseases, where the use of telemedicine has shown to be a very necessary resource. Other resources, including human resource, equipment, PPEs, and medicines were pooled nationally. The pandemic has also expedited Brunei Darussalam's plan towards a one-platform digital health for the public and private healthcare providers. A platform called the Mini-HIS platform had been utilized by some of our private healthcare providers, where information essential for the best care of the patients, including access to medical record and the reporting of infectious diseases, amongst others, are available. The Bru Health apps used initially for the surveillance of COVID-19 patients in our effort to curb the spread of the disease has expanded exponentially towards the inclusion of patients on medical record, pharmacy component, health information, and the ability to book doctor's appointment in primary health care, which is accessibility for the population. Despite the difficulties faced during the past 2 years, Brunei Darussalam has managed to maintain the high vaccination rates through our expanded program of vaccinations for the children aged 0 to 5. The high COVID vaccination rate up to the third dose is also a concerted effort by a whole nation approach. Vaccination teams for COVID-19 has been deployed to reach the rural areas and the vulnerable groups in the country. Additionally, primary health care focuses on quality improvement activities, promotive and preventative care, standard operating procedures, clinical guidelines, and at the same time, made efforts to link with the private healthcare providers. However, we also realize that further research is needed to support, understand, and improve the extent of strengthening primary healthcare in Brunei Darussalam. The National Health Screening Program for screening to detect and prevent non-communicable diseases has unfortunately been affected during the outbreak. This program has now been restarted with some planned improvements for ease of access for all. Finally, Brunei Darussalam would like to reiterate our gratitude for WHO for the continuous support extended to us. We remain fully committed to working towards the strengthening of primary health care. Brunei Darussalam therefore fully supports the regional framework on the future of primary care in the Western Pacific region. Thank you, Chair.
Thank you, Pranay. Malaysia, you have the floor, followed by Cook Islands. Thank you.
Thank you, Mr. Chair. In Malaysia, primary healthcare has remained remarkably stable over the past 5 decades, while the broader context has changed dramatically, including an aging population, growing disease burden, rising healthcare costs, rapid socioeconomic transition, and changing patients' expectations. The unprecedented COVID-19 pandemic has stretched the health system beyond capacity. This disruption cascaded into structured change via coordination at the national level, involving mobilization of human resources, capacity building and training of health personnel, emergency measures to procure necessary equipment and consumables, application of digitalization in delivering health services, and a robust national vaccination rollout strategy. Forging a solid public-private partnership was essential in mitigating the effects of the pandemic. Besides maintaining existing services at health clinics, these partnerships include sampling COVID-19 specimens, home monitoring of asymptomatic or mildly symptomatic COVID-19 positive cases, and scaling up vaccination activities, including outreach for rural and remote areas, virtual clinics, virtual health advisories, and online employment system institutions. In Malaysia, a digital application called as MySejahtera was developed to store vaccination records and evolve to contact tracing, quarantine, isolation measures, and also for health monitoring. Malaysia is now repurposing this application as a platform for population-based screening. And these measures will in turn pave the pathway to lasting community, interministerial and intersectoral collaboration on all levels, from better addressing the social determinants of health to adequate coverage and quality of care across a spectrum from wellness to illness. Many countries are under-resourced for the prevention and control of NCDs, even before the pandemic. The most crucial challenge is the shift in mindset from sick care to healthcare and wellness, which is essential in achieving better population health. Hence, improving access, affordability, and equity in providing healthcare through decentralization of services is one of the keys to providing diagnostic and therapeutic care nearer to the community level, which is under primary health care. For example, screening and intervention of mental health conditions are now available in public health clinics and through the Plenary initiative, community-based mental health services to improve outreach and reintegration of people with mental illness into society, as well as a platform to promote early detection of mental illness and treatment and rehabilitation. Consequently, policies and programs planned and implemented would need to be sustainable to impact health and well-being significantly. Therefore, periodic evaluation and improvement and continuous engagement with various stakeholders, including social, cultural, political, private, and academia, are necessary to achieve the best outcome. On that note, Malaysia is pleased to support the endorsement of the draft regional framework on the future of primary healthcare in the Western Pacific. Thank you.
Thank you, Malaysia. Cook Islands, you have the floor, followed by Samoa. Thank you.
Kia orana Chair, kia orana ko tātou katoa. COVID-19 have caused us to review and change how our primary care services better accommodate the screening, triaging, and consultation of symptomatic COVID patients at the same time undertaking business as usual, services to attend to NCD and patients with other underlying conditions. Moving primary care into the village community and in home care management required health workers to be more innovative and agile. Appropriate models to respond effectively to both COVID and other health conditions called for the exploration for a more resilient future models and systems capable to respond to future potential pandemic outbreaks like COVID-19, simultaneously with business as usual primary care services. The development of this draft regional framework on the future of primary care in our region is commended, as this will guide the development of fit-for-purpose models for our primary care hospitals in our countries. We have just spoken about the draft NCD regional framework this morning, which most of these health conditions is examined at primary care. The Cook Islands would like to acknowledge the support of the ADB Bank with some minor infrastructure extensions to our existing primary health care center to allow extra consultation rooms for NCD and mental health services that is expected to start next month. Chair, the Cook Islands is also at the final stage of its funding submissions to the Green Climate Fund. If successful, will enable us to further strengthen our primary health care centers on our other 12 inhabited islands to be more resilient and to withstand future potential climate change threats. Again, the model for these primary health care centers will have to be tailored to the context of the island, the health risks they face, and its population. Therefore, Chair, the Cook Islands supports the endorsement of the draft regional framework on the future of primary care for the Western Pacific region. Metaki.
Thank you, Cook Islands. Samoa, you have the floor, followed by Lao PTR. Thank you.
Thank you, Chair. Samoa remains committed to the importance of primary health care as it is essential for strengthening of health systems. The Alma Ata Declaration highlights the main principles for primary health care that is a guiding tool for our country. This is further reflected in the Healthy Islands vision in the Anuta Declaration, where children are nurtured in body and mind, environment invite learning and leisure, people work and age with dignity, ecological balance is a source of pride, and oceans which sustain us is protected. Samoa highlights from the report the importance of primary health care being people and community centered. We believe addressing challenges at the grassroots is vital, and working with our communities is central to allow robust systems in health to work. Samoa wants to encourage a primary health system that not only focuses on the ill, but encourages health and well-being. This will assist with our current non-communicable disease burden, where resources are focused on treatment and care, and there is the need to push the primary health care to address the increasing NCD burden and emergence of infectious disease of public health importance, including neglected tropical diseases. The COVID-19 pandemic has brought us many lessons on how it has impacted essential health services and the need to have good systems in place at the community level to maintain quality health care. We find that a sustainable primary health care system also requires good financial resourcing, which is a challenge today with the effects of the pandemic in our economic systems. However, we are hopeful that implementing primary health care that provides access for all will ensure that no one is left behind. It is important that we recognize the key agents to build primary health care that focuses on population health and well-being. With this being said, Samoa acknowledges and recommends endorsement of the regional framework on the future of primary health care in the Pacific. Thank you, Chair.
Thank you, Samoa. Lao PDR, you have the floor, followed by Papua New Guinea.
Distinguished chairs and honorable ministers, dear delegates. In a landlocked nation with mountainous areas, remote locations, and a low population density like Lao PDR, primary healthcare is essential. As a result, I'm happy to report the governance frameworks to drive our primary healthcare agendas have been strengthened. The health sector reform strategies of Laos place primary healthcare at the heart of effort to achieve universal health coverage. Our PSC policy was updated in 2019 to reflect recommendations from the previous year's global conference on PSC and provide a clear set of priorities. A law is currently being drafted to facilitate the implementation of these policies. COVID-19 provided us with unique opportunities to strengthen PSC through multi-sector collaborations. The health sector was able to forge stronger partnerships with local authorities to enhance community engagements, expand local governance and prioritization for health, and boost trust in health services through an innovative approach that we can connect, means community network engagement for essential healthcare and COVID-19 response through trust. Similarly, there is ongoing work to clearly define the responsibilities of village health volunteers and option them to provide a more holistic service delivery approach rather than a program-based approach, and strengthen governance and finance for sustainability. On the financing side, we have taken a bold step towards strengthening PSC operation levers like workforce, infrastructures, and availability of medicines at the primary healthcare levels via resource-based financing instruments supported by donors. There is a balance at the national level by health financing strategies that clearly prioritize strengthening PSC amidst economic challenge and donor transitions, and better use of data to redesign health services delivery with a focus on sustainability, people-centered, and reaching the hard to reach. In many of these initiatives, WHO remain a long-trusted partners in advancing the PSC agenda in Lao PDR. We believe that the development of the draft regional framework on the futures of PSC in the Western Pacific is timely and provide clear policy directions on primary healthcare to advance USC in these regions. We support the endorsement of it. Thank you, Mr. Chair.
Thank you, Lao PDR. Papua New Guinea, you have the floor, followed by Hong Kong, China. Thank you.
Thank you, Chair, for giving Papua New Guinea the opportunity to make comments on this important roadmap on primary health care in the Western Pacific region. Papua New Guinea recognizes the importance of primary health care and acknowledges the ongoing work on the regional office in coordinating it. Papua New Guinea supports the regional efforts on primary health care as it is an important pillar of sustainable development. In order for us to achieve universal health coverage and mitigate social determinants of health, it's crucial we work together as a region and learn from each other. Papua New Guinea has huge challenges in developing primary health care due to the geographical disparities across the country, where most of our people choose to live in rural areas attached to their traditional and cultural heritage in 22 provinces and 118 18 districts in the country. We now have a new government that came into power in July 2022 and has challenged the health system to provide primary health care to our people within 1 hour of walk, by car, by boat, or by air through our 22 provincial health authorities and nearly 3,000 health facilities in the country. Despite of the challenges faced, we have prioritized primary health care in our new national plan 2021 to 2030 under key result area 1 and 4, and we are committed to improving our primary health care facilities and services, especially in maternal, child health, nutrition, family planning, water and sanitation, health promotion, NCD, and communicable prevention strategies, including partnership with our local communities and churches for them to take ownership at individual and community levels. We also plan in this new national plan to introduce a lowest level of a public health worker called village health assistants to promote preventive and promotive health care or public health in every village and extend primary health care under the new national health plan. PNG values the experiences shared by the member states, including the continued support from WHO regional office in advancing the primary health care programs in the region and also in Papua New Guinea. Thank you, Chair.
Thank you, Papua New Guinea. Hong Kong, China, you have the floor, followed by Solomon Islands.
Thank you, Mr. Chair. Hong Kong, China appreciate the work of Western Pacific Region Office and fully support the regional framework on primary health care. Hong Kong's healthcare system provides extensive healthcare service, including a low-cost public health care safety net that ensures no one in Hong Kong is denied medical care due to lack of means. As highlighted in the regional framework, primary health care is the most equitable, efficient, and effective strategy to enhance health and maintain the well-being of population. Hong Kong, China will revamp our local healthcare system with the aim to shift the emphasis from currently treatment-oriented, hospital-based structure to a prevention-focused, community-based healthcare system by investing additional resources to promote primary health care. We will publish the primary healthcare bulletin within this year, with district health centers as a hub for coordinating primary healthcare service for our people. We will partner with the private healthcare sector to promote the concept of primary doctor for all, and collaborate with various healthcare professions to provide comprehensive, sustainable, and people-centric primary healthcare service in the community. Among other initiatives, Hong Kong, China is going to first establish the Primary Healthcare Authority for coordinating and governance of primary healthcare service provision across public and private sectors. It will also be responsible for setting standards and devising quality assurance mechanisms. Second, to better utilize multidisciplinary healthcare services, including amendment of legislation to facilitate direct access of patients to service provided by physiotherapists, occupational therapists, referring doctors referral. Third, we'll set up a working group on the development of dental care service to review the existing service and to advise the government on enhancing the service group and delivery model. The COVID-19 pandemic has presented exceptional challenge to public health authority around the world, which highlight the importance of a strong district-based primary healthcare system. The primary healthcare blueprint I just mentioned will lay down a strategic roadmap for the future development of primary healthcare in Hong Kong, transforming it from treatment-oriented to a prevention-focused, integrated community health system. Thank you, Chairman.
Thank you, Hong Kong, China. Solomon Islands, you have the floor, followed by Palau. Thank you.
Thank you, Honorable Chair and Honorable Delegates. The Solomon Islands health system is largely primary healthcare based with more than 300 primary healthcare clinics. With the exception of our National Referral Hospital, all other provincial hospitals are to some extent still offering primarily type healthcare services to our rural communities.
Access to adequate healthcare services in our rural communities remains a major challenge. Our clinics are often manned by 1 or 2 nurses, and this contributes to high rates of clinic closures when clinic staff is sick or attend trainings. Lack of basic staff accommodation in the rural areas is one of the main reasons why many staff posted to rural clinics often end up working in the hospitals or urban centers. Unfortunately, most donors partners shy away from funding residential facilities for health workers. We believe staff accommodation should be considered a critical component of health infrastructure in settings where there are no houses that government could rent. Hence, donors should be willing to fund if that is government priority. Our commitment to enhancing primary health care is embodied in the role delineation policy. It calls for investment in upgrading of primary health facilities to cater for the expansion of services, such as basic diagnostic facilities and access to medical and dental care. This will reduce the need for referral to our provincial hospitals or the National Referral Hospital. It will also reduce preventable deaths through early diagnosis, treatment, and referral. Since the adoption of the role delineation policy, 4 area health centers are using standard designs. At least 6 of our area health centers have medical officers on duty stations, 2 with dental officers, and we expect other health graduates to join these officers in due course. Some view the role delineation policy as an expensive policy to implement. We, however, see it as an investment in quality health care and a vehicle to achieve universal health coverage. We therefore welcome the regional framework on the future of primary health care in the Western Pacific as a guide to member states where primary health care remains the backbone of their health system. I thank you, Chair.
Thank you, Solomon Islands. Palau, you have the floor.
Thank you, and good afternoon once again, Honorable Chair. As we were aptly reminded earlier this week by the Director General, emphasizing the importance of primary health care, the Republic of Palau further recognizes that primary health care is essentially the first responder of the healthcare system, and if strengthened and prioritized, would allow for more cost-effective and streamlined management and delivery of subsequent acute and tertiary care. Earlier this year, the Palau Ministry of Health and Human Services underwent major organization restructuring to realign policies, plans, financing, and personnel with the aim to enhance primary healthcare services, as well as alleviate the financial and human resource challenges and burdens on our only hospital in Palau. Additionally, we are undertaking efforts to further decentralize and integrate primary healthcare and human services to deliver more comprehensive and accessible services to our communities and especially to the unreached. We hope that with these initiatives, along with efforts to strengthen collaboration and interaction with our partners and stakeholders within and external of the health space, we will facilitate the improvement of primary health care in Palau. And while Palau endorses the draft regional framework on the future of PHC in the Western Pacific, supporting its scope and emphasis on several strategic actions, more is needed for us to achieve our primary healthcare objectives, including fostering a paradigm shift in our communities, as well as within our institutions with the way we think of, define, and operate our health systems. This means attempting to redistribute financing, focus, priority, and policy realignment towards primary and preventive health, while promoting a more ecological and holistic approach to health and wellness. Thank you, Honorable Chair.
Thank you, Palau. Are there any more representatives who wish to speak on this topic? If not, I understand that the following non-state actors have submitted a video statement to the committee on this agenda item. International Association for Hospital and Palliative Care, and International Council of Churches. Secretariat, please play the video. Thank you.
I am Adjunct Clinical Professor Leroy William, past President of the Australian and New Zealand Society of Palliative Medicine, and a life member of the International Association for Hospice and Palliative Care, a non-state actor in this Western Pacific region meeting. Continuing the advocacy for relief from serious health-related suffering, we welcome the robust inclusion of palliative care as part of the spectrum of primary healthcare. The focus on treating ill health and maintaining well-being is integral to primary care and further supported by the early introduction of palliative care, for example, at the diagnosis of serious illness. The principles of whole person care unite palliative and primary healthcare as psychological, social, and spiritual care occurs predominantly in the community. However, the effective integration of palliative care skills into primary healthcare requires 1, undergraduate and postgraduate training of the health workforce, 2, adequate access to internationally controlled essential medicines on the WHO model list, including the palliative care medicines in Part 2C, and utilizing the learning project of the International Narcotics Control Board to assess need. 3, the adoption of the WHO essential package of palliative care interventions, medicines, equipment, human resources, and intersectoral supports designed to minimize costs. 4, collaboration with regional and national associations of palliative care professionals on regulations, evaluation, and indicators for palliative integration into primary healthcare, assistance with healthcare worker training, and appropriate estimates for essential palliative care medicines. As a former GP, I recognize the importance for people to be cared for in their households and communities as much as possible. Subsequently, I support the IAHPC's recommendations and encourage member states to take action in the ongoing challenge to relieve unnecessary serious health-related suffering from our countries. Thank you.
Honourable Chair, distinguished delegates, thank you for the opportunity to speak on behalf of the International Council of Nurses. ICN recognises that the healthcare workforce is under pressure, particularly in primary healthcare. The shortage in nursing workforce is particularly concerning. In addition, we believe that the workforce is not being used to its potential. There is a widening gap between the needs of the healthcare and the education systems producing the health professional workforce. As such, ICN is calling on member states to commit to developing regional and national action plans related to building and supporting the primary healthcare professional workforce. Commit to investing and implementing the WHO Global Strategic Directions for Nursing and Midwifery. Commit to integrated and team-based primary healthcare to deliver effective and comprehensive care. Develop and build the advanced practice nursing workforce to improve access to primary healthcare. Support and invest in chief nursing officer positions across all countries and within WHO Western Pacific region. These recommendations will improve access to quality, safe, and affordable primary healthcare that is able to meet surge demand as the need arises. We look forward to working with you on this important program.
Thank you very much. All written and video statements from non-state actors and observers on this agenda item will be uploaded to the RCM webpage. As statements reflect solely the views of the NGOs concerned, it follows that statements do not necessarily reflect the views of the WHO, including its member state and secretariat. May I now call on Mr. Taylor to respond to the points that has been made. Thank you.
Thank you very much, Chair. And I begin by thanking all the honourable delegates, both for your wonderful comments today, but also your extremely active engagement in the consultation process to develop this framework. It was much appreciated. So to recap some of the key points from this conversation today, I think we've heard very clear endorsement of why this framework is needed in terms of the challenges of the future, the burdens of non-communicable diseases, aging populations, and also recognition that from COVID-19 era, primary healthcare was so vital for maintaining essential health services. We've heard from many of you about the need for reorienting health systems to both promoting health, a kind of paradigm shift, and health systems that are people-centered. Most recently, of course, just in the last few minutes, Palau commented on that. Other member states have done as well. We heard about primary healthcare needing to be and should be at the core of healthcare systems for the future. Singapore was strong on that, Australia, Lao PDR, and many others. Also, many of you made the connections between this framework and other frameworks that are in front of you this week: non-communicable diseases, reaching the unreached, and mental health. A note in particular, Malaysia commented on the importance of those connections. When we turn to some of the elements within the framework and your comments on those, I think we heard a strong endorsement of the objectives within the framework, both in terms of their importance, but also in terms of ongoing support from the Secretariat to member states. In particular, I would highlight, we heard frequently and time and again, the importance of community engagement and engaging individuals in their health. Many member states commented on this. Kiribati, I noted, Samoa, New Zealand in particular in terms of indigenous populations and their health. Philippines commented on schools and workplaces as other areas for community engagement. Papua New Guinea on churches. So I think there was a very strong and clear articulation around that area. We heard many, many comments on the importance of finance, both in terms of increasing finance, but also in terms of how it is used. Issues around performance-based payments and provider payments from Mongolia and Vietnam, issues around incentives from Korea and Japan, Cambodia as well on financial protection and inclusion. Finance was key. We heard many speak about health workforce issues, but I think the only one I will highlight here now in particular was from the Solomon Islands, just in those last few comments, around the importance of incentives for primary healthcare workers, especially in remote and rural areas. Many of you spoke about the importance of developing locally appropriate service delivery models, in particular at the subnational level, provinces and districts, models that will be fit for populations in those locations. Cook Islands, Vanuatu, Lao PDR, all, I think, mentioned this, as did many others. A number of you also spoke about issues which are not in the framework as one of the 5 objectives, but which are in there as thematic areas. We heard many comments around the importance of innovation, digital health, telehealth, and noting many of the lessons that had come from the COVID experience, which were now going into longer-term primary healthcare. I heard in particular on that Brunei and Tonga, Cambodia, and others. Finally, I think that many of the member states noted about the importance of this framework in terms of issues of equity, vulnerable populations, children, women, aging populations, LGBTQI, and the importance of primary healthcare for reaching all of those populations, and in doing so also including sexual reproductive health within that. I noted in particular Australia, US, FSM, Cambodia on many of those points around equity and specific populations. There's a huge richness there that we will take account of as we work with you, member states, in terms of taking this framework forward. With regards to that, I noted a number of key areas where there were requests for the Secretariat to support you. First of all, I'd highlight the importance of policy support and implementation support tailored specifically to the context within which you're working, and support on developing strategies. Support in terms of this transition to a healthcare system that promotes and encourages health. support on issues around clear indicators for monitoring and evaluation. Japan in particular noted that, and I highlight on that there is a new global framework around monitoring and evaluation, which is referred to in the framework, and which we will continue to work to support member states to adapt it to their context. And then finally, there were some requests for WHO to support the timely sharing of experience between member states so that the ideas and the actions that are being taken forward can be shared and therefore encouraged to other member states. I conclude by saying thank you all very much for your supports and your warm support for this agenda. It has been a real pleasure working with you to develop this primary healthcare framework. We can see from this discussion how important it is for the future of this region. And from the Secretariat, we look forward to supporting you and working with you on implementation. Thank you, Chair.
Thank you, Mr. Taylor. If there are no further comments, may I request the rapporteurs to draft an appropriate resolution. That concludes our consideration of this agenda item. Thank you very much. Can we all put our hands together to item number 13? We now move to agenda item 14, reaching the unreached document WVL/RC73/10. May I invite Dr. Jacob, DDG and Wipro OIC to introduce this item. Thank you.
Thank you very much, Chairperson. Distinguished representatives, I'm very pleased to present for your consideration document WPR/RC73/10 on reaching the unreached. Reaching the unreached through health systems and services continues to be a real challenge in the region. Despite considerable progress on many health indicators, large groups of people in every country and area cannot access effective, good quality health services, which negatively affects health outcomes. The COVID-19 pandemic reiterated the importance of health systems that can reach everyone, everywhere. It also challenged us to innovate rapidly through mobilizing across sectors, engaging communities, and developing new approaches to health service delivery. But unfortunately, health systems in many countries and areas remain fragmented, cost inefficient, and hospital-centric. This has kept healthcare out of reach for many groups. We need to take actions to transform health systems to be integrated, comprehensive, people-centered, and built on strong primary health care, as we just discussed, including outreach services. As we do this, we have a real opportunity to put those who are unreached at the center of these efforts so that health systems routinely reach everyone, everywhere. This work will require high-level political commitment, intersectoral collaboration, and community engagement to remove barriers that may prevent health systems from reaching everyone, everywhere. The regional framework aims to guide member states to accelerate progress through health system action on reaching the unreached and, in turn, accelerate progress towards universal health coverage and the vision of the Sustainable Development Goals to leave no one behind. The regional committee is invited to consider for endorsement the draft regional framework for reaching the unreached in the Western Pacific between 2022-2030. The Secretariat would like to show a short video on this agenda item. Thank you, Mr. Chairperson.
In every country, there are groups of people who are unreached by health systems. The pandemic has shown that those disadvantaged groups are more exposed to risks and illness. This, in turn, compromises global, regional, and national health security efforts. We must transform health systems to reach everyone, everywhere, and to support equitable health outcomes. The new regional framework for reaching the unreached in the Western Pacific supports member states in addressing the factors that create disadvantages and leave people unreached by health systems and services. To do this, we must engage stakeholders within and beyond health sectors to achieve equity in health outcomes, strengthen comprehensive, quality primary healthcare services to provide care people need closer to where they live, and build strong data and evidence systems that support and monitor progress to reach unreached groups. Through these actions, we can transform public health systems so that they routinely reach everyone, everywhere, and no one is left behind.
Thank you, Dr. Jacob. We will now hear from representatives who wish to speak on this item. Please indicate your wish to speak by clicking on the button on your microphone if you are in the plenary, or by using the raise hand function on Zoom. Thank you. I call on the representatives of the Philippines, followed by Mongolia. Thank you.
Thank you, Chair. The Philippines fully supports the draft regional framework for reaching the unreached in the Western Pacific. Health inequities had been a persistent concern in the Western Pacific region, and especially challenging in the context of the Philippines, where the country is an archipelago of more than 7,000 islands, where the governance of the health system is highly decentralized, where financing is fragmented, where cultural practices are diverse, affecting risk factors and health-seeking behavior. The enactment of universal health care law in 2019 had emphasized reforms and vision to narrow gaps in health inequities by first addressing social determinants of health through stronger stewardship of the health sector, investing in health literacy of the populace, and mainstreaming health-promoting communities, schools, and workplaces. And second, by focusing our investment on integrated primary care-oriented service delivery. In implementing both of this, the Philippines is cognizant of the need to explicitly articulate the intent to invest in this area of work and follow through with agile, customized efforts on the ground. For example, to combat vaccine hesitancy in geographically isolated and disadvantaged areas, we hired community social mobilizers to complement mass and social media strategies. We sought the assistance of tribal and religious leaders so that we may be able to speak their language of our targeted audience. We also made sure to develop FSL-friendly communication materials. We have also initiated Healthy Schools Initiative among our 270 last-mile public elementary schools in 9 provinces, and we will be scaling this up to 1,500 schools next year in a bid for more targeted approach to addressing mental and adolescent sexual reproductive health among school children. To make services closer to people, we supported the scale-up of telemedicine services in urban areas, the delivery of life-saving medicines through more modern application-based couriers, and the rollout of mobile service providers in rural areas. This is on top of our decades-long healthcare worker deployment program in geographically isolated and disadvantaged areas. We are also, with the help of partners, exploring ways to systematically deploy primary care mobile vans to underserved areas to bring healthcare services closer to people. Related to this, the Philippines is also modifying its facility licensing guidelines to take into account access and capacity issues that merit more flexibility. These are just some of the efforts we need to continuously improve and innovate, which we can do better with the assistance of local people's organization, with the private sector, local leaders, religious and cultural influencers to reach the unreached. We request the Secretariat to host a platform for member states to share their good practices in reaching specific groups, for example, indigenous and other vulnerable population for specific contexts, such as islands or urban slums, among others, which may be curated to serve as a live resource for all. Thank you, Mr. Chair.
Thank you, Philippines. Mongolia, you have the floor, followed by Vietnam.
Thank you, Chair. The government of Mongolia has been committed to making healthcare services more responsive and equitable to the needs of the population, especially of the most vulnerable and hard-to-reach populations, including undocumented migrant populations, as well as those residing in geographically distant communities. The COVID-19 pandemic has highlighted the importance of innovative approaches, including outreach services to ensure continued delivery of routine essential services, including maternal, child, reproductive health, prevention and control of communicable and non-communicable disease, and emergency medical services. As such, from 2020, my government started introducing innovative actions related to the delivery of essential health services and COVID-19 services through intensified online primary healthcare services using modern technologies such as mobile health technology and telemedicine approaches, in addition to continuously organizing capacity building and refresher trainings of PhD workers using virtual platforms. Such innovation can be applicable to routine healthcare services beyond COVID-19. In addition, most importantly, the service package for primary healthcare and its funding from the Social Health Insurance Fund have been doubled to finance services such as daycare, home care, and diagnostic tests. Moreover, a package consisting of medicines and rapid diagnostic self-tests have been provided to all individuals who contracted the COVID-19 disease but did not require hospitalization. We believe that this is a good example of the investment and expansion of the service package. However, challenges remain like other countries in the region, such as inadequate quality of care and capacity of healthcare workers, insufficient motivation, and referral system. The government recognizes the importance of addressing these issues, and therefore we welcome the regional draft framework for reaching the unreached. Thank you.
That was Mongolia. Yeah. Thank you, Mongolia. Vietnam, you have the floor, followed by Australia.
Thank you, Mr. Chair. Firstly, Vietnam would like to thank and appreciate the regional WHO for developing a very concrete regional framework for reaching the unreached in the Western Pacific. Reaching the unreached is a global and regional health policy priority, and the framework is developed to support action to reduce inequity impacting on health and well-being of groups across the region, thereby addressing important issues on the journey to achieving universal health coverage and realization of the Sustainable Development Goal. Vietnam has made significant progress in reducing infant mortality rate, under-5 mortality rate, maternal mortality ratio, and it is on track to achieve MDG and SDG targets. However, disparity in basic health indicators between urban and rural areas, between regions, and between various population groups are still existed. Ethnic minority pupils in remote areas, members of poor households, pupils with low education levels still have a higher risk of child mortality than residents of non-ethnic minority pupils and members of households with better economic conditions and higher education. In addition, the COVID-19 pandemic also revealed a fragmented health system that is unable to continue providing essential health services, especially for NCD patients, which put more people at risk of being unreached. 5 key action domains in health system that reach the unreached are clearly identified in the framework and very useful for Vietnam in knowing how to reach the unreached groups. Political commitment and strong leadership is critical to reduce inequity in healthcare and reach those unreached. During the COVID-19 pandemic, the government of Vietnam has been very committed and implemented different strategies to prevent COVID-19 at the early stage with decisive actions. The government has increased budgets for the health sector as well as other sectors to prevent pandemic. Commitment and determinations of the country's leaders was a prerequisite for successful COVID-19 prevention. The commitment also led to the mobilization and active participation of all stakeholders and the whole society in implementing various measures to prevent COVID-19. This was a critical factor to ensure the success of COVID-19 prevention for Vietnam. In order to increase accessibility of people to healthcare services and reach the unreached, the government of Vietnam has implemented reform to shift healthcare from hospital-based to primary healthcare, disease prevention and health promotion. The grassroots health facility have been upgraded to share the responsibility of managing and treating NCD locally. Changes include investment in district health centers and community health stations, staff rotation in strengthening capacity for district health workers, and adding preventive services to the scope of services covered by health insurance or government budgets. Vietnam strongly support and commit to implement this reaching the unreached framework. We will recommend the health sector to develop specific country plan to support the rollout of this framework. These plans will success for developing related policy as well as supporting the development of local plan according to local context for reaching the unreached. Thank you very much.
Thank you, Vietnam. Australia, you have the floor, followed by China. Thank you.
Thank you, Chair. Australia appreciates the regional office's focus on the Reaching the Unreached strategic priority and acknowledges the importance of this work in making health for all a reality. We acknowledge continued challenges which put unreached populations at higher risk of poor health, and in many cases, these have been further exacerbated by COVID-19. It is apparent that more needs to be done to improve access to timely, affordable, equitable, and culturally safe healthcare for vulnerable populations. And it is important that we work to address inequities both within countries and across the region. We are pleased to see the framework's focus on the social determinants of health, as well as reducing stigma and discrimination in addressing health inequities across populations, particularly vulnerable populations. Australia is committed to addressing existing disparities in healthcare and health outcomes for all Australians. We have dedicated, community-led, culturally safe primary healthcare services and strategies for our First Nations people working towards closing the gap in health outcomes. Australia supports action to strengthen health systems and services to reach all populations and welcomes the framework's focus on building robust, people-centred healthcare systems across the region and recognition of primary healthcare as the cornerstone of universal health coverage. Australia also appreciates the framework's recognition of the importance of using data for decision-making as well as for monitoring and evaluation. We encourage the Secretariat to further consider the need for consistent data standards, the use of a unique health identifier in health systems, and the use of geospatial analysis in order to improve member state access to relevant and reliable information on unreached groups. Finally, Australia remains committed to working with our regional partners to strengthen health systems and make progress towards the Sustainable Development Goals. Thank you.
Thank you, Australia. China, you have the floor, followed by Brunei. Thank you.
我们看说是吧？谢谢主席。
Thank you, Mr. Chair. Promoting UHC and providing services to the unreached are the common goal of all countries. The Chinese delegation appreciates the WHO's efforts in improving the health quality. We support the Western Pacific region in putting forward the regional framework for reaching the unreached in the Western Pacific 2022 to 2030. The Chinese government has been committed to prioritizing people's health. We have constantly improving our reform in the health sector. We've promoted the building of healthy China in a comprehensive way and promoted health for poverty alleviation campaign so as to provide the services to the people and address the unmet needs of the people. The accessibility and the equality of services have been improved. We've built the world's largest healthcare system. 90% of the urban and rural households can reach their health service centers within 15 minutes in their proximity. Second, we've comprehensively improved the rural health services and qualities of care. We've helped to deal with the service gaps in rural areas for the routinely diseases and NCDs of the rural citizens. People can seek medical services in their proximity. Second, during the pandemic period, we've provided faster tracks to the rural citizens. We've provided telemedicines to meet the needs among the maternal children, elder citizens, people with disabilities, and people suffering from mental diseases in both urban and rural areas. Going ahead, China is willing to step up our cooperation with WHO and all member states to implement efforts to reach the unreached. This is one of our priorities. We will continue to accelerate the promotion of the international initiative and jointly promote the health-related 2030 Sustainable Development Goals. Thank you, Mr. Chair.
Thank you, China. Brunei, you have the floor, followed by New Zealand.
Thank you, Honorable Chair, ladies and gentlemen. Brunei Darussalam commend WHO for the commitments and continuous work on the action to realizing the priority of reaching the unreached and in the preparation of the regional framework on reaching the unreached in the Western Pacific. Brunei Darussalam is also committed in providing universal health coverage where accessible and equitable health care are provided for all stated in the Brunei Darussalam's Health Strategic Plan goal of excellence in healthcare service. However, Brunei is also not spared from the challenges in handling the pandemic. Being a small nation with high dependence on outside supply of resources such as human resource, medicines, food, skills, and technology, Brunei had needed to be more creative and appreciates that all these challenges were actually disguised opportunities that provided an impetus to develop faster than otherwise planned. The use of the BruHealth apps during the pandemic for surveillance, health education, and for epidemiological purposes has been fully embraced by the population. However, we recognize that such advancement in the use of technology has created a new group of the unreached population that has highlighted the digital divide for those with low digital literacy, as well as the group with financial inability to access technologies. Hence, centralized national hotline help desk was set up throughout the country with the assistance of the communities and the NGOs. A lesson learned from trying to reach the unreached in the country was also the importance of a whole of nations approach, which was demonstrated during our national vaccination program. In addition to provide the strategically placed vaccination centers, mobile vaccination teams were sent to hard to reach areas and also to the vulnerables and the elderly in the country. This was only possible again with the effort from all the governmental and non-governmental agencies. This was seen in the management of the community and the patients, not just for their health needs, but also for their daily dietary and mental health support needs. Brunei Darussalam is facing urbanization with demographic and societal change, where the extended family concept is on the decline. Hence, inequities for access of care in highly populated areas has to be considered, as well as at the same time giving healthcare in the hard-to-reach areas. One of the action plans in Brunei Darussalam's Ministry of Health Strategic Plan is also in standardizing the catchment areas of the health centers, in line with improving the primary healthcare doctors to population ratio and infrastructure's capacity. New comprehensive health centers and private-public partnerships with health centers are also in the plans. Lastly, Brunei Darussalam would like to reiterate our gratitude to WHO for the effort in providing guidance on the priority area of reaching the unreached. Brunei Darussalam fully supports the regional framework in the Western Pacific region for reaching the unreached. Thank you.
Thank you, Brunei. New Zealand, you have the floor. Thank you.
Tēnā koutou katoa. Aotearoa New Zealand endorses the draft regional framework for reaching the unreached in the Western Pacific region. We are proud to have supported this work and contributed perspectives and priorities to its development. This framework aligns with our aspirations to create an equitable health system that leaves no one behind. We recognise the importance of political commitment, courageous leadership, high-quality data insights, people and whānau or family-centred primary health care, effective community-led engagement, and the need for a whole-of-system approach and an all-of-government commitment to achieve this goal. In Aotearoa New Zealand, Māori and Pacific peoples are more likely to experience disproportionate rates of health risk, higher rates of morbidity and mortality, and shorter life expectancy compared to the general population. As we endorse this important framework and its vision and goals, it is important that we recognise the drivers behind health inequity. We have recently released a position statement and working definitions for racism and anti-racism in the New Zealand health system. The definitions are underpinned by a comprehensive literature review of the evidence. The relationship between the presence of racism, the unequal distribution of the social determinants, and the impacts of racism on health and wellbeing outcomes is well evidenced. We are building a shared language and understanding for how racism manifests in our health system and taking pragmatic steps towards implementing an anti-racist maturity model. Taking action against racism as an underlying cause of health inequity is congruent to upholding our obligations to Māori under the Treaty of Waitangi and giving practical effect to the vision of the new Pai Ora Act, Healthy Futures for All New Zealanders. It is also a priority outlined in our national Māori, Pacific peoples, cancer and mental health and wellbeing plans. As part of our health system reforms, we have amplified our efforts to work with Māori and Pacific primary healthcare providers and the communities they serve, which begins with asking what matters to them, and then developing responses accordingly, effectively flipping the system's historic top-down focus on its head. We know that listening closely to Māori and Pacific peoples and investing in community-led, culturally responsive primary healthcare enables people to thrive in their own communities, moving from passive recipients of care to active players in their own health and wellbeing journeys. By creating new system change models that tackle the root causes of inequity and enable, empower, and equitably recognise and resource Māori and Pacific communities to lead their own solutions, we can more effectively reach the unreached in Aotearoa New Zealand. Ngā mihi, thank you.
Thank you, New Zealand. Ministers, Excellencies, thank you very much for all your contribution today. We will need to suspend the session for today and resume tomorrow morning at 9 a.m. We now need to start our private informal consultation of member states. And I'd like to respectfully ask everyone who does not need to be here for the caucus to leave the room. We need the head of delegation +1 to stay for the caucus. Thank you.